Okay, great. So just to start with, I'd like to call our speakers for this morning to the stage. If you'd like to just take a seat, and then so if Eliud, Patricia, and Mohammed would like to come up and take a seat. And good morning, everybody, and welcome to Nairobi, and welcome to this workshop. Thank you all very much for taking time out of your program. Before I pass over to Eliud to officially open, I'll just go through some housekeeping points for today. In the interest of time, we won't be doing a roundtable introduction at the start, but when countries and programs come up to present, please do present your whole team so that everyone can be aware of who you are and your roles. And partners will introduce themselves as and when they take the microphone to answer any of your questions or feed into anything. But also, please do feel free to, in the meantime, and introduce yourselves to others. This morning or 2 days, mainly about hearing about your plans. So please do send, if you haven't already sent your presentations, either to the Google Drive that Amina shared, or if that's causing you problems, please share it directly with Amina and Melanie so we can have it ready for when you present. We have translation available. We have colleagues here from Francophone regions and from Latin America. So thank you, the Latin American colleagues who had an epic journey to get here. So I'm very glad you're here. So the translation services with the headset. So please, if and when a language that is not your first language is being used, you can put on the headset and tune into the appropriate channel. Sorry. Then other housekeeping. We have post-it notes on the table as well as pens. I think we have many experts here today to answer any questions you have. So in the interest of sort of the flow, if you think of a question, please feel free to write it on the post-it note. And during the breaks, you can post it on our questions board so we can capture it for the Q&A if it hasn't already been addressed, and we will be having time for Q&A at the end of the day. So please, as you think of the questions, let's see if we can capture them and we can make sure that we can have the answers for you. So yes, and the other thing is we do have a Plus Life platform in the room, at the back of the room. So during the coffee breaks, you can go up and have a look at the product if you've not already seen what we are seeing in real life, the product that we are talking about implementing here in 2026. And again, many of our technical partners here have hands-on use of using it. So if there are any questions, there will be plenty of resources for you on how it works and the workflow. So without further ado, I will hand over to Dr. Eliud Wandelo, the head of the TB program at the Global Fund, to welcome you to this meeting. Thank you very much.
Good morning. Good morning and welcome to Nairobi. Karibuni sana. Yeah, so first I would like to thank the countries which have agreed to our invitation to come to this important meeting. I would like also to thank our partners, different partners. I'm sure you will know them. They are in the room, for also attending this important meeting. Many greetings from Geneva, the Global Fund. Also would like to give our condolences to our host, Kenya. As you know, in the last few days, they lost one of their heroes, so the country is sad, and we would like to join them in that sad moment. Why are we here, and why Global Fund? Of course, with our partners, we have decided to organize this meeting. For us at the Global Fund, we think we are at an important point in TB care. We think with arrival of near point of care diagnostic, this will change the way we do diagnosis, treatment, and the whole management of tuberculosis. So we think this is an important moment, and we need to grasp this moment. We need to work with countries very early for countries to be able to work with these products. And there are many products coming in this class, as you will hear in the next 2 days. And we have a leading candidate of this product. So we want to work with countries very early for the countries to be able to scale up this product. We have experience with other products like game-changing innovation, and how as a community we didn't take opportunity to help countries to be able to scale up those products. GeneXpert, for example, we know there are countries which took almost even 5 years to have a policy on GeneXpert, and we don't want to repeat that scenario. That's why we think it's important to be here to learn from countries which have already started using, or projects which have already started to use those products, and also to discuss with you how can we help you so that you should be able to scale up those products. And for us as a Global Fund, we think this is a critical moment to prepare also for the next funding cycle, where we think countries will be able now to include this in their funding requests in the next funding request next cycle. Otherwise, we are here to hear from you what plans you have in terms of adopting this tool, what type of support you'll need from us, Global Fund, but also from our partners who are in this room. And we are ready to work with you. We are ready to support you so that you should be able to scale up this product. So we'll be mostly hearing from you in terms of what you're planning, what is your demand, and how can we meet that demand to help you. So I'll stop here because I think the main agenda is really to listen from countries, and we'll be keen to help you to scale up and make sure this product is available to you at an affordable price for you to be able to scale up. So thank you very much for coming, and looking forward to the discussion and to hear more from you. Thank you so much.
Great, thank you. Just for participants online, we've been made aware that you may not be able to hear, so please select the English channel in the translation part of the Zoom link, and then you should be able to hear. And obviously, if you're tuning in from a Francophone region or a Spanish-speaking country, pick the right channel and you will be able to hear. Sorry, just a bit of admin there. Now I'd like to introduce our next speaker, is Dr. Patricia Hall Edison, the HIV, TB, viral hepatitis testing and diagnostic team lead at WHO. Patricia.
Thank you, Grania. And thanks to all of you for traveling to be here and to take the time. Thanks to Global Fund for hosting and coordinating, bringing us all together, and for the opportunity for us to be able to be in person, to work together and discuss implementation plans that are so essential around these new technologies. From a WHO perspective, ensuring access to quality assured TB testing services is our #1 priority in the testing space and in the diagnostic space. And I think we're all in that together, where it's a global community that's working towards that goal. And while we know and we see the figures and the data that we're not quite there yet, programs are making advances. And then we're also seeing these advances and innovations in technologies, in strategies. And so I think this is a really great opportunity for the countries that are here to be able to build on the advances that they're already making towards achieving universal access to testing by optimizing and planning for how to embrace these new advances while optimizing and addressing your setting specific needs and gaps. And so I'd like to just acknowledge and recognize Eliud's nice comment at the end about us listening. I think today in particular, it will be really great to hear from you which of your gaps in regulatory and policy, in patient systems and epidemiology, do you feel that some of these advances can address, and which ones they might not be able to address where optimization of other services would be beneficial? These implementation plans that are developed will be able to accommodate the near point of care technologies that we're assessing for policy guidance, the Plus Life that's already achieved ERPD, and will be available through this initiative, but also other strategies as well. And I think we've recently seen a new publication from colleagues in Uganda, from our WHO regional office colleague, Jean Iragena, and others, around the timelines that some of these advances have taken in the past. Eliud also touched on this nicely. Between 2 to 9 years for policy uptake and for adoption in some of the countries. And so while we are assessing the policy evidence, we're also embracing some of these new initiatives towards early adoption of technologies. We're doing the parallel pre-qualification assessment of these technologies to try and speed access to some of the solutions as they come to market. And so I just want to highlight the importance of this to be able to use your regulatory policy, again, program data in order to use that evidence and address the gaps that are there. And then just quickly to touch on the policy process from a WHO perspective, we will be holding the guideline development group in November. You will have heard that from us before. The outcomes of the technology assessment, we are now planning to release in a rapid communication. But then perhaps more in touch with the purpose of this workshop today around implementation and uptake and the really practical use of these tools. I just really want to emphasize that we have been working with the evidence generators, some of whom are in the room, and so I'd like to acknowledge and thank them, around putting together an implementation toolkit. We have consistently heard that practical guidance on how to use these, how to monitor for them, training materials on their use, monitoring and evaluation forms. These things are sometimes lacking when new technologies come to market, and they have to be customized or made from scratch. We don't want that to be the case for new technologies that could help us to address the access gaps. And so we will be releasing an implementation manual that has technology-specific tools that come with it alongside the policy guidance this year. And so as you're planning, if there are tools or materials or implementation guidance you feel would be needed, please raise those in your small group discussions, raise those here, because we still have time to influence what those global tools look like so that we can provide what's most useful for you as operational guidance as you are working towards adoption and piloting of the new technology in a first step towards implementation. So with that, again, for the sake of time, I think I'll stop there. Very much looking forward to the workshop, and thanks again to Global Fund.
Thank you very much. And I'll now hand over to my colleague, Mohammed Farag, who's a senior specialist in new product in-country introduction and access, to go over a little bit on the workshop expected outcomes. Mohammed, over to you.
Thank you, Grania, and good morning, everyone. And nice to meet you all. I see some familiar faces, but also some new faces. So glad that you all made it here. And thank you for taking the time to come from your busy schedules and participate in this workshop. I'll leave you with 3 quick notes on the expectation. This workshop is about you. It's about countries. It's not about the Global Fund. So we are here to listen from you, to hear your voice, and to understand your needs. Be clear, be candid, be concise on what you need, on what you expect from us. So that's one of the key expectations that we're looking at here. The second thing is that this is not really a meeting, but it's a workshop, meaning that it's hands-on. You need to participate, you need to be active, and you need to really come out openly and say, well, if you disagree about something or if you have a different opinion about something, please share this with us because it will help us in the design of that early access initiative, which will eventually serve the countries which you represent. And then I think the last thing here is that we are designing this early access initiative across the House between the Grant Management Division, where I represent, working directly with you, with the principal recipients and the implementers in countries, and the TB team and the Supply Operations Department working coherently as one unit in order, and with partners obviously, in order to be able to accelerate the access to this innovation in the countries, right? So speed is of an essence here. And with speed, we have to think about pre-planning things to be successful, right? And one of the key things that we are expecting out of this is to know your country introduction plans, which you have received the templates for. And in the next day, tomorrow, we will be working with you in the breakout rooms on this. Knowing your timelines for the introduction, be ambitious, but also be realistic. And the second thing is your demand, because it's going to be very helpful with our upstream planning, working with the manufacturer and trying to match the available supply capacity with your demand so that you can get the products on time, in full, aligned with your introduction plans. So these are just some remarks that I wanted to leave you with in terms of how we were expecting the interactions and the expectations from the workshop. Thank you very much.
Thank you very much. And I'd like to thank our introductory speakers for very nicely setting the scene. And then I think, as we have been saying all morning, this isn't about us, it's about you. So we're going to start on the what I hope is going to be the most interesting part of the day, is hearing from yourselves on what your plans are. So our introductory colleagues can leave the stage, and I would like to invite, there's been a slight change in the country order, but so to open our country presentations today, we will start with the Nigeria team. So whoever is presenting from Nigeria, if you would like to come to the stage. And as I said, it'd be great if you could introduce your team or highlight who your team are. They could stand up, and if we get one of the roving mics to that table, they can introduce themselves so everybody knows who they are in the room. And yes, without further ado, thank you very much. And please introduce yourself as well.
Good morning, everyone. Yeah, so my name is Tolu Lopeada. From the National Tuberculosis Control Program, the Global Fund Program Management Unit, and I lead the laboratory programs for the country. And with me, I have the PMU team lead, Dr. Hempera Hubojema. I also have some of my other colleagues from the ministry, from the government. I have Chimaroki Obasi, who is the M&E officer. I have Ishaq Abubakar in the laboratory unit of the NTBSCP, and from the Medical Laboratory Services Division for the Federal Ministry of Health, I have Gaius Matthew. All right, so good morning, everyone. Are my slides up? Okay, so we can just gist on. And we first want to appreciate the Global Fund for giving this opportunity and looking at the need in our country to see, even across the TB landscape, that tuberculosis is a major disease that has been affecting the public health cycle, and bringing near point of care, which will help us in achieving our end TB strategy or the target for 2030. It's a welcome innovation. So we want to see how much Nigeria can explore this and also be able to utilize it for accessing or improving the access to TB diagnosis in the country. So we had looked at the presentation templates given to us and also looked at the means of improving what we currently have and see the introduction of this new platform will help us. Yeah, I'll just go straight into the country overview. For people who do not know Nigeria, we understand that Nigeria is one of the 6th high burden countries in the world with TB, and with an estimated cases of about 500,000, 499,000 in the global TB report of 2024, which is giving us the 2023 report. We have 59,000 of them being children, and about 300 of them males, and 200,000 being females. From that, we also have 25,000 being HIV positive patients, and about 9,000 have the multi-drug resistance TB. So the TB incidence that we have in a country is on the principle of 219 out of 100,000 population. So out of this, in 2023, 64,000 deaths were recorded, and 23% of these TB deaths, which reported 23% of TB deaths in Africa. In 2024, 405,000 cases were bacteriologically confirmed and notified. 97% of them, they were known HIV status, which related to 4.9% co-infection, and 3% of them are on ART. For the MDR cases that we identified, about 3,600 had multi-drug resistant TB. So for the diagnostic infrastructure for Nigeria, it was basically due to the distribution that we have, the molecular distribution that we have currently in the country, and the number of instruments that are across this population. So for a population of Nigeria being 236, which is a huge number compared to some other countries, we want to ensure that there is saturation of this molecular diagnostic platforms across the country. So the number of health facilities that we have is about 40,000, and the number of molecular diagnostic platforms available, it's 1,162. Inclusive in this is the expert, which is 513. Out of this expert, we have 9 of them with 16 modules, and the 504 are 4 modular gene experts. The TB lamp, we do not have BD Max, but we have the TB lamp. The TB lamp is 277, and we have 372 units of TrueNAT. The portable digital X-ray machines that we have, it's 400, which goes across the community and the facilities. It's important I mention here that the Gene Expert was introduced in country in 2012, but brought into policy fully in 2013. So it had been in the country for over 10 years. We also have TrueNAT being introduced just recently in 2021, and we have it in the large distribution across the country in 2024. For TB lamp came into policy in 2018, and it had long been in our diagnostic algorithm. Number of microscopy sites that we have. Initially, we were testing with microscopy, but as the platforms kept increasing, we had to migrate completely from microscopy testing for diagnostic only to the molecular diagnosis. So we have 202,398 currently functional molecular labs. It's also good to point here that these labs are only testing for follow-up. Of course, when there are shortages in commodities sometimes, and we could have them still test using the diagnostic, using it as a first-line diagnostic instrument. So in general, we have 3,237 microscopy sites that have the capacity to test TB. For the molecular lab sites, for the line probe assay, we have 10 laboratories that ask the line probe assay that could test in the country. And for out of the initial 513 expert labs, 46 of them have the 10 color capacity, which also complements the services of the LPA. For the central culture and the drug sensitivity testing, we have 11 of our labs. So out of these 11 labs, it's only one of them that doesn't have the LPA. Okay, so what is the current state of our diagnostic infrastructure in the country? We had mentioned earlier that we did 236 million population. We should see that there's a high surge of the need for the molecular diagnostic platforms. So currently what we have in country based on the population per the diagnostic, the ones with the light color that the pinks have the fade, I think here from FCT and Nasarawa State, you will see that compared with the population, the 219 per 100,000 population, it's accurate. But if you look upper parts into our northeast and the northwest zone, we'll see Borno State having high population, but the number of diagnostic platforms available are a bit low. Same thing with Kano. So we have this uneven access to diagnostic distribution based on population. If you want to use the population density, then these states that are showing high dense of the pink color, they are the ones with the gaps. Then if we look at the burden of TB in Nigeria using the 2019 case finding, we'll see that the Kaduna, some of the sites in the upper part, that is in the northeast and the northwest, covers those ones with the ITB case burden. Then we also look at Lagos based on the population. Lagos is down the other side. I hope you can see. Yes, in southwest, we see that Lagos is also one of those sites with ITB, one of those states with ITB burden in the country. Okay. To give us an overview of what our national diagnostic algorithm looks like, we have introduced in the country, we have the first is the TB lamp to test, but we have TB lamp testing, we have GeneSpats, we have TrueNat, and we have in country that is coming on board is the Cobas MTB. But what we have seen in implementation is we have TB lamp at the first where it is available. Currently, we have 50% of our GeneSpat sites saturated with TB lamp. So we ensure that TB lamp instruments are also co-located in high-burden GeneSpat sites to reduce the use of cartridges and also to improve, to be able to test more samples based on the active case finding outcome that we have been having. So we have TB lamp as the first test. We have Expert in places where TB lamp is not available, and we have TrueNat in other places where TB lamp is also not available in the remotest and facilities or states where they have power challenges. Basically, that's where we have them deployed. The TrueNat and the Cobas serves as the rifampicin-resistant testing platforms that we have. So for every site that is a standalone that is testing for TB lamp, we ensure a strengthened sample referral mechanism where samples are moved from those sites to either a GeneSpat site or a TrueNat site to ensure the status of the rifampicin is identified. So what is our overview of the expert use? If you look at the slide on my extreme right, yes, you will look at it that 80% of the TB cases in 2024 were patterned across all of these diagnostic platforms. And raising high here is the GeneSpat. The GeneSpat raises so high, about 68,000 of detection was done using the GeneSpat in 2024. We have next to it is the TB lamp, 22.4 thousand with TB lamp, and the next is AFB. Now it's good I mentioned here that because last year it wasn't a smooth implementation strategy, especially in the area of commodity availability. So the AFB improved or increased in the cases identified through AFB was because of access not available or commodities not available. And that had led to the about 6,000 cases that were identified through AFB. All the 6,000 cases were also tested, transferred to GeneSpat and confirmed to be through positives and also just rifampicin status identified. So for TrueNat's deployment at the time out of the 372, last year we had 39 only until November last year, where we introduced 333 new TrueNat instruments into the country. So the uptake of the 1,800 is as a result of those 39 existing instruments that amounted to the 1,800. And for LF-LAM in the advanced HIV population, we have 1,000 cases identified. Both from AFB and LF-LAM, all these tests are retested using GeneSpat and TB lamp and TrueNat. For the specific targets, according to our national strategic plan for NSP, we currently have our NSP till 2026. So you will see that the number of incident cases for 2025 is 521. 521,000, while the targets for NSP is 372. So as it is, we seem to hope to go beyond the target, yes, for 2025. The same thing with 2026. Our NSP target for case notification has been 401,000. We hope that by 2026, the number of incident TB cases will improve beyond we improve and get us to 535,000. What are those current TB diagnosis challenges that we have in Nigeria? Key out of this is unavailability or unstable power supply. So when we saw the demonstration for the Plus Life, it was something, oh, this is good, it would improve our access, it's also be able to breach this challenge. Power is an issue in some areas of the country, and you see that's one of the reasons why the country even moved away a little from the GNSPA testing to invest in more diagnostic tools that will have power backups in the form of solar power, in the form of additional batteries, to get access to the unreached sites or the riverine sites or sites with insecurity. So power is a major challenge. Then uneven access. We have seen from the previous presentation that showed the population and the availability of the diagnostic tool available. So uneven access to diagnostic is also one of the major challenges. Out of it, which is key, is staff. We understand that personnel is key in driving any innovation in the country. And so staff attrition resulting in the frequent transfer of trained personnel, because most of the people who test, the high number of these instruments are in the government coffers. So we see the staff attrition, people move away from and also go to greener pastures, or trained staff are transferred from the current facilities where they are to another site. So there's a need for continuous capacity building across the personnel availability. Inadequate funding landscape due to disrupted supply chain management and incessant stockout. It's also a major challenge in country. We have currently now that commodities are not available, and we look at the funding available. Is the GF plays a great role in ensuring commodity availability for the country. However, it is known that it is not enough for us, and also if this funding is also not available, it can disrupt the supply chain and facilities call out where we have increased active case finding. We have different models and modality strategies to increase case finding, but what we have in country, so when the community outreaches are being conducted, do we have the laboratories that can serve them? Yes, but do the laboratories have the commodities to test this samples being received? Then that is where we have most of the challenges about testing. So we adopted some of the recommendations from the presentation, what are the key in-country milestones for the TB near point of care. Introduction and planning. For us as a country, the national planning and budgets, its budgeting also entails that we'll develop introduction plans as we have introduced for other platforms. We develop introduction plans. We include phased deployment to primary healthcare centers, because these primary healthcare centers have direct contact with the community. So we believe introducing them to the primary healthcare centers is key, not microscopy side. We have already moved away from microscopy in Nigeria. So we are introducing them to those primary healthcare centers that will improve testing. Then conduct budget analysis, incorporating all the relevant costs. Of course, accelerate product introduction and uptake. If you look, when we get to our introduction plan, you will see what timelines we have included there. The regulatory and importation requirements, we will be ensuring that national regulation clearance is provided, just as we've done for other introduction of new platforms. Then import authorization given and customs clearance as required. The health product procurement and supply chain management, we include quantification of tests. We have also done that in some other slides in my presentation. Then the order placement time, we have to know what the order placement time of this instrument. I know we've been communicated that the procurement has to be on Wambo or the other platform. So we also factor in the lead time placing that order on Wambo. Then include products in supply chain systems, the procurement, the stock replenishment, and the distribution plan to be put in place. The policy and guidelines for implementation includes update the national TB diagnostic algorithm to include the near point of care. In this case, we're talking about the Plus Life instrument. So we hope to update our national diagnostic algorithm. You said that what I presented later does not have the Plus Life. So for us to have it introduced, then that instrument has to be updated on the algorithm. Then cascade the guidance and circulars from the FMOH and the NTBSB to all the implementation levels. The strength of the Nigerian TB program lies basically on the state TB control program. So we utilize the local government, the TB local government supervisors also to implement some of the strategies or new innovations that we're bringing into the program. So we integrate sample transport and the DST referral. Yes, because we identify, I think during one of the webinars, that the Plus Life currently doesn't identify the repurposing status. So one of the things we also strengthen is for placement in sites where they do not have any form of diagnostic, molecular diagnostic instrument at all. And we also have to strengthen sample referral to the TrueNat site or the GeneXpert site to ensure identification of the risk status for those patients. The monitoring and evaluation strategy will include linking the NPOC data to the National Diagnostic Information System. So in country, in Nigeria, we have the NLIS, and I think we should appreciate Global Fund at this point. Can we give a round of applause? GF has greatly helped us in country for laboratory systems to develop an electronic laboratory information management system that cuts across all diseases. It's a robust platform that we have been looking at. It's being piloted currently in about 74 local governments. So we expect that it should be expanded, and it's also give the government view of what is happening for every diagnostic platform in the country. So we will also integrate it into the HMIS or the LMIS and real-time dashboards that we have for all our platforms. We will train health workers on the procedures and data capture that have to appropriately capture our data. And we will also need to include or update our DCT tools. Then we also track the KPIs. Such KPIs that we are looking at here is the error rates. We have seen in the previous platforms that we have, at the beginning like this, we could have increase in valid testing, increase error rates. So we also want to track that and see that the near point of care is giving a value for money. Then the functionality and the successful test, and we are looking strictly at the turnaround time, which is key for us to ensure that the 48 hours that we have as a country from the time of sample collection to the time of results getting back to the clients, it's being observed within that by introducing the new point of care. So our plan for early access deployment, we have 3 scenarios that we developed. The first scenario, based on our country targets, the country target of the 238 million is to have 1 molecular diagnostic platform in about 175,000 population. Currently, we are at a deficit of 200 instruments that we need to achieve this target. So we have a scenario 1, which is giving us that 74 instruments will be deployed to hard-to-reach sites. And these hard-to-reach sites are basically the riverine sites, the sites within security, insurgents, uneven landscape that we have. Those are the sites we priority. And we hope that after this workshop, we will have it started from the 1st of April to 30th of June. So the capacity that we expect that the Plus Life should give us is to test about 1,000 tests per year. That is giving us about 4 tests per day using that first scenario for Plus Life. That is taking us to using the mini doc of 2 mini doc and 1 Thymo LISA. The scenario 2 is 126 instruments to other rural areas with erratic power supply. So first, our target is to the hard-to-reach sites, the sites with the high DPs. And so the second one is to the sites where they have erratic power supply. We understand that the Plus Life has the capacity to charge the battery and the solar panel. So this would greatly help the country. The third one is the 170 high volume dot sites without any molecular diagnostic tool at all. It's also to improve access. The prioritization of our criteria is the deployment will use both the population and the geographic gaps that have been identified to improve access. Our regulatory and importation requirements, we understand we will need the national registration. The Standard Organization of Nigeria provides the SUNCAP certificate for every newly introduced instrument for program purposes. However, if this instrument is going to go beyond program purposes, it's going to go into the mainstream market, further registration will be required that the MLSD, IVD registration. But if it is just for program purposes, just the SONCAP is sufficient for that introduction. Then the customs waiver takes about 4 weeks. We have the NAFDAC registration, which must be applied and also takes about 4 weeks. Let me go to the tax waiver. It's already included in the signed GF's grant, so we don't need a tax waiver exemption again. We have already included into the current grant that speaks that every new diagnostic instrument for the purpose of the program has received this exemption. So custom clearance is about 2 weeks, and the delivery to port of entry is also included in the custom clearance. I'll just rush through this. We have our plan 2026 demand. We order. Let me go straight to the in-country supply chain. We will integrate it in the national stock management and the stock money replenishment tools. Integrating the distribution plan and the warehouse management tools, it's not going to come as an extra cost because it's going to be integrated in the existing system. We will strengthen sample referral, we said, and we'll also develop a budget for introducing this new tool. The policy and the guideline for updates, we would definitely have to update our TB diagnostic algorithm and also the national treatment and testing guideline aside from the diagnostic algorithm. Provide policy circular and share with the national TB program across our levels. The change management is to develop an SOP for this new tool. Demand generation and community engagement. We understand for every acceptance of a new tool, the community plays a huge role. So we ensure that we improve demand generation and community engagement. Training of trainers first for the national program, the national developers, then the next is to the facilities and the states. Then we have provided a budget order for these trainings and meetings that we owed. For our M&E, we, just as we do for other new products, our key indicators will be the number of people tested using Plus Life, specifically the number of positive cases from this instrument. We also look at the negative cases that we move further to do the number of positive cases that were initiated on treatment because we have a strategy of test and treat. So we want to know how many of them were initiated on treatment based on the outcome of the new instrument. Then the number of the types of sample tested, we know right now that from the webinars that the Plus Life can test both the mouth swab and the sputum. So we also, now that we have this level of samples and introducing the mouth swab as a new sample, we will have to know the types of samples that were tested. Then the demographic populations, the number of TB cases with HIV, the number of TB cases with HIV status, and number of positive NPOC that was transferred to either the genus part or the TrueNAT for their DST. The need, basically, we have, go to the third point, is technical assistance support for mapping, distribution, and demand creation. We will also be needing that support. We also, as a country, will need support for in-country capacity building and continuous quality improvements, which it's key to ensure absorbance of or acceptance of this tool. Wow. I have a budget here. I don't know what went wrong. Okay. In this budget, I can just speak from it. So we have 4 main areas that we looked at. The first one is the introduction to the policymakers. That is the first budget. Then the second one speaks to training of trainers. The third part of the budget speaks to the rollout training of the facility. And then we now have the update of the algorithm. So those are the 4 major areas that we looked at in the budget. And it amounted to about $111,000 to have the MPOC rolled out. Apologies for this blank space. So what are our enablers? Currently, we have availability of our policy on the introduction of new diagnostic platform. We have the essential diagnostic list. So we will improve, we just improve and facilitate in rollout of the MPOC. We have engaged and committed leadership to facilitate the successful introduction. Our leadership is very committed to diagnostic tool uptake. And so we also have regulatory pathway and waivers to absorb this new instrument. We have technical capacity and readiness of our service delivery platforms, our PHCs, our labs, our mobile platforms, our community outreaches. And so we have those ones, our enablers. What are the bottlenecks we've identified? There could be delay in the NRA registration. based on the vendor or the manufacturer to align with the in-country policies. The budget constraints, the product may be unsustainable with existing domestic fiscal space and uncertain funding availability. There could be short shelf life, risk of expiry and waste, depending on what was supplied at the point of delivery. Then electric power dependent NPOCs. We will not want an NPOC that is dependent on power if we really want it to be point of care in our country. The delay in providing a minimum of 6 months of consumables, like we had in the TrueNAT deployment, there was a delay. So the instrument arrived, but we had delay in providing the commodities to initiate testing. So it's not just enough for us to have this new tool introduced. Do we have the commodities that's available to start testing immediately the new tool is being introduced? I think that should be all. Yeah. Okay. So this is just a sample of our scenario again. And I say thank you.
Very appreciated. Are there any specific clarification questions, or otherwise we will have a sort of open forum at the end of the day, but if there's anything very specific that you would like to ask. Otherwise, thank you very much, and thank you very much for the work of you and your team. Great, and so now I would like to ask a representative from the Ethiopia team to come up and present your plans, and also please do introduce your team when you come to the stage and yourself.
Good morning. Thank you. I'm here today to present the Ethiopian plan. I'm not alone. I'm with my team from National TB Reference Lab, as well as from the National TB Program. So, Mr. Getachew from the National TB Program Advisor, please introduce stand up once. And Mr. Ephraim is from, please stand up, and is from National TB Reference Lab. Thank you. Just let me introduce some plan from Ethiopian side. Just I'll be run over these titles on this agenda. So let's move directly to that parties. As you see, a country overview. Almost it is the second populated country next to our sisters Nigeria. So the country is still a big geographical area, and the population is around 132 million. So when we see the country, as you observe it from the map, it is around 14 provinces or regions, and more than 1,100 districts. Ethiopia is one of the 30 high TB and TB HIV burden countries globally, and TB incidence is again around 146 per 100,000 according to the 2023 global TB report. So the incident TB cases around 108,000. The treatment coverage is almost near to 73%. So related to the drug resistance TB, almost it is 1.9 per 100,000, and it is around 2,600. But it is a challenge with the notifying of drug resistance TB as a global. So when we come to the health profile of Ethiopia, we have more than 404 hospitals, including the primary, as well as secondary and the tertiary hospitals, and more than near to 4,000 health centers. This is related only for the government or public health facilities. And also there is at village level around 15,000, more than 15,000 of health posts that providing health service for a community. And AFB sites, actually it is including more hospitals as well as health centers have microscopy, which have conducting AFB tests. When we come to the molecular test, recently we have more than 961 gene expert machines, including the 10 color and as well as 6 color machine. And again, there are this 961 gene expert machine is almost settled at 900 sites. And the TB culture and the DCT labs, it is again 11, and which is one is under construction, and the regional reference lab is around 70. So laboratory equipment centers, we have around 235 laboratory equipment centers, and there are other private health facilities that providing TB. So that is around 2,000 recently, and it is increased from time to time. So another one is there are TB treatment initiative centers for drug resistance TB, that is around 75, and treatment follow-up center is around 800 for drug resistance TB. So when we come to the recent WHO recommended molecular diagnostic coverage, actually in Ethiopia, the following diagnostic test is almost recommended according to the national algorithm. The first one is still microscopy is under utilization, and WHO approval rapid TB diagnostics is a part. The third one is culture, and other one is almost targeted next generation sequencing machine is a part of the diagnostic part, and supplementary diagnostic test like TB lamp is also another part. So as you see from the graph, again, as I said, our gene expert machine is reached 961, and TrueNAT is around 99, and almost 65 under placement. Here, so these all are under utilization recently, especially the expert MTB RIF Ultra and the expert MTB XDR assays under utilization. TrueNAT, as I said before, again, it is under utilization. And LFLAM is also under utilization, especially at the ART site. And TB lamp is under pilot. So when we see the almost, this is, I said before, but for summary, again, almost 961 gene expert machine, 99 TrueNAT, and the 4 sequencing machine is recently in a country. And number of TB treatment sites, it is more than 6,000 areas, including the private health facilities. And the microscope is again similar. As well, TB culture lab is 11, and almost we have more than 510 color gene expert machine recently. Here, this is a country map with the TB diagnostic site and treatment. It is look like somewhat crowded, but this is including all private health facilities as well as government health facilities. So it is look like that concentrated in the central part of Ethiopia, but when we move to the border sites, it is dispersed. This is due to even the population living in this area is also dispersed. The current TB diagnostic challenge is that mostly, as you observed before, we have more gene expert machine in country, and the challenges relate to the high module failure rate is one of the challenge. And second one is especially the short shelf life of culture and the AFB reagent is another challenge for the country, because we are ordering, procuring, and shipping, and within 6 months that will be expired. That is a main challenge. The other one is high initial cost, and the price of cartridges, another challenge for the gene expert machine. Other one is electric power interruption, and power backup is another challenge. And also procuring these materials, also there is a budget gap, as you know, especially the recent reduction, including the global fund reduction of fund is another challenge. So when we come to the key in-country milestone for TB near point of care diagnostic, introduction and the planning, as a country, national planning and the budgeting, just evaluation at country level is very important, and this will be conducted through the National Reference Lab, and which is important to include in the national diagnostic algorithm. The second one is including it to the National Strategic Plan in 2026, because we are moving to revising our national strategic plan. So this is a good opportunity to include this part for the national. The third one is, again, when we revise our national strategic plan, our guideline is also revised with this. So aligning with this national strategic plan, and that is second opportunity. And also in 2027, especially July 2027, it is a new grant for the Global Fund, and there might be there is an opportunity to include this part in 2027. So the second one is the regulatory and importation requirements. So as a country rule and regulation, WHO endorsement and item listing in GTF is very important for us, because this make thing is very simple. So that is very important. The second one, there is a need of registration at Ethiopian Food and Drug Authority, and the zero local agent, and MOH and the APHI will support in this part. The other one is import authorization through Ethiopian Food and Drug Authority system, so that authorization will be given for the FDA. The Ministry of Health with Ethiopian Pharmaceutical Service System will order the product, as well as APSS support in providing of shipping document like pre-import permission, and the national regulatory clearance through Ethiopian Food and Drug Authority, and the custom clearance required through APSS is the way. The other one is healthy product procurement and the supply chain management. Quantification of test will conduct through MOH, Ministry of Health, APSS, and also APHI. When we say APSS, hopefully you understand that it is a Ethiopian pharmaceutical system. So that is managing every product in a country, which is under the Ministry of Health, and APHI is the Ethiopian Public Health Institute, which is a wing of the ministry, and also our partners also support in this part. The other one is revision of quantification is conducted every year, because we have quantify every 3 years as a general, but it will conduct revision every year. And then supply plan revision is also conducted every 3 months. So this is also very important for including of this product. And the Ministry of Health will order the procurement and the follow-up is the shipment. And APSS will responsible for clearance, storage, and distribution. The other fourth one is a policy guideline to implementation and training of these materials. So update national TB diagnostic algorithm to include includes the near point of care test in national strategic plan and guideline in 2026, as I said before, because we are moving for revision of our national strategic plan. The other one is preparation of training manual and the provision of TOT and the rollout training in collaboration with our Ethiopian Public Health Institute and the regional lab is very important, and integrate with existing sample transport and DST referral system. So we have a sample referral system, and this is also integrating this part. The other one is monitoring evaluation in the learning part. So this is a very important part actually. So incorporating indicator for near point of care to national DHIS2 system, but it might be take a time because our DHIS2 system is revised every 3 years, and it might be need a time to waiting for this 3-year revision. The other one is almost manual reporting system can be taken as an option also in this part, and turnaround time will be within an hour for the site. It might be take 24 hours and 72 hours for the referral areas. So national planning as early access deployment. So as a country, what we said before is one of the important part. For time being, we put 4 scenarios. The first one is almost we move with a phased-based approach, and at least 100 low load health facilities from 1 March to 30 August 2026 is one of the plan. And in the same time, 50 sites with a medium throughout. Third scenario is 50 lab site with a higher throughput. So this is a 3 scenario, and for other one, we also need that for evaluation of quality assurance and training for at least for 20 facilities, another plan. So prioritization criteria will be hard to reach areas, one of the part, and congregate setting, again, it is one of the priority part, especially for prison, refuge camp, IDP, like is one of the priority part. So almost this is said. Again, regulatory and importation requirement is national registration is needed, as we said. Regulatory waiver or approval is needed, and import authorization is essential. And tax waiver or exemption that will be with the government later, and the custom clearance through Ethiopian Food and Drug Authority, and the delivery to port of entry or site is very important. So most probably it is through the Ethiopian Airlines. The time required that need to be occur for a new platform to be registered, imported, and used in a country. It might be take at least 3 months. It's very fast, and 6 months is a time that will be needed. So here is the health product procurement and supply chain management. As we said before, quantification and the forecasting as a country, every partner and the stakeholder will be included, in the country full demand for 2026 to 2028 will be need at least for 3 years. We should be import at least 1,000 of this near point of care. And so in 2026, at least 200, and in 2027, 400, and in 2028, at least 400 is maybe the plan. So order placement will be as soon as budget is confirmed, and the shipping and the delivery will be take at least 4 to 6 months. And maybe budget holder, we need the product cost integrated in global fund, because most of the procurement is taking through this. And the in-country supply chain will be take place through a PLS system, which is integrated pharmaceutical and the logistics system within the Ethiopian pharmaceutical service. So with this will be almost integrated in this system. And the integration in national stock management and the stock replenishment tool is again take place in EPSS, and we will integrate in this part. And the integration with existing sample referral system is also, as I said before. So here, this is the monitoring part. The indicator is already mentioned, but one thing is that the national technical working group will revise accordingly and approving in this part. So this is a part, and maybe some part may be excluded or additional indicator maybe need to include it. So that's based on the technical working group of in a country. Oh, sorry. So implementation support needed, evaluation of product at national level, and consultative workshop through the lab technical working group and big again the technical working group of the country. Training material preparation is important. Giving TOT is another part, and rollout of the training is important. In a country distribution cost, again in the site selection and the placement is the areas that need. So maybe for this part, Ministry of Health and the EPHI will mobilize some resource from the domestic funds from the country. So what is the enabler? Engaging and committed leadership to facilitate it, successful introduction and the rollout of TB near point of care diagnostic, including the budgetary and the policy support is one of the enabler. And the second one is the technical capacity and the readiness of service delivery platform is 1 point, and the price of the product is even one of the enabler. And availability of battery, especially in remote area, that is again the essential one. Minimum training and the technical skill is also one of enabler. So the bottleneck, short shelf life span, that might be, it is only 12 months or 13 months, that is again a challenge, just like that of AFB reagent as well as culture reagent. The other one is the budget gap and the reduction of donors is maybe bottleneck, and the delay in registration and no drug sensitivity test might be a bottleneck. It is just not like TrueNAT or GeneXpert, that is again. And incorporate to the HS2 system might be take time, and the lack of separate connectivity solution is one of the bottleneck. Thank you so much. Here's my presentation.
Thank you very much. Again, a very comprehensive and succinct presentation. So thank you very much. Any specific clarification questions for Dr. any of you? Yep. If we have a mic, just because we have people online. So, and Wayne, if you'd like to introduce yourself for people in the room.
Hi, everyone. I don't know if you can hear me. Yeah. So I'm Wayne Van Gemert. I'm with the Stop TB Partnership in Geneva. I have a question about the first planning step. You indicated the evaluation at country level with EPHI. Does that encompass a diagnostic accuracy study or something else? If you could just elaborate on the evaluation. Thanks.
Thank you very much. Just for the evaluation, as a country rule and the regulations, the first one is every diagnostic tools which is imported in country should be evaluated by a national public health institute in a country. That is mandatory. The second issue is that every diagnostic tool is evaluated for the feasibility, acceptability, and the challenge according to the country.
Great, thank you very much. Thank you. And everyone, thank the Ethiopian team. And I'll now like to invite our third country for this morning is the South Africa team. If you would like, yeah, if you'd like to come up, Dr. Njeka, and introduce yourself and your team, that'd be great. Thank you.
Good morning, colleagues. Norbert Njeka, NTP Manager, South Africa. I'm having two comrades here. Comrade Dr. Vali Oma, the head of TB Reference Lab. Can you show hand, please, so we could see you? Thank you. And Comrade Yulisa Tibolani, Director, Global Fund. Thank you. All right. Give them a hand, please. Please welcome them. They've done a big effort to be here. So, colleagues, I'll present a short report in terms of what we want to do with this in South Africa. It's a near point of care implementation plan. Shall I use this? How's this? Thank you. Yeah, so I'll start with the country overview. As you can see, we're really high burden. I was looking at the Nigeria report. It's also high burden. But if you look at our report from South Africa, incidence of 427 per 100,000 population, that's quite a big number if you compare to the global average of 134. But I think what is even a bigger problem for us, 230 per 100,000 compared to 8 per 100,000 in terms of the HIV proportion. So our epidemic is really driven by HIV. It's a big feature of that. But you can also see resistance, 49 against a global average of 21 against a global average of 5. I think our epidemic has, let me show. So I'm looking at these figures. We really have a great deal of, a great proportion of HIV, people living with HIV, 55% actually of the cohort, people living with HIV, and resistance, quite a lot of resistance. I think it comes from the old history of those who are not adhering to treatment. You know, when you run a program with a lot of people not adhering to treatment, you end up with a lot of resistance to an extent that if you look at our MDR cohort, your new cases are more than those that are in treatment, right? 55% of people with resistant TB, resistant, have never had any form of tuberculosis before. So you can see when we show this estimate here, the message, what it means, and the other issues that are connected. Now, in terms of laboratory, we have a huge network. We're the first to move from sputum to TB to molecular tests in 2011. And by last year, we had tested 26 million people in South Africa using mainly GeneXpert. And you can see most people live closest to where the laboratory, where they could be tested for TB. So it's really a huge network, which is very helpful. Our strategic plan recommends testing, finding people with TB, because we realized that the gap was too big between those we treat and the estimated number. So the finding TB is critical as well as linkage to care. Our NSP, National Strategic Plan, is about TB, HIV, and STIs. So the advantage is that you cost all this together. And as you know, HIV has a bigger budget. So part of it then will cover TB activities. But we developed a TB plan that has those 5 pillars. And every year we have various priorities. And at this stage, our first priority is really pillar 2, finding TB to end TB. That's our main pillar. Now, if you look at the provinces, there are quite a lot of sites, 3,700 facilities, and including 391 hospitals. We still have microscopy sites. These are important because you follow up patients on treatment using microscopy. So what happens is everybody, all TB presumptives, present a sample which is tested using a TB NAT. We use GeneXpert, we use BDMax and Roche. Roche is a bigger machine, bigger than the GX80. GX80 is fascinating. It processes 80 sample at a go, but the covers will take 96 samples and process them at the same time. So you can load maybe 200 something or 300 samples, but it's a bit labor intensive. I'll come back to that. So this diversification we're talking about. So all our TB patients get DRTB reflex. We get to do we run the XDR cartridge. We also introduce targeted next generation sequencing. We finished the pilot. Now we moved phase 2. We're trying to scale up everywhere in the country, and we thank Global Fund for the funds that are coming. But I think the pilot was done through Unitate, right? Give them a hand, please. Unitate. Thank you. So this is where we are. So the test really big. So when you test more, you find you got to treat. The good thing is that really is pushing us to find, to treat, and is also improving our treatment outcomes. But the cost is high, as you can see. We spend more or less 229 rands per test, which is like $8. Is it 8 or is more? 15? I don't know. You can $1 is 17 rand. So you can see it's expensive. Rejection rates quite high because some of these machines are very complex in terms of the processes, like I explained, your Roche and all that. But the turnaround time is also long because many patients will walk to the clinic. I mean, they give a sample at clinic, but it's processed elsewhere, and then the results must come and all that. So the turnaround time is a challenge. So for us, really, implementing this, we have to identify areas where we should place the instrument. Like I said, we use TB NAT for first, for all TB presumptive. So we need to identify those areas without test. And these are budget. The reason why I put it there is just to indicate that Global Fund is now funding more. I think this is the first time. We used to get more funds from domestic for testing, but this time you can see the Global Fund allocation is even more, but there's still a gap, right? There's a gap because we are too ambitious. We used to target like 3 million people every year. From this year, we said, let's move to 5 million. We didn't know there would be all this chaos. We decided last year we'll move 5 million. And for the first time also, we have a shortfall there, which I think can be covered by NPOC, like we're discussing now. So for us, this is really an opportunity to say we don't have enough money to test 5 million because of the changes. But if we get cheaper alternatives, we're good, right? Because you're still testing for TB, you'll achieve your objective. So this really where we're looking at. Our provinces have money for TB services. We have another source, equitable share. I did not put it here because the tendency has been to divert it to other needs and then get the Global Fund allocation and the conditional grant, which come from national level. So now we've been telling our colleagues to say you have to make use of the TB, allocations that flows from Parliament to provinces. And we're even planning a study to try and understand how is this being spent and all that. So in terms of regulatory, SAPRA is the South African Health Product Regulatory Authority takes up to 12 months really to get clearance. It is the responsibility of those who own products to get it registered. But sometimes we push as a program, we talk to SAPRA, we talk to the suppliers, we talk to say, please, can you do something? We need this. So once it is registered, we can buy. Procurement is really based on the Public Finance Management Act. This is an act of parliament that considers a few things. It stresses about economy, effectiveness, efficiency. Sometimes economy brings confusion, right? But what it means is that you're going to buy cheaper if we're going to get the same results. But some people think it's just about buying cheap. No, it's not about buying cheap. It's about buying cheap if the cheaper alternative gives you same results or similar to your expensive one. But also the other element here is the triple BE, the broad-based Black economic empowerment. Very important because most suppliers are local. So as you give these tenders, these are the triple BEE and the triple E's, those are the framework for the bureaucrats who have to do this work. So in terms of rollout, training is critical and all that, but also to get people buying, because having laboratory services at primary clinics is not really in the DNA of South Africa, right? Most of the time, tests are done at hospital. Samples are collected from clinics to point of processing and results come. So samples are traveling, not patients. Now, when you bring in tests to be done at PSC level, it's something new, and you'll see how we're going to negotiate introduction of NPOC. In fact, we want a point of care, been wanting it for a long time, but this is what we have. So you'll see what we're saying here is that we need to leverage on the existing laboratory network and go into phases. Phase one, and this is not really by chance or by mistake. Phase one, we said we want to get hospitals that do not have testing capacity, right? Because like I indicated, the system is a bit centralized. Samples are traveling, you got a good network of transportation of samples. But if you want to move to bring NPOC, you started the clinics, the hospital nearby doesn't have testing is a problem. So we want to start with the hospitals and then move to community health centers all the way down, right? Because we really want to have in mind the whole thing of supporting acting case finding across high burden populations. So we started developing geomapping for the 12 global fund districts, and this will expand to the whole country. I know it's a bit strange. I saw colleagues who were planning to start in a village very far, but for us it's a bit problematic. I think if we go this route, we really populate nicely to an extent that if you have problems with those community testing sites, your facility in the area, be it a primary care or a hospital, will support such operations. So that's what we have in mind. We have a lot of licensed suppliers. I think at this stage, someone contacted us, they have offices in South Africa, they can supply the equipment and they're registered. So it will be a matter of talking to the bureaucrat to do tenders and all that. If the program is happy, if we finalize a plan and all that. So the regulator is in place, and there are people who can supply. which is a plus, and procurement systems are in place. So that's why we continue to engage with local suppliers. Now, in terms of policies, there's no major adjustments because this is augmenting to what we have. Although I need to point out one probably challenge, because we do TB that will give you resistance to rifampicin or RIF and INH. This time around, we would not get that result. So to a lot of people, it's going to be strange. Why is there no resistance? And you've seen the number, 21 out of 100,000 is a big number of resistance. So it means that we need to then make sure that every positive gets resistance done. The test must be sent, sample might be sent for resistance. But even with that small inconvenience, I think it's going to be, we can save a lot of money. Just imagine, instead of doing an expensive whatever test for everybody like we're doing, if you are able to select those that have TB and take those samples only, thank you, and send them for testing, it's really very economical. So in a nutshell, that's what I wanted to say. The indicators, those red ones, we don't see the need for them, but the rest, I think, as proposed, we'll be able to align with our existing indicators. The need here is technical assistance. I don't have to really say a lot about this. And budgeting, like I indicated, we have domestic component and global fund. We don't budget that we have at this stage. The enablers are really the trials we have. We do have a big research network, a lot of drugs and a lot of tests have been validated using our National Health Laboratory Services. So we get to know about this test beforehand, and we have a huge network of private and NGO sector that uses this test. But planning will be critical. We need to make sure we get enough resources, capacity building, get people to buy in. We have high staff turnover within our laboratory area, but critical is really also system integration and data connectivity integration. This is going to be necessary to have this implemented. So that's all from me. Thank you so much. Thank you for listening.
Thank you very much, Prof. Njeka. Any questions? The South Africa clarification questions? Then can we give them a big hand again, and thank you for another very succinct and detailed presentation. So this now brings us to the coffee break. We are a little over time, so I'm going to decrease it to 25 minutes. So if we can come back here at 11:05, we've got another session where we have 4 countries presenting their plans. And so if the Vietnam, Kenya, Bangladesh, and Philippines, just make sure you have shared your slides, so we'll be able to project them. For those online, we will have a 25-minute coffee break, depending on your time zone. So otherwise, yes, please feel free. We have the platform at the end of the room. If you've thought of any general questions through the morning, post them on the question board. Otherwise, please enjoy your coffee break, and there's a balcony outside, so you can also appreciate some of the nice weather here in Nairobi as well. So see you back at 11:05. Thank you. The mid-morning session. So maybe if we can turn the music down as much as This isn't quite a karaoke session. Thank you very much. And okay, well, I hope everyone's had a restful break. I see some people were having a look at the Plus Life machine. It'll be there for the rest of the day or the rest of the meeting. So without further ado, I will start with our next country. So I'd like to invite a representative from Vietnam to come to the stage and then also to introduce your team. So thank you very much.
Now my turn. Good morning, everyone. So first of all, I would like to introduce the Vietnam team. So with my boss, the Vice Director, the Dr. Nguyễn Kim Cương, Vice Director, National TB Control Vietnam, and also the Dr. Nguyễn Văn Cử is a Deputy Head of the Project Office National TB Control Program, and myself, my name is Hương Đình. I'm from the National TB Reference Lab. So I'm so glad to be here to show our NPOC implementation plan in 2026. Yeah. Yeah. So just now you can see that several countries already show their implementation plan with some huge number of tests planning to performing in upcoming years. But in our case, we are proposing a this number, a small number. So right now. So as in country already is to be available to be here, Vietnam also so excited about the implementation plan of NPOC to improve their access to the TB diagnosis. But with our plan that we would like to take a kind of step by step, slow to get the experience and to accept the feasibility and susceptibility before to be rolling out ski up in the 2027. So first of all, I would like to kind of give a brief introduction about the Vietnam TB burden. So according to WHO TB report in the 2023, Vietnam have their total TB incident about 192,000 TB cases. But the total notified case only about 60%, and with the multi-drug resistant rifampicin in incident about 10,000 case, but the total notified MDR case only is 40%. It means that Vietnam, there are the major gap in the TB and MDR TB detection. About more than half of case not unnotified and diagnosis in Vietnam. And regarding the molecular WHO recommended rapid diagnosis coverage, until now in Vietnam, the microscopy is still a major technique for TB diagnosis. In the 2023, we already performed about more than 400,000 TB expert and TrueNAT tests. And it means that the coverage of the MWRD coverage only about 36%. And in the 2024, we got some improvement with the 45%, with almost 600,000 expert and cartridge and TrueNAT test performed in 2022. But we still have a main gap to can reach the coverage of the molecular WHO rapid diagnosis test coverage to 90%. And now we are on the way to try to find out the way to improve the coverage. And regarding the current state of the diagnostic infrastructure, Vietnam has population about 100 million And the number of health facility in the different level with the primary healthcare center, there are about 3,000, more than 3,000 primary healthcare center, and with the sub-district about more than 700, and provincial is about 60 lab. And with about the number of sites performing with the MWRDs, with the expert and true nurse, right now Vietnam in 2025, there are about 226 expert and true nurse sites in Vietnam. And the number of TB treatment sites available in Vietnam, about more than 800 sites in the sub-district and also provincial level. And about to talk about the number of microscopy, we have about more than 1,000 sites in Vietnam. With a molecular lab to performing the drug resistant diagnosis, there are 4 sites have capacity to perform the LPA. And with the expert XDR test, there are 22 sites. Among 22 sites, they have 4 sites performing the LPA. And for the culture and DST, right now in Vietnam, there are 33 culture labs and 10 the phenotypic DST lab to perform. And we have 1 site with the sequencing in the National TB Reference Lab right now in Vietnam. Regarding the challenge with the TB diagnostics implementation, Vietnam have faced a lot of the challenges, but in here, I only mentioned about major challenge in Vietnam. The first of all is that the MWRD is not available in all primary healthcare center. And right now, the specimen transportation system is not optimal. So that's the main reason why the MWRD's coverage in Vietnam is still low. And the second challenge is the procurement and importation process for the TB diagnostic reagent have been delayed and have not aligned with implementation. We got several reagent storage in the 2024, and that's the reason why also affect to the TB diagnosis, the MWRD coverage. And the next one is a connectivity solution. Right now is not still not in place. That's kind to limiting the monitor of the network performance. Right now, the data management, we still use a manually collected and analyzed, and also the supply chain management is the manual performance. And last but not least, high costs associated with the calibration and maintenance with the Zinc Expert platform. That also kind of the main challenge Vietnam is facing right now with the limited budget, but the high number of the amount need to put in the calibration and test cost with the Zinc Expert platform. So regarding the national Vietnam planning for the NPOC deployment strategy. So in the 2026, we are planning to deploy the NPOC in the National TB Lab and also plot 4 provinces with a time frame in April to the, December 2026. So within each province, the site will selected at 3 different levels of the health system. So in the 3 different levels, I mean with the provincial lab, we have 4 provincial lab, and we select with the microscopy side with the medium throughput, with 4 side plus 4 province, and primary healthcare center with the 4 side plus 4 provinces. So for the 4 provinces selected, will be represented for South, Central, and North region, and also covering the geographic system, including the rural, mountainous, and urban area. We would like to take this chance to accept the feasibility and acceptability of the near point of care testing with the different healthcare facility system healthcare facility level to see that, so that we get the experiences and for planning for the in 2027. So regarding the regulatory and importation requirement for the new tests, there are a lot of steps to get that with the national registration. Right now in Vietnam, there are local distributors available in Vietnam, and they already submitted the donor registration of the plus line and waiting for the approval maybe end of 2025. But with the Global Fund project approval, the reagent and device with the near point of care need to be approved under the Global Fund Project 2026 by the MOH. And this one take about 2 or 3 months to get the approval. And the next one with the import authorization and tax waiver also take time to do that. So average about 2 months. And the next one with custom clearance and delivery to port entry and site also take several months. So it means that in Vietnam, the regulatory and importation, it take a long time to get, average about 5 to 6 months. So we can able to officially to implement the near point of care in Vietnam. So that's the reason why in the 2026, so we need to take about half year to dealing with the regulatory importation. So we only have a half year of 2026 to be able to have time for phasing out and roll out NPOC. So in here, we only put the kind of the MADIS number here with the 50,000 tests with the in the 2026 for procurement with the 37 site and the deliver within the several shipment in 2026. So the decentralized site with the 16 site, the low throughput facility is a 16 site and the higher throughput site with the 5 site. To be able to implementing the NPOC in the 2026 from the Vietnam side, we already make some kind of assumption, some activity related to that one with the reagent and device with the 50,000 tests. We need to have the budget, the required for 200,000 USD, and for other activity related to implementation, facilitation of implementation, we need to procurement with the result visualize device, such as the tablet, also some kind of allocation budget, and also for the NPOC consumable and testing incentive for the site, and some kind of the meeting and in-country consultation for updating guideline for the NPOC diagnosis. And we need to have activity for the SOP instruction, QC, data collection, form development, and also the TOT training and training for site, and also monthly meeting between the NTP and site to review the data quality indicator, and so the troubleshooting, updating manually with the site. And next one, we also would like to conduct kind of the technical support on site to the NPO site test, at least quarterly, for the site to support them during the implementation, early implementation. And we are also planning to conduct the EQA program for this site. Right now, Vietnam, we already have experience to conduct the EQA program with the expert and TrueNAS. So we are quite confident to conduct the EQA program for this NPOC testing. And the next one with the data connectivity solution for the NPOC, and also other activities. So the total amount we would like to allocate for the NPOC implementation in 2026 about 200,000 USD. For the challenge implementation enable and bottleneck for the NPOC in Vietnam. So with the NPOC, you know that all we know that the NPOC test is straightforward. So it requires minimal training and infrastructure requirement. And also in Vietnam, we already have a local distributor, and right now the registration dossier have been submitted. That's quite an advantage for Vietnam for the regulatory requirement. And Global Fund and other partners are willing to support the process of rolling out of the NPOC in country. But when we talk about the challenges for implementation in Vietnam, we got a lot of the challenges. First, as I mentioned in the previous slide, that with the regulatory and importation process in Vietnam is quite lengthy. That's caused a delay for the implementation. It takes about half a year to get the regulatory approval. And also in 2025, the government administrative reform happened in Vietnam. That's happened, and the health system restructure with the consolidation of the provinces and community wards, limiting of the district level. So that's caused some. That means that it takes time for stabilization, because right now with the health facility level, the human resources reallocation, and also the role, function, and responsibility of different health facility is trained. So it takes time to can be stabilized, and that's the reason. That's one of the challenges we are facing now with the implementing of the new diagnostic test in Vietnam. And last but not least, that in Vietnam right now with the supply chain, with the data management, we still currently capture and monitor manually, that leading to inefficient and non-real-time management. Also one of our disadvantages. So that's all from the Vietnam team. Thank you so much for listening.
Thank you very much. Are there any clarification questions? I'm going to take Chair's prerogative. I have one or two clarification questions. The 4 provinces that you are implementing at a provincial microscopy and PHC, are they the same 4 provinces, or is it 12 provinces in total?
So the microscopy or the microscopy primary healthcare center or provincial lab is same provinces.
Okay,
Yes.
great.
So that takes save time for monitoring and training and technical support. Yes.
Thank you. And maybe just a clarification from our side, and great to see the budget on what you need. Part of what we are hoping to negotiate with the manufacturer for this first year, the sort of very time pressured year, is that as part of the $2 copay, they will support countries with the on-site training. So that may be an opportunity. That budget line may not need to be thought about for extra, but we can confirm that. But that is what we are aiming for, is to see if that on-site training can be done with the manufacturer when they provide the product there. But we'll confirm that afterwards.
Yes, but I would like to ask one thing, that for the training on site, not only for the testing procedure, we also provide the training for the data collection and also the algorithm of diagnosis. So it means that even though with the distributor or the company can give the on-site training, but with the NTB, we still need to provide training to the site in terms of the data collection and data management, and also the algorithm diagnosis. Yes.
Perfect, thank you. And I see another question in the room.
Thank you so much. And thank you to the other presenters so far. Maybe just, hi, good to see you. Just one question I saw in the plan, the inclusion of the National TB Reference Laboratory as one of the recipients. And I think that's a great best practice, right? For the national lab, that's essential for the program. I'm wondering whether it would be useful or whether you're planning to see if you could get early access to new technologies as they become available just at the NTRL level first in order to be able to develop your EQA materials, to inform the algorithm and do other steps while you're waiting for the full regulatory process to be approved. Is that something that's possible and just something to maybe flag for other countries as well as part of the preparation process so that things, when we have these new technologies, can move at the same time?
Yeah. Thank you so much for the question. So we already included the NTIL in our planning for implementation, but actually right now the NTIL already have a collaboration with some partner to performing the evaluation of the NPOC, and right now with the local distributor, also we perform kind of the lab verifications in our lab. So we are quite confident that we have early access to the NPOC region to can get a skill and also to perform to prepare for the EQA program in advance. Yes.
Great, thank you very much. Oh, one more question over here. We've got a microphone coming for those so that.
Thank you, Vietnam. That was an awesome presentation. I think my question is also similar to the one led to NTR, but more about the statement you said you want to test the NPOC at different facility levels. Would then that, after testing at all the different facility levels, after 2026 is when you decide which is the best place to place, or it will inform now the scale up at all those different facility levels?
So thank you so much for the question. So as I mentioned in my presentation that right now we have not have a clear implementation plan for the 2027. So we hope that with the early implementation in the 2026, we got some experience. So how we can rolling out the NPOC in different level, and what the disadvantage, what the advantage of the different level. So I should say that. So right now we do not have a strategy. Only now we would like to try different level to see that what the susceptibility, feasibility when performing the NPOC different level. Yes.
Thank you. Oh, you've simulated another question. So
Thank you very much for the presentation. I saw that you are projecting to test 50,000 samples with requesting for 100 mini docs. Then I don't know over what period of time. Then I was also thinking, because I have 15, we're working with 15 right now, and in 3 months, we're almost doing 3,000 tests. So I wanted to find out what period you want to do this 50,000 with 100 mini docs.
So with the 50,000 and with the 100 mini doc device, you mean that? So we calculated based on the bundle option approach, and we try different. We also try different bundle approach. We order 16 bundle 1, 16 bundle 2, and 5 bundle 3. So we are planning to rolling out 3 kind of bundle at the same time in the 3 different levels. So the time frame that we are supposed to do in the April to the December to performing to rolling out in the 3 different levels and with the 30,000 tests. But as I mentioned, that's the very regulatory and importation requirement in Vietnam. It takes lengthy, so we are not sure what time the device and reagent can be available in Vietnam for distribution. So that's right now we hope that we have at least half year to be able to rolling out 37 sites with the 50,000 tests performing in 2026. Yes.
Great. And I think this is what tomorrow's breakout groups is really allowing the countries to get very granular on exact timelines, matching up the regulatory timelines and really trying to think innovatively of what can happen in parallel, what exemptions could potentially be sought in 2026 just for this early implementation work, while more standard national processes for the scale up in 2027 and beyond. So I think that's sort of one of the things that tomorrow you'll have an opportunity, and with sort of the experts in the room, is to think about what your timelines are versus your global fund allocation, and if you think you can absorb that in the time frame, because we absolutely don't want products going to waste. So it is trying to think of, right, and if they're, or if you think you can do more, we want to know that too, because we may be able to offer more tests once we get to the end of this process. So that's kind of just to be thinking about. Thank you. That's been incredibly helpful. So our next country that will be presenting is the Kenyan team, our hosts. So if the Kenyan team would like to come up and then introduce your team as well, that would be great. Thank you.
Good morning, everybody. Just have to make sure we're together. Good morning. Much better. So I'll start by introducing my colleagues. In the house, I have Jeremiah. Jeremiah Okari is our NTP lab manager. And then we also have Dr. Mashari. Unfortunately, today being a public holiday, he had prior engagements that he could not disengage from, but he'll be joining us tomorrow. And they are part of the amazing team that I am blessed to be working with, and they are the reason why Kenya has made all the progress that we have made. My name is Dr. Kathure Immaculate, the NTP manager. Okay. All right. So I'll begin by giving us a brief outline of Kenya. When it comes to the TB burden, we are a country that's considered one of the 30 high burden countries for TB and TB HIV, with an estimated incidence of about 223 per 100,000 population, and a treatment coverage of about 77%, which we're ambitiously trying to scale up over the coming years. We have up to 27% of our patients facing catastrophic costs. Please keep this number in mind. It's going to be very important when we're looking at some of the challenges that screening is posing for us. We have a TB HIV co-infection of 24%. We happen to be one of those countries where, whereas HIV is a major risk factor, it may not be the only or the main driver for the TB epidemic. We have a 20% case fatality ratio, and we are able to identify and initiate on TPT up to 38% of our household contacts. Now, of note, if you look at our risk factors, most of these are risk factors that are attributable to persons within our communities that actually need to be reached out, which means that our ability to screen and identify the remaining cases of TB calls for us to go beyond passive screening within the facility to a community-based screening where we are able to identify them. So the online team seems not to be having audio. We may need a bit of help with that. All right. So when we look at the current state of our diagnostic infrastructure, and something I didn't mention in the previous slide, is we're looking at a population of 56 million people and growing. And out of these, we have about 14,000, just over 14,000 health facilities in country, of which 5,600 are TB treatment facilities. When we look at our diagnostic landscape, we have up to 227 expert equipment and 77 TrueNut machines. We also have 30 LAMP machines, and these are distributed across the country, as you can see, the diagnostic network. But of note, looking at the northern area of the country, we seem to have a very sparse distribution of diagnostic platforms, but also to note that that's an area where the population is also very sparsely concentrated. And also the area is very vast. So it's hard to reach it's sparsely populated, but also associated with certain challenges when it comes to access to diagnostics. Now we have up to 2,800 molecular microscopy sites. And then when it comes to the molecular labs, we have 5 labs that have capacity to undertake LPA. We have already deployed 18, or in the process of deploying 18 10-color expert machines, and we have 128 equipment already eligible for the module swap. Now we have 2 culture labs, and so far we have been able to deploy, sorry about that. Looks like the chat is very active. We have up to 269 digital X-ray machines with AI, but please note, not all of them are ultra portable. So Kenya has 2 models of deployment. We have the ultra portable equipment, where through Global Fund support, we've been able to deploy so far 80 machines. We've also received some support from PEPFAR that gives us about another 30 equipment. But then we also have a retrofit model where we have pre-existing digital X-ray machines, where again, through Global Fund support, we're able to retrofit them with artificial intelligence to be able to enhance our ability to detect TB. Now, when we look at the progress that Kenya has made, it's one of those countries that it's well on its way to achieve our NTB targets. We've seen a 41% reduction in incidence and a 66% reduction in mortality compared to a baseline of 2015. Now, of note is that despite the tremendous progress we've seen, some of the recent shocks that we have seen, especially in funding, threaten the very progress that we have made so far. Now, one of the other things that I would want you to note is that, yes, consistently we've had a consistent decline in incidence. However, and this is where I'm adding a but, is that a recent repeat of the prevalence survey, or prevalence survey, which was the basis for all the data that we've been using, was done way back in 2015, 2016. Now, a repeat mini prevalence survey in Nairobi showed that the number of the incidence and the prevalence of TB has actually doubled. And that is only one county. So we could also be dealing with a model that is being fed assumptions that may need to be reviewed over time. Now, of note, looking at our 2024 data, we had over 96,000 cases and 700 DRTB cases. Pediatric cases comprised up to 13%. We have a good private sector contribution, again of note, even as we're looking at deployment of the NPOCs, with private sector contributing up to 23% of our cases, and our TB HIV collaboration is very good, with up to 98% of our patients being on ART. Now, when we look at contact screening, and now we're getting closer to the essence of the NPOCs, we have up to 50,000 bacteriologically confirmed cases, of which we expected up to 150,000 contacts. But then we were only able to line list 40%, of which we had a symptom screen for 38%. We managed to initiate as many of them on TPT as possible. But what that means is that our ability to screen beyond just a symptom screen is critical. But secondly, we need to focus on why are we missing these eligible or potential contacts that are still low-lying fruits for us when it comes to TB screening. Now, when we look at the WHO recommendation on population to be screened, we have strong recommendations for various categories. Again, we have the household contacts, the PLHIV, the minors, prisoners, and IDPs. But the question that Kenya is asking is, these may not be the only populations of interest for us, given the risk factors that we saw. For example, patients who are coming down with NCDs, malnutrition, they seem to be high risk factors and populations that might be of interest to us. But then the question that begs today, and even as we're looking at the NPOC, is what tools are we going to use for systematic screening? A lot of the time we've used our symptom screen. Now, going back to the prevalence survey, using the symptom screen alone, we were missing up to 50% of the potential cases of TB, the presumptive cases. And then what algorithms will we use? And it's very easy to say we are deploying an NPOC. But remember, I have a symptom screen, I have a gene expert, I have a LAMP, I have a CRP, I have NPOC, I have LF-LAM. So I have an X-ray with AI. So who starts and who ends? Where do I? The diagnostic algorithm is one big factor that will need to be considered even as we are deploying the NPOCs. Then the implementation models, we have centralized versus decentralized. We have lower level facilities, community level versus the central testing facilities. And then when it comes to screening, for us, We have experienced challenges with the specimen transport networks. This is something that has been a pain point for us, and one that we are really grateful to the Global Fund, because for the first time we are able to have an integrated sample referral system that will actually help to address that problem in a sustainable way, but also that integrates not just TB, but all the other diagnostic tests within the country. The other challenge we have is that we have had delayed and missed diagnosis. So we find that we have some facilities that are still using smear microscopy. It has low sensitivity for certain populations of interest. We also have those atypical presentations, especially extrapulmonary. We have challenges around pediatric TB diagnosis, but we also have delayed diagnosis. Apart from stigma, the distances, the costs, and all the other factors that are making patients not show up. Then the other challenge related to that is the fact that a lot of delays happen when patients, especially in the urban areas, seek services first within the private sector. And so one of the things that Kenya will be thinking through strongly is how does the NPOC then help to improve access to diagnostics even within the private sector. The other challenge in diagnostics is the pediatric TB diagnostic, where there is a heavy reliance of clinical diagnosis. And let's remember that every time we're making a TB diagnosis, the question that begs is, are we treating drug-sensitive or drug-resistant TB? So when we look at the early access deployment strategy, we'll start with being able to identify the first area there. We'll be able to identify our area of support activities and the budgets that go with them. We will be undertaking our performance data verification, and then we'll be able to look at our policies and guidelines to revise them to be able to adopt our diagnostic algorithms. As I mentioned, we have all these tests and we need to guide the healthcare workers to be able to make a very decisive decision. At what point do I pick an NPOC versus an X-ray versus all the other tests that are available? Then once that planning process is done, our engagement is multi-stakeholder. Usually when we're looking at our diagnostic and care cascade, we have various stakeholders. And the stakeholders are brought together not just for resource mobilization, but because within them there are various capacities and key expertise that will help to contribute to moving this conversation along. We have a diagnostic committee of excellence, and we also will be undertaking routine forecasting and quantification to make sure that then we get our numbers correct. We already have a preliminary indication of what we need, but we will be looking back at our pipeline to be able to align with that. For the facility identification, we'll be looking at our spatial analysis. We're looking at our data to be able to identify, and I'll be showing us the criteria that we'll be considering to say which facility then would be of higher impact if we were to deploy the NPOC. Then we will also, now after that, once we are clear, we'll implement. It's usually a collaborative approach, but then a very continuous process, because as we implement, for us, implementation science becomes very pivotal, because one thing that ourselves, what's the impact of the new technologies that we are deploying? So one of the things that we'll be looking at closely is part of our monitoring and evaluation will include a lot of implementation science questions that will then inform our scale-up plan based on the lessons that shall be learned from there. Just as I mentioned, I did state that through Global Fund support, we have managed to come a long way in our integrated sample referral system. We look at the samples referred across the board, not just limited to TB. You can see those there. The mode of transportation is also very diverse. We actually have in some of the counties where they're already starting to use drones, but then I think that has faced a few setbacks because of the security concerns in some of those areas, but then conversations are ongoing to be able to revamp that. Now, when you look at our facilities, the assessment that was done as part of the ISRS establishment showed that facilities have M&E tools to varied extents, and there was a duplicity and diversity of tools. Again, one of the things that we will want to ensure is that as we are introducing a new test, usually it comes with a new monitoring and evaluation tool. And the question that, of course, we had to ask ourselves is how do we take care of the healthcare workers instead of burdening them with additional M&E tools? During ISRS, we also looked at our power sources. Most of our facilities have some form of power, but we also still have up to 3% of our facilities that do not have any form of power source. And then the question that begs is, for those facilities, how do we support them? And this is where leveraging on the existing integrated sample referral system becomes very critical, but making sure that the networks are bringing the services as close to those facilities as possible. We have adequate staff that are adequately trained, so at least that is not going to be a challenge for us. Now, when we look at the strategy and what criteria we used, we looked at the demand for tests based on the notification data. We went back several years, and then we came up with various scenarios for deployment. So one of the things that we looked at is the distances from the existing molecular tests as a baseline, and for that we identified a total of 150 facilities that would be considered priority because of the long distances from our primary molecular test site. Then we looked at the number of cases. We looked at our data between 2023 and 24 and asked ourselves, what proportion of our cases actually missed the laboratory diagnosis? They did not have any form of confirmatory testing. And based on that, we mapped the facilities that were at highest risk, that also compared that to the distances, and then picked another 100 facilities. Then at the levels, we looked at various levels, all the way from dispensary to referral facilities, with prioritization being given to lower level facilities, and also engaging the faith-based and the private sector. We used that to identify another 50. Just to mention that this is very preliminary. A lot of conversations will be going on around that, because we're also looking at other factors like waste management, but also access to services and the interrelationship with the ISRS. Now, for implementation and training, we will have 5 outputs. One is starting at the national level, cascading to the county levels, where we'll have our training of trainers. Then we'll also have super users. One of the things that we have learned as we have deployed molecular testing is that it does not befit to just train the people that are coordinating the services, but we need to ensure continuous quality improvement. And that is why for us, the super user model has been very effective to be able to offer continuous mentorship and ensure that the facilities are able to troubleshoot, but are also able to continuously improve the quality of their diagnostics. Then we'll also then move on to train the end users, and then thereafter continue with refresher trainings. Of note is that as a country, we are moving towards digitizing as many of our training curricula as possible, so that whereas the initial cost may be significant, subsequently maintenance of the trainings and the refreshers is going to be much cheaper. Now, as I mentioned, every diagnostic platform comes with its own monitoring and evaluation system. I don't know about other countries, but Kenya, it's a pain point because you have Expert, it has a system. TrueNat has a system. Microscopy, of course, they don't have a system. So you either have an Excel sheet or an in-country method. LAMP, you have another system on the side. X-rays have their own. And now I believe even Plus Life is going to come with another one. So one of the things that we've done is we've realized that when we have so many diverse systems, then it becomes a bit of a challenge to be able to consistently at a national level have a snapshot of what is happening and then look at the diagnostic system as a whole. So Kenya developed what we call the TB system, which is an online data reporting system that brings together all the diagnostic platforms up to and including digital X-rays, and now seeking to expand that to the treatment data so that then we are able to have visibility on all our reporting systems to one. Then using that, sorry about that, we are able to look at instrument utilization. If you can see at the bottom here, we're able to look at the utilization of the instruments, the error rates, the invalid issues, and then also be able to look at how to relay those results to clinicians in a timely manner. This data, when it comes together like that, is able to inform decision-making, scale-up and prioritization, and also inform our commodity status. Some of the proposed indicators that we were proposing are listed there. I'll not go into each and every one of them due to time. Now, when it comes to regulatory and importation requirements, we have a very clear regulatory process. So we have the national registration, we have the waivers. They usually take between 2 to 4 weeks, an import authorization. Now we normally get tax exemption, especially for donor supported and global fund supported processes. Custom clearance is usually not a pain point, and once the commodities arrive, then they're able to be distributed immediately to the facilities. Of note, and the reason that area is in red, is that whereas it seems to take 3 to 4 months, some of those processes can actually occur together. So as soon as the in-country agent, who I think Kenya already has somebody that is registered as an in-country agent, then once we get the go-ahead and then we are able to do a verification of the samples, we do our pilot, we analyze our data and roll out, that process can actually run all at the same time. So by the time then we are ready for the national rollout, we actually have information that can inform how that rollout is going to be done. Now, when it comes to supply chain, again, we have our full demand done for 2026-28. We'll be reviewing that to incorporate the NPOC needs. Then we are looking not just at our diagnostic commodity stocks, because we already had commodities for the other diagnostic platforms. And then looking at the how we mitigate expiries of these ones. And then also integrating not just into the other commodity management system, but the sample referral system. What do we need? So we will need support to develop the implementation plan and the supportive documents up to and including transition plans. We are facing funding cuts left, right, and center, and therefore, even as we're deploying, one of the lessons we've learned is we need to start having transition discussions right from the beginning. We'll be looking at support for our lab diagnostic capacity strengthening, and then looking at support for implementation science protocols to be able to inform future scale-up. This is our proposed budget. I'll not go into the details. We have tried to break down the various components. As I wind up, our enablers, at least we have an NSP that helps to be able to recognizes and appreciates the scale-up of newer diagnostics. We have a clear approval process, and we have an existing lab infrastructure. What are some of the challenges? Of course, the budget. Then we look at the shelf life of the commodities, demand creation, and then future scale up. Because what we are saying is, yes, we are screening, we are identifying TB, but how do we plan to scale these up in case tomorrow Plus Life comes and says, now they're able to do DST? The question that we would want to ask is, will they ask us to buy new platforms, or will they be willing to do the exchange that we're seeing with the experts, so that then we trade in our old machines for the newer ones, maybe probably at a smaller fee? Thank you.
Thank you very much, Dr. Kathore. Are there any questions of the Kenyan team? Yes, we've got one question over here.
Thank you, Immaculate. I think that's very well thought through. I see the proposed placement criteria, 3 criteria. I'm very curious about the second one. Then you'll propose to use the number of cases missed lab confirmation. Could you please elaborate to identify sites? And I think you identified 100 sites from that. Thanks.
Thank you, Dr. Yes, indeed, what we looked at is looking at our 2023-24 data. We actually reviewed when it comes to the number of pulmonary TB cases who are diagnosed, what proportion of them actually had a confirmatory test done. And then based on the proportion that were missed, then we asked ourselves, are these sites expert sites? If not, then the next level we went ahead and asked is, do they have access to a diagnostic platform? And then are they lower level facilities? Then we used that as a criteria to prioritize another 100 facilities.
Oh, one more question.
Thank you very much, Dr. Immaculate. you recognize the challenges with the hard-to-reach remote areas, which are well marked in your country, in Kenya. And then in the placement of the near point of care test, it's a bit higher. I see that as a missed opportunity. Why are you not considering those rural hard-to-reach communities for placement of this particular tool?
So going back to our slides, there were 3 possible criteria. And those hard to reach areas, one of the things that was being considered for them is distance from the nearest diagnostic test, but also how it is placed in the integrated sample referral system. So you'll find some of those hard to reach areas, whereas there is an ISRS, the integrated sample referral system, the frequency within which samples are collected may not be as often because of the terrain. And sometimes there are no vehicles, or even if there are motorbikes, it's hundreds of kilometers, so it's practically impossible. So for some of those sites now, when we looked at the distance from the molecular tests, some of the facilities that were prioritized under that category were actually those from hard to reach areas. Yeah.
Great, thank you very much. Another question in the back there?
What is the last one? Don't worry.
Thanks, Dr. Kature. That's really exciting. And just to follow up on the point you've just mentioned. So I'm wondering, how do you then balance that need for improving access, but you're also seeing the terrain is difficult. And you've mentioned that some of the sites, the number of times that a pickup is actually scheduled is lower than other sites. So how do you balance that with the need that this new tool require that reflex for DST? Over.
So, and that is why, yes, the main or the most important thing is to make sure you capture the patient and start treatment. But then most of the time, if the test you're relying on is the DST, it means you have to wait for the sample to be collected. It goes to the molecular testing site and the results come back. Now with the NPOC, it means the clinician can make a quick decision that I will, on the best case scenario, assume this patient is sensitive. But that does not mean a specimen will not be collected. It will still be submitted for DST if that patient is positive, but at least the decision to start treatment does not need to be delayed much further as we are waiting for the DST results. And then in case the results are any different, then the treatment can be adjusted accordingly.
Great, and we have one question online. Dr. Iragenda, I hope you can unmute and ask your question.
Yes, do you hear me?
We'll see if this is...
Do you hear me?
Yes, I think we can hear you.
Thank you very much. My name is Jean de Dieu Iragena. I am from WHO Afro, and happy to join remotely. I have a quick question, which is not only for Kenya, but also for the other countries. So we know that the rollout and scale up of diagnostics in general, and in particular POC, is challenging in our member states. And it really requires many factors that can be impediment or that can help the technology to be mobilized. Across all the presentations, I have not seen really the role of the national reference laboratories or the supranational reference laboratories in this scaling up of the technologies. Maybe Margaret, you can elaborate a bit on the role of the national reference lab in Kenya, and also the other countries, I think, can do the same, because this rollout and scale up really will depend on how they are much involved in this exercise. Over to you. Thanks.
All right. So I'll assume with permission, I can speak for Kenya, and hopefully maybe other countries can add if there are different opinions. But for us, the reference lab, though not explicitly mentioned, will play a very pivotal role in quality assurance, in making sure that, and that was under the mentorship and support program. So even as we're identifying the sites, of course, mapping the sites and make sure that the samples can still reach the reference lab. That's in the interplay with the ISRS. But for us, the reference lab has been very pivotal in ensuring quality assurance for all the diagnostic platforms that are being rolled out, especially in the regional centers of excellence. And then now supporting those regional centers of excellence to be able to cascade the same quality assurance to lower level facilities. So that's how we envision their role. I don't know if other countries may have a different way of looking at it.
Thank you. And maybe we can build on this in the Q&A session this afternoon, because I think that is a very important point. So without further ado, I'll invite our next country, the Bangladesh team. If you'd like to come to the stage, and then also to introduce your team who are here. Are you ready to present? Yes, please.
Good noon and regards to all. I'm from Bangladesh. I'm Dr. Ifat Araifa from a National Tuberculosis Reference Laboratory. I'm working as a microbiologist, and in my team there is Dr. Fazli Rabbi, medical officer from Planning Ministry, and Associate Director of one of our principal recipient, BRAC. She will join soon. Okay. At first, the scenario of Bangladesh. The tuberculosis burden summary, it is the notification rate is 221 according to 2023 TB report, but now the national CNR is 192. And the incidence of MDR TB is 2.9. And the current WHO recommended molecular diagnostic coverage is by the end of second quarter of 2025. NTP has significantly expanded its molecular diagnostic capacity with 840 gene expert sites and 150 TrueNet machines. And after that, with a reflex test of positive cases, currently 146 expert laboratories are providing MTB XDR testing. That is a molecular diagnostic capacity built by NTP. This is the national strategic plan of up to 2030. Bangladesh has coverage of molecular diagnosis, currently 88%, and by the end of 2026, it would be 90%, hopefully. And 2030, we are planning for 95%. This is the overview of implementation of arrangement, highlighting the funding, data, and reporting flows. It is the working flow of our national TB control program and the principal recipients and some sub-recipients. Our principal recipients are BRAC and some sub-recipients are ICDRB and ACTB projects. This is our national algorithm. It is divided into two sections, an expert sites, a molecular sites, and the microscopy sites. Where it is available, the expert sites, when it becomes positive, then the all it is reflex testing, and it is all the positive cases are going to testing for XDR, MTB XDR. This is the overview of our diagnostic infrastructure. Total population is 175 million, and total health facilities are 38,892, And the GeneXpert sites are 840 and TrueNet sites are 150. The microscopy sites are 1,103. And currently our MTB expert sites are 146 and culture sites are 8. The major challenges with TB diagnosis, it is almost main challenge is budget constraints, limited testing coverages, because some rural areas are not under coverage of the molecular testing like GeneXpert or TrueNet. Challenges in sample referral and sample transportation system, and some infrastructure problems and some continuous equipment services we need, that UPS and AC. So key in-country milestone for TB NPOC diagnostic introduction and planning. Country has to plan and budget for this NPOC diagnostic introduction, and some regulatory and importation requirements are also there. Procurement and supply management also have some procedures. And policy and guidelines for implementation and training, it is already some work are done here. And monitoring, evaluation and learning system, we have a strong monitoring and evaluation system, and the training system are also there. National planning for early access deployment strategy. At first, we are planning to 50 sites that hard to reach area from April to August 2006, and then 100 sites for rural that have unstable power supply sites from July to August 2026, and then the sites that has no molecular testing capacity. Then prioritization should be according to service populations and geographic gaps where MWRD sites are not there, and after all the existing MWRD population coverage. Health product procurement and supply chain management. It is always it is quantification done by NTP and DGHF and MOH and partners every 3 years, and that it is revised in the middle of the grant cycle, and supply plan revision conducted based on quarterly consumptions, because we have to evaluate the quarterly consumption of the cartridges and others consumables. NTP will order the procurement and follow up the shipments, and government is responsible for the custom clearance, storage and the distribution. Policy and guidelines to implementation and training. Policy and guidelines update. NTP has the priority to do the testing at nearest facilities for timely diagnosis. National treatment and testing guidelines and testing algorithm updated to include TB NPOC diagnosis. And the algorithm has been aligned for NPOC testing and the sample transportation and DST referral pathways. Policy circular drafted and shared by NTP to implementation levels. NTP issues official circulars and operational guidance to all levels. Training at national, regional and facility level. Both NTP and BRAC, the principal recipient, conduct for healthcare providers at all levels. Demand generation and community engagement activities. Community engagement is vital to achieve NTB targets. Development of IC materials. Development of IC materials is crucial for advocacy and community awareness. but the budget constraints is also there. The budget placeholders, limited budget allocation from the Global Fund. Monitoring approach, Bangladesh has established routine monitoring evaluation system through ETB Manager. And the key indicators are turnaround time, sample to test, number of tests and positivity rate, device functionality and error rates, and timely reporting monthly and quarterly. Monthly data reviews are also there. Supervisory visits with monitoring checklist, monthly review meeting and at district level, quarterly review meeting, support data-driven decision making and continuous improvement. Feedback loops for ensuring data quality and prompt corrective actions are also taken. This is the data for monitoring in evaluation system. And budgeting, actually it is not absolute. It is from the Global Fund that Bangladesh has testing capacity of indicating volume 300 to 1,000 and indicative co-pay, double co-pay, it is the volume. Implementation enables and bottlenecks. Enablers, government is committed to MWR establishment and public-private partnership throughout the country. It is also there for implementation. Monitoring and evaluation system is in place, and government infrastructure below the district levels are also very strong for implementation, and skilled technical human resources are there. Microbiologists and MT labs are there. And the bottlenecks, sometimes delay in registration decision, budget constraints, and short shelf life, and maintenance of GeneXpert and TrueNet machines, warranty and other things. Thank you.
Very much. Thank you very much to the Bangladesh team. Now, are there any questions, clarifications? Great. Okay, we'll have. And please, those online, if you do have any questions, raise your hands and we will come to you as well. Please go ahead.
Thank you, Bangladesh team. Just have one information, maybe. I think she has presented the strategic plan since 2023 to 2030. Are you included the point of care tests, or are you going to update it, maybe?
Yes, based on the budget, we are going to update. And
just to add with her, actually, yeah, we are going to, this is our planning based on the national strategic plan. It has been done earlier, but each year, usually we are planning with the Ministry of Health also to change the modalities, because by this time we have received, we have procured many machines like GeneXpert and TrueNet throughout the country. So we are planning to revise all these accordingly based on our resources, the budget. And by this time, government already approved some of the cartridge cost in their development plan budget, DPP, we call them, for next few years. So that is one of our initiative we have taken from the country, and hoping that Global Fund will come forward in GC8 also in implementing this planning. And as she has already mentioned, the co-pay in that system, we are going to implement that in 2026, and going forward in GC8 also we are hoping that we will scale it up by cartridge as well as machines. Thank you.
Great. Got another question in the back of the room.
Thank you so much for that presentation. And I think this question might not be specifically for you, but I'm raising it because of something you mentioned in your slide under potential challenges. And one of them was budget, and you put in parentheses that this is unsustainable with the domestic fiscal space. So I'm just wondering, maybe this is for Global Fund, I suppose. What is the thinking that beyond the 1 year or 2 year that the support is being provided to make sure that testing is still going to be maintained, particularly if these tools are being placed in the hard to reach areas? And secondly, I see most countries have been talking about the short shelf lives. Is there any discussion with the manufacturer to make sure they increase that shelf life? Over.
Great, thank you. And so maybe we'll touch a little bit on the sustainability component tomorrow morning when we present the Access Fund and why this $2 copay has been decided, because I think that is, we are looking into the future and understanding that this early adopter work and the copay is very much for 2026 to really kind of help countries start to implement in the final year of many of the grants. So I think, but there is a sustainability. So we'll maybe touch on that a bit tomorrow. And then I will wonder with any of my diagnostic colleagues about the shelf life, because there is work being done on that. And I want to make sure I say the right thing. Is there any of the technical partners who can give an update on that one? But I think it was for the countries, it was in the FAQ document that the Plus Life, we have expressed that a 13-month shelf life is very short, particularly as many of our countries today, programs have said that thinking about hard to reach areas where, as Dr. Immaculate was saying, kind of the distance covered is hundreds of kilometers. So they are working hard, from my understanding, to get the shelf life up to at least 18 months within the 2026 timeframe. I think that's from my understanding, or at least that's what we're asking them to do. But I don't know if any partners want to update on that. I'm getting a thumbs up. And we have Jean Dejeu, you please go ahead.
Yes, thank you very much, and I'm glad to hear from Bangladesh. I saw some similarities with the region and most of the African countries, which is really great. And among enabler factors or enablers to really implement, I think there is another component we might consider, maybe during the breakout sessions. We need to look at it, is not only to talk about the government commitment, but specifically to mention or to focus on the laboratory directorates within the Ministry of Health. Because when we talk about near POC, right now we are thinking of the integration, because most of the technologies are not only diagnosing TB, but they might diagnose other diseases as well. So among enabling factors, this group of people need to be considered within the Ministry of Health. That's just an addition I would like to consider when we talk about the implementation, the rollout. Over.
Thank you. And I think we have a number of either TB lab focal points or lab director present in the room. So I'm hoping they feel that they are very much included in this. Now, we are going to run a little late for lunch. But I would like to now introduce, and our next country, the Philippines, will be presenting online because they were unfortunately unable to attend in person. But I will now, hopefully we can get that all set up, and I'll hand over to the Philippines team. Thank you.
Hi, everyone. Can you confirm if you can hear me well?
Yes, great. Thanks. We can hear you.
All right, thank you so much. First of all, we would like to extend our apologies for not being able to attend this very important workshop in person. But we are also grateful that you allowed us to attend virtually. So before I begin, I would like to introduce ourselves first. So I'm Earl Mantes from the National TB Reference Laboratory of the Philippines. Particularly, I'm from the Laboratory Network Strengthening Section, and I'm joined today by Mr. Luis Andrew Olazo from the Learning and Development Section or the Training Unit of the National TB Reference Laboratory. And also here online is Ms. Dolly Rose Santos from the National TB Control Program under the Department of Health. So I'll just be presenting a quick or a preliminary plan for implementing TB NPOC here in the Philippines. For the next slide, so this is just an overview of the TB burden in our country. So our country is really heavily burdened by tuberculosis based on the last or the latest WHO Global TB report. We actually ranked 4th among the countries that contributed the highest to the global TB burden. And in the next slide, so this is the overview of our TB burden. In 2023, our incidence rate is at 643 per 100,000 population. That's around 739,000 people falling ill with TB in 2023. For our MDR RRTB incidence, that's around 29,000 people or 25 per 100,000 population. And for our TB mortality rate, that's 37,000 people or 32 per 100,000 population. And moving on to the next slide. So I would just like to highlight here some of the laboratory data here in the Philippines. So comparing to our performance in 2016, so we actually saw a rise in incidence rate. For notification rate, we also saw an increase. So actually, it went dramatically down at the height of the COVID-19 pandemic in 2020, or in 2020 rather, but we actually were able to come back on track. And in fact, right now, our notification rate is around 78% of the estimated incidence. So we are back on track. For the proportion of presumptive TB or notified rather that were tested with rapid diagnostics at the time of diagnosis, so we also saw an increase from 13% back in 2016 to 65% in 2023. This is largely attributed to the rapid expansion of molecular diagnostics, since back then we were planning to really use it as our initial diagnostic test in 2020. So we scaled up our molecular laboratory network from 2017 to 2020. And so that translated to more people getting tested for rifampicin resistance and more laboratory confirmed rifampicin resistant TB. For RRTB patients who were tested for fluoroquinolone resistance, there's an increase, but actually that 12% is quite questionable. This is more of a reporting issue because many sites were not really reporting their FQ resistance testing data in our reporting platform. That's why it's quite low here. But we have already scaled up the expert MTB XDR or the low complexity NAAT for follow-on DST, and that actually helped us improve on this one. Next slide, please. So here I am showing you the framework of our new National Strategic Plan for TB or the Philippine Strategic TB Elimination Plan, Phase 2 from 2025 to 2030. This was just recently issued this year. So here our goal is to reduce our TB mortality rate, incidence rate, and catastrophic costs by 2030, as shown here on the upper portion of the slide. And we are focusing on the cascade of care framework, wherein we categorize our objectives into the 4 components: the screening, test and diagnose, treatment, and then prevention. So for testing and diagnose, our objective is to test 2 to 3% of the population. So that means around 2 to 3% of our country population will be identified as presumptive TB, and they will have to be tested. And out of them, 90% of the incident TB cases will be detected. And specifically for this component, we have 3 major strategies. Number 1 is to optimize the diagnostic network at local levels. And we see that the TB NPOC will really contribute into this diagnostic network optimization activity. And also, sorry, that's number 2, fast-track adoption of diagnostic innovations. So really, the introduction of TB NPOC aligns very well to the strategies in our new TB NSP. And third would be sustained notification from the private sector. So next slide, please. And here I'm just showing you our targets for testing from 2025 to 2030. So you can see here, next year we aim to test a total of almost 2.2 million people with TB, and hopefully TB NPOC will contribute to the achievement of this target. Next slide, please. So we have an overall TB national strategic plan, but at the same time, we also develop and implement a laboratory network strategic plan, which serves as a sub-plan to the TB NSP. And right now, we're actually in the process of developing the new laboratory network strategic plan for 2026 to 2030. And we have already identified preliminarily the 3 primary key result areas for the new LNSP. And we see here that TB NPOC will fall under the 3rd key result area, which is adopted innovations through research. And also, of course, it will contribute in the other key result areas, which is optimized network providing efficient services and sustained delivery of quality assured diagnostics. Next slide, please. So this is just a bird's eye view of our TB laboratory network, and I think we're all aware of this 3-tiered structure. So we have the central level, the intermediate, and the peripheral levels. So I'm just showing you here that we have deployed low complexity NAATs and smear microscopy up to the peripheral level. And for culture, phenotypic DST, and line probe assay, we have implemented these tests up to the intermediate level. So next slide, please. This is just a listing of the different WHO recommended TB diagnostics that we have programmatically employed in countries. For low complexity NAATs, we have 4 different assays. We have Expert Ultra and TrueNat for initial TB diagnosis. We also have TB LAMP, which serves as an alternative, mainly during active case finding activities. And then we also have Expert XDR, which is our follow-on test for drug resistance. Of course, we still have smear microscopy for treatment monitoring, and in case low complexity NAATs are unavailable or inaccessible. And we also have culture and phenotypic DST. We do DST to the new regimen or the BPAL regimen, but this is still done as a special request since we're still building our national capacity to really perform BPAL DST routinely. And we still have line probe assay as an alternative to Expert XDR. Next slide, please. So this is the number of laboratories in our network. For initial LC-NAAT, we have more than 1,000 sites. And for follow-on LC-NAAT or Expert XDR, we have 171 sites. For smear microscopy, we have almost 3,000 sites. And for culture, we have 30 laboratories nationwide, 10 of which can do solid DST, 4 for liquid DST, and 2 for line probe assay. So the figure on the right just shows the placement of the initial LC-NAATs across the country. So thanks to the expansion in previous years, it has really been scaled up nationwide. And the latest TB laboratory spatial analysis that was done in 2022 revealed that our current network of molecular laboratories already covers around 81% of our population within 20 kilometers of distance. So that's good coverage already, but still there's room for optimization and expansion. Next slide, please. So moving on to the next slide. So meanwhile, this is the directory of treatment facilities in the Philippines. So in total, there is around 4,400 public TB treatment facilities and 6,600 private ones. So we have, you can see here the DOTS centers, which are providing drug-susceptible TB services. And we have the IDOTS, or the integrated DOTS centers. These are peripheral facilities that provide services for both drug-susceptible and drug-resistant TB treatment. What I would like to emphasize here is that we have already been making efforts to decentralize BPAL, the BPAL regimen up to the peripheral level. That's why we have many IDOTS centers now. For the PMDT, these are the old sites who were previously specializing on drug-resistant TB treatment. But then again, as I've mentioned, we have already decentralized DRTB treatment to the peripheral level. Next slide, please. All right, so this is from the template, the outline of the presentation, which we will be discussing in detail. So next slide. So for the TB diagnostic challenges, we have highlighted here 3 main challenges, which would relate to how we develop the scenarios for the TB NPOC implementation. First, while, as I've mentioned, our existing molecular laboratory network is already able to cover 81% of the population, still there are some regions in which access is still limited because of their geographical connectivity. For example, in one region that is mentioned here, Mimaropa, this is very archipelagic in nature, so there are many islands. So really, we can't connect them by using specimen referral system alone. We really need to place machines or testing instruments in each island to improve access. Second, while we have been implementing molecular diagnostics as our primary TB test since 2020, still 8% of our testing data are smear microscopy data. So there are still some regions who are using smear microscopy, particularly the 2 regions mentioned here. And one of the contributing factors why this is happening is because of the frequency of power interruptions in these areas. So they result to the use of smear microscopy instead of molecular diagnostics. And third, while if we count the number of modules that we have nationwide, it can already cover all of our targets based on our NSP. But then again, when we look into the testing data of each facility, we were able to find that some areas or laboratories are actually performing beyond capacity. So at least 12 tests per day. So this means that they are working beyond 8 hours in a day. So really, they have high testing volumes. So next slide, please. So given that, we identified 3 possible scenarios for the implementation of TB NPOC. So we're actually looking into a pilot in select areas first before we go to full-scale expansion. So for the first scenario, we are looking into areas with a high usage of smear microscopy as an initial TB diagnostic test. So we're looking into somehow replacing smear microscopy with TB NPOC. And we have preliminarily identified 7 low-volume rural sites in 2 regions that I explained earlier. So the estimated annual demand for this scenario is around 7,000 tests. So for the second scenario, these are laboratories with higher throughput, Specifically, we looked into laboratories that are testing more than 2,000 specimens in a year. And we identified here 19 high-volume urban sites in the National Capital Region of the Philippines, particularly in one city, so that's Quezon City, and the estimated annual demand is 38,000 tests. So for the third scenario, we're looking into the utility of TB NPOC in contact tracing. So specifically for household contacts. So since there are challenges in doing contact tracing, since you have to ask them to submit sputum sample, and many of them would be unable to provide sputum sample saying that they don't have symptoms. So it's quite difficult. And then you have to bring the sputum sample back to the testing laboratory. And we're looking into if TB NPOC can address that challenge. So we're looking into targeted universal TB testing of household contacts. And here we have identified 30 medium volume urban sites in the same city as with scenario 2. And the estimated annual demand is 45,000 tests. Next slide, please. So just some notes regarding the other requirements for implementation for regulations and importation. So in the Philippines, TB is actually non-registrable under our Food and Drug Administration, but we have to apply for a medical device notification. So basically, we just have to inform our FDA that there is a new IVD product, and based on their issuances, application fee is around $130, and the timeline for this is 1 month. So that's actually faster. That's actually already faster compared with regular registration of IVD products. And another thing, the National TB Reference Laboratory will have to perform a central test validation first before we implement this. So I think there was one country earlier who also mentioned this one. So we have to look into the diagnostic accuracy of the test first before we roll it out in the network. And then beyond the grant, we also have to apply for what we call the Health Technology Assessment Council evaluation. So this is a statutory requirement of the Philippines before the government can procure any health technology, including test kits. So if we want the government to carry on the procurement of TB NPOC beyond the grant, then we have to apply for this HTAC evaluation. And this can be started once we have the WHO recommendations on the use of TB NPOC and also evidence from the country pilot. Next slide, please. So for importation, there's not much of a challenge because the Department of Health is a registered importer. So it just have to be that DOH is the consignee so that it can be covered by our import permit. For tax, the DOH can shoulder the customs duties, and customs clearance typically takes 1 month, but I think that's already fast given our experience with other reagents wherein it could actually be delayed. For delivery, so this will be shouldered by the supply chain management service of our Department of Health. Next slide, please. For procurement and supply chain, so for the left portion of the slide, at this time, we are unable to provide projections for 2027 to 2028. Similarly with Vietnam, we first need to see the results from the country pilot before we are able to really define our projection for 2027 to 2028. And for in-country supply chain, so we have an existing system under the Department of Health for inventory management and also for distribution. For specimen referral, we have what we call the Strider network. So Strider stands for Specimen Transport Riders. These are motorcycle drivers that have been engaged to deliver specimens from facilities to laboratories. And this network is funded by the Global Fund grant here in the Philippines, and it covers the entire Philippines. So we can easily tap that existing system. Next slide, please. For policy and training, so on the left side, this is more on the policy development process. So we have outlined here how it usually takes to have a new policy on TB diagnostics here in the Philippines. It starts with the National TB Reference Laboratory, drafting the guidance, getting inputs from stakeholders, and then finalizing the guidance based on inputs from stakeholders. So this could take 1 to 2 months. For training, we preliminary see it that we can do a 2-day blended program, 1 virtual session to gather everyone, and then 1 face-to-face session on practicum that can be done in batches. So we can do TOTs in regions since we have already an existing system in certifying trainers in each region, and then they can implement the trainings for the implementers later on. Next slide, please. For monitoring and evaluation, we can easily integrate it into the existing system that we have. We just have to update or create new forms as needed, and this will be done simultaneously with policy development. For reporting, this is done online through our existing integrated TB information system. And then for the pilot, we will do monthly or quarterly desktop reviews, and we plan to do 1 week on-site monitoring missions in each of the implementation areas. So that's a total of 3 missions. Next slide, please. For other support needs, so highlighting the last bullet, we also would like to request support for a face-to-face implementation review 6 months after the implementation. So we aim to gather all of the implementers and stakeholders to gather their inputs. And then we also would be needing TA on quality assurance. Next slide, please. So for budgeting right now, but aside from the budget for the bundles themselves, we still have to fill in the budget placeholders for other activities. We still have to discuss this with the Department of Health. Next slide, please. Yeah, and these are just some of the enablers and bottlenecks that we have identified at this point in time. So right now, there is really interest in the DOH here at NTRL and even in other stakeholders regarding NPOC TB diagnostics. And laboratories can easily be trained. They already have the technical capacity and readiness. And again, we have already an existing specimen referral network that we can tap into. For bottlenecks, we see there might be potential delays in the medical device notification as well as customs clearance based on our past experiences. For supply chain, there could be challenges on distributing the test kits in far areas, especially in regions 2 and Mimaropa. And there could also be delays on the HTAC evaluation, but this will still be happening later on. Next slide, please. I guess that's all. Thank you very much for listening.
Thank you very much, Charles. That was a very comprehensive overview and really inspiring the sort of short timelines and the ambition that the Philippines has and some of the parallel structures of kind of being able to move fast in this early adoption area. Are there any questions from either online or in the room for Earl? Oh, Jean, please go ahead.
Yes, a quick one. Thank you very much, colleague from Philippines, for your nice presentation. I have a quick one about the strategic plan and the implementation. You mentioned SME microscopy, and knowing that if the Philippines is among the higher TB burden countries in MDR, do you have any plan to phase out the use of SME microscopy as initial test? And also the second question is about, you mentioned validation or verification or evaluation. Are you involving the TB supranational reference laboratory in this exercise? we might have also colleagues from the SRL network who might play a role behind these verification studies that can speed up the process. Over.
All right, thank you very much. So for the first question regarding smear microscopy, actually since 2020, we have issued a policy update stating that molecular diagnostics are now our initial diagnostic test. Basically, it's supposed to phase out smear microscopy, but then again, with regards to the geographical challenges in the country, really, we can't totally phase out smear microscopy, and also because of the power interruptions and things like that. That's why we're looking into adopting technologies that are more suitable to the peripheral level. And really, TB NPOC is proving to be a great opportunity to address this challenge. For validation or verification, we routinely receive technical assistance from our supranational reference laboratory in Japan. But for this one, we have to do a country level validation, since it's our mandate as a national reference laboratory in the Philippines to do evaluation of new TB tests or technologies. So we have to do this quite independently from the SRL here at the country level. Over.
Thank you. Any other questions for Earl? Great. Well, I'd like to thank the Philippines team for their presentation today. So we've had a very, very informative morning with the 7 countries having presented their plans. And I think really interesting to see your national context, your analysis of your gaps and where this tool could potentially fill. I would, just before we go for lunch, and I will see my colleagues will give me instructions of how the lunch is happening, we would very much like to have a team photo, because I know everyone's probably getting quite hungry. I'm hoping it won't take a very long time, our team photo, because that is what's keeping us between now and lunch. And please do continue to talk to your colleagues and make the most of the experts we have in the room over lunch. I'm going to try and push us a little bit for lunch. So I think if we can aim to be back here at 10 to 2, so giving you about 50 minutes for lunch. And I think there's vouchers coming out. But if I can ask you all to now come to the stage so we can just take a team photo of everyone. Oh, wait a minute. Oh, yes. And the other thing is very important as well is my 2 colleagues, Melanie and Amina, will stand up. They have your value cards, so they will be available through lunch in the foyer? In the foyer, sort of in the foyer area of the hotel for if you want to go and start picking up your value cards. So that's another important announcement. So thank you very much. And can I give a big round of applause for all the countries who've presented today? Huge amount of work, so thank you. And just Indonesia will be the first country presenting after lunch because of the time zone issues. But right, please, everybody come to the stage for the photo. Thank you very much. Can I just confirm if the Indonesian team are going to present in person or if online? We'll maybe find that out. So if everyone can start making their way in, I might do a tour of the lobby to bring us all back. I think in the interest of time, we have got quite a few people here. We will start with the afternoon session, and I hope you all had a nice lunch and got to admire the beautiful view from the lunch terrace and the nice weather we're having here. So can I ask the Indonesian representative to come to the stage? Is somebody here from Indonesia to present? Yes, come. Excellent. Please. Great. And if we can put the slides up for Indonesia, please. Okay, so and if you would like to introduce yourself and if there are colleagues online as well. Thank you. Please go ahead.
Guys, slide from Indonesia. Indonesia. Yeah. Okay. Very good afternoon, everybody. My name Andrian Sauda Rukmana. I'm from the National Referral Lab for Tuberculosis Molecular. Thank you very much for the Global Fund to invite us to important meeting today. I will not introduce my team because I'm a single fighter today. But there's someone maybe from the NTP join by the Zoom meeting. Okay. Thank you very much. Today I would like to present about the Indonesian country perspective about the tuberculosis. Next slide, please. This is the Indonesian condition about the TB case notification and TB case treatment from 2020 until 2025. As we can see that based on the global TB report in 2024, Indonesia have the 1,090,000 TB cases or around 387 per 100 population, 100,000 population. And there is the TB resistant incident around 32,000 cases and TB HIV incident 25,000 cases, and what the mortality rate is 125,000 people in 1 year. And in the graphic, we can see that, yeah, in the graphic, we can see that there is the positive trend when the estimate case notification to be increased every year, and also the case enroller also the increase. And 2025, there's still calculation because we are still in October. Next slide, please. This is the TB suspect undergoing molecular diagnosis testing for 2024 and 2025. There is a slight increase in proportion of TB suspect by molecular diagnosis testing. Is from 67% in 2024 to be 68% for October 2025. And we have the 12% of TB suspect undergoing molecular testing become bacteriologically confirmed cases. Next slide, please. This is our national strategic plan alignment for 2025 until 2029. Actually, our NSP have the 6 strategies to accelerate TB elimination. First, the strong commitment, leadership and accountability from central and local government. Improving patient-centered access to integrated diagnostic treatment and preventive services. Meaningful participation from communities, civil society organization, and the private sector. A resilient and sustainability health system, and innovation in health technology and development of evidence-based research-driven policies. In the table, we can see that the new indicator to support strategy number 2 to improve TB diagnostic access, where the proportion of the TB suspect undergoing molecular testing to be increased year by year, starting for the 2025, 75%, and in 2029 to be 90%. And also, the number of health facilities equipped with MPOC, we plan in 2025 around 200 health facility will equip with NPOC, and to be increased to be 12,047 in 2029. 29. We note that the NPOC utilized to be equipped with the healthcare facilities. Actually, this Indonesian FKTP mean the primary level, what we call the public health center, like something like that. And we call also the puskesmas in Indonesia and this public clinic. Also, we note that the FKTP in here, the health facility already equipped by the gene expert machine or other the TrueNut system. The next slide, please. This is the current state of diagnostic infrastructure in Indonesia. We have the big population, I think, 286 million people in Indonesia. We have a number of health facilities around 10,000 PAC, 3,100 hospital and 18,000 clinics. We also have some laboratory equipped by the MWRD, including the gene expert, TrueNut also, and also BDMX. We have the totally 422 machine. And also we have the diagnostic site for the microscopy. This around 50,000 site. And also the molecular laboratory site. We have the LPA for the 7 site. Gene expert 10 color around 800. 800, and for the XDR site only is around 292. We also have the central culture for drug stability testing. We have the 23 TB culture phenotypic site and the 16 CDST site. The big challenge in Indonesia, because Indonesia is very big, and we have the 17,000 islands. So this is a really big challenge for Indonesia to tuberculosis national program. The next slide, please. This is the mapping of the laboratory and spreading of the molecular diagnostic tools. We have the 340 machine of gene expert. This all district already equipped with the gene expert machine. 17 machine for TCM. TCM mean the test cepat molecular, cepat molecular mean rapid molecular diagnostic. Sorry, this Indonesian language. Also the 65 machine for the TrueNut per March 2025. We have also the phenotypic laboratory for culture and drug stability testing, also line probe assay. Mostly maybe we can see here, mostly in Java Island, because the Java Island is more developed than other places in Indonesia. We also use the TB Open PCR laboratory. It means that we use the real-time PCR and use the kit from the manufacturer that's already validated nationally. Next slide, please. This is the current TB diagnostic challenge in Indonesia. You can see the some factor influence the TB program in Indonesia. Some of the technically problem, like the patient do not return to the healthcare facility to submit sputum specimen for TB diagnostic, or the TB suspect or presumptive TB cases cannot produce sputum. We have the interpretation of plan, for example, use a stool specimen for TB in the pediatric TB suspect. We also utilize a new diagnostic tool that can use non-sputum specimen, for example, the tongue swab. Another challenge is the geographical constraints and limited resource for placement of TB diagnostic, including suboptimal specimen transportation. So for that, we have the plan to point care TB testing suitable for remote areas with limited resource, and also implementation planning for diagnosis and treatment initiation as one-stop services. Delayed TB diagnosis turnaround time and specimen transport requires between 2 until 5 days. We try to implementation planning for diagnosis and treatment initiation as one-stop service. Deployment of rapid TB diagnosis tool in health facilities with short turnaround time. And also we have the challenge in procuring and maintaining TB diagnosis cartridge and consumable. This one factor is like the high cost, and our intervention or planning is diversification of diagnostic tool to reduce reliance on a single modality. Next slide, please. This is the early access deployment strategy. In our national strategic plan, 2025 until 2029, we plan to utilize NPOC to expand diagnostic access across all primary healthcare facility, including primary health center and also public clinic. And now we are currently conducting a pilot for the utilization of NPC. We start from August until December 2024. This is actually done by the RC3ID, Pajajaran University, and also the World Bank. We implemented across primary health center in 3 cities, but mostly is Java Island, especially in the West Java and East Java. This part of the one-stop service implementation, it means that we use the X-ray plus NPOC. This we will also perform the piloting of the one-stop services for 200 rapid molecular test site from January until March 2026. This we will use 1 mini-doc and 1 thermolyze across 9 provinces using 2 methods, with X-ray and without X-ray facilities. And we selected the area based on the gene expert or TrueNAT ability, because if the patient positive, something like that, we can continue to buy the gene expert. And also the high or the low molecular method testing volume. So this now we are currently under procurement process using the National Budget Fund. And in 2026, we have the plan to expand around the 1,100 molecular site across 38 provinces using NPOC. And also the sites are selected based on the ability of the molecular tests, and so we can enable to drug resistant testing with 1 facility and estimated presumptive TB cases. This is the category to selected the facilities. We divide into 3 categories. Number of health facilities with low testing, this under 1,000 presumptive case annually. And then number of health facilities with medium testing, use electricity. This is the testing between 1,100 until 2,000 presumptive case annually. And also the number of health facility with higher testing, use electricity. This is more than 2,000 estimate presumptive case annually. Next slide, please. This regulatory and importation requirement. This I think this important in the below one. This takes time. This around 1 until 1.5 months. The administration side. At the procurement time around 1 until 2 months. So the totally importation requirement needs the 2 until 3.5 months until the cartridge received by the facility, health facility. Next slide, please. This health product procurement and supply chain management. We have the procurement planning and execution, like the quantification and forecasting country full demand for 2026 until 2028, order placement timelines, shipping and delivery, and budget placeholder. This product cost integrated in Global Fund grant, loan from World Bank, and also the domestic budget. In country supply chain, we will integration in national stock management and stock replacement tools, integration and distribution cycle and warehouse management system. Supply chain and stock monitoring will be integrated into national stock management because we have the SITB, mean the tuberculosis information system, and also SMILE. Budget placeholder for in-country distribution, integration of TB NPOC in supply chain tools and logistic information system. Next slide, please. This policy guideline to implementation and training. First is conduct evaluation of the pre-pilot result from primary healthcare as a basis for determining the algorithm, policy direction, and developing the related technical guideline. We also want to update the national TB diagnosis algorithm to include the NPOC tests, develop specific technical guidelines related to NPOC, develop training modules, conduct training session both online and offline, and also integrate with sample transport and referral system. This budget and communication also. Next slide, please. This also the monitoring and evaluation and learning for the NPOC implementation. By the monitoring approach, recording and reporting of NPOC are included in the tuberculosis information system. Conduct monthly data review and quarterly supervision visit to assess performance and implement course correction. Utilize feedback quarterly. Utilize feedback loop between testing site, laboratory, and TB program to improve data quality and case management. Next slide, please. This implementation support test, we need the technical assistance support for mapping, distribution, and demand creation. Also support in country capacity building and continuous quality improvement strategies. Next slide, please. Budgeting. Currently, we are in process of finalizing budget for training, workshop, monitoring, and evaluation, preparation of technical guideline, dissemination and procurement of equipment and reagent in national strategic program for 2025 until 2029. Next slide, please. This is the enabler and bottlenecks. As the enabler, we have the pre-pilot result serve as key evidence supporting the utilization of NPOC in Indonesia. This all we will covering the aspects such as effectiveness, sensitivity, specificity, algorithm, and also the cost effectiveness. Engage and community leadership to facilitate successful introduction of rollout TBC and POC. Diagnostic including budgetary and policy support. Technical capacity and readiness of service delivery platform, also waiting for the result of the WHO pre-qualification and recommendation. As the bottlenecks, the bundle price of locally produced NPOC equipment and reagent is higher Then the global price is also the common problem as to the budget constraint. Product is unsustainable with existing domestic fiscal space and also uncertain donor funding. Short shelf life like this of Inspire and worse. Clear information regarding warranty and its financing is not yet available. There's a need for information on the development of NPOC capable of performing the persistent testing. Also, the technician or service provider are not yet available across in all our region. Next slide, please. I think that's all but the Indonesian country. Thank you very much.
Thank you very much. Thank you for the presentation because Indonesia is piloted already. So just one curiosity and one question. My curiosity is you have a lot of, they are not landlocked because a lot of, sorry for it. How do you manage the spaceman transportation and so on? This is just my curiosity. The next is, in your pilot study, cost effectiveness, algorithm effectiveness, is it encouraging? Okay. Thank you.
Yes.
Yeah, I will try to answer the question. Sorry, I'm improving my English. Yes, Indonesia big challenge is because Indonesia have the 17,000 island and separated by the sea. Not all the region of Indonesia can coverage, but mostly because the successful rate in Indonesia we can find in the big island like the Java Island. Is because our Java Island is developed province comparing to the others. Actually, we work together with the national courier in Indonesia, or this like the milepost to send the samples from the remote area, something like that. We also divided some laboratory have to coverage some area. So I explained before that many laboratories spreading in the different island, and they also service from the others. Like our laboratory, we collect sample from the 6 province, even from Kalimantan, for example, the big island, there is the laboratory, but sometimes in the same island, there's difficulties to send the sample to the same island. So sometimes they have to also based on the easy transportation. I think. Around the pilot project, actually, sorry, I cannot answer you correctly maybe, but we will have the 63,000 sample for the pilot project. But all covered by the World Bank, and also some come from the national budget. It's already calculated by the epidemiologists and also the statistician. So maybe the result will explain the NPOC next step in Indonesia. Thank you.
Thank you. Any other questions? I've got a question here at the front.
Thank you, Indonesia. A question about the pre-pilot. You say it is in 3 cities, X-ray plus NPOC. Just how did you what kind of sites or health facilities, or is it communities that the pre-pilot is being done? Because you said it's the one that will inform the algorithm and the next steps.
Yeah, for the pre-pilot, we just use the site with the X-ray and plus NPOC. But for the stop service, we will implement the NPOC in 2 sites, different sites, with the X-ray and non-X-ray. Yeah, maybe from the pre-pilot, we just get information algorithm between the site with the X-ray and NPOC. Thank you.
Great, thank you. Okay, one more question.
Thank you very much, and a very exciting presentation. What findings in the pre-pilot will convince you to roll out?
Sorry, I cannot catch you.
He was.
Sorry, maybe tomorrow from MTP.
That's fine. We can put it on our question board.
Because this I mean that decision. Yeah.
Thank you. We can. Thank you very much. And I think I want to recognise the level of ambition and already the domestic financing being mobilised. So our next country to present is Zambia. So is anyone here? And then if there's, I know that unfortunately Dr. Angel couldn't make it, but if there's anyone else from the team, please do introduce them. Thank you. And the liquors there.
Oh, it's okay. Good afternoon, everyone. Yes. Great. Here with a colleague. She's just stepped out, but I'll pause to introduce her because I think she's key to this work. So my name's Chitalu Chanda. I'll present on behalf of Dr. Angel Mubanga from the National TB and Leprosy Program. Basically, when you look at the overview of TB in Zambia, we are competing with South Africa. Among us, the top 30, probably we are 19. And that's Judy. Hi, Judy, welcome. So basically, we are among us the top 19 countries, you know, with high TB cases. And you can see that we notify over 59,000 cases per year. That's quite significant, with almost 60% of these being bacteriologically confirmed TB. In 2023, at least we notified 93% of the cases that we had, and with the 93% success rate. Our mortality is slightly higher, with about 5,000 deaths being noted, and we're seeing an increase in mortality in the HIV negative populations, which is similar to the HIV positives. We do have significant catastrophic costs being faced by our clients, and probably you'll see when you look at the map that some of these have to do with the distance they have to face just to get the service of getting an expert or an X-ray testing done for them. Okay, so when we look at how the NPOC falls in line with our strategic plan, you can see that we really want to scale up our ability to diagnose TB using molecular diagnostic tests. And you can see that based on the NSP, we were at 46% in 2020, and we aim to get to at least 80% by 2026. This is 2025, meaning we are lagging behind because we're now currently at 62%. You could appreciate the other indicators in terms of where we are in the TB cascade, in line with the national strategic plan in terms of treatment and DRTB. And maybe if we scale up our ability to diagnose TB, you will see that our DRTB finding might also increase because we're still at 83 when our target by next year would be 700 cases. Lastly, but not the least, also we are having to find TB cases in children, and you know how challenging it is to find TB, not just in the urban, but also in the rural, where specimen collection might be a challenge. Currently, we are sitting at 10% in terms of our target with an NSP. So probably you see that there is room for opportunity and areas of intervention where we could have strategically placed molecular diagnostic tests to find the cases that drug resistant, and to find the cases in children. Okay. Sorry, it's moving faster. How many of us have been to Zambia before? Just raise your hand. Zach, Zambia. So you can appreciate from our map that it's not small, it's large. And as you can see, the red ones basically highlight for us where we have the microscopy diagnostic points. And then where you have the green, that's where you have the molecular diagnostic tests. And you can see there are areas of gray where there's nothing that we need to go to. So there is at least an opportunity for us to find those areas. But you can see that we still have a small population, just 21 million people. And the health facilities are around 4,000 if you look at the health service. And also you find that in terms of GeneXpert, we have currently 318 GeneXpert machines. Of these, 50 are 10-color module that are distributed in the provincial towns. We also have recently brought on board the TrueNet and the LAMP, being able to supplement these diagnostic tests. You will find that most of our diagnostic facilities, most of our treatment sites are actually public, with a few that are private. Like I've said on a map, you can see we still have molecular sites, and we run to these when we have challenges with the molecular tests, especially because we still have the microscopy done in some places. We have gone down on the use of the LPA. We had 3 LPA points, but since the introduction of the 10-color module, I think this has lessened the burden and the turnaround time. Right now, I can say our turnaround time for between sample is basically 1.5 days, despite having such a large map where we have a high coverage. Great. So what are some of the challenges? There are many, and some of them are cross-cutting with what other colleagues have said before. But I think I'll highlight 2 things that, for me, are key. When you look at our map, we need to access people. In some places, the map might not show. During the rain season, it becomes challenging to get there. Okay, on the western side, there's a lot of flooding, becomes quite a challenge to get there. So access to these, I know that we have a lot of dependence on referral system, and that might also impact the quality of the sample that you're actually getting if you have to courier it over 100+ kilometers. So those are the 2 main ones. That's the main one, access, because of either geography, or sometimes we have this dependence on the courier system. I think we've integrated, I've seen some colleagues have mentioned, we've integrated courier system of HIV samples with the TB samples, and that has been very, very helpful. But I think sometimes it just gets challenging when the terrain might be very difficult for you to get to. The second one I want to look at is the current GeneXpert testing modalities really require you to have a certain environment that becomes very easy for you to do this test. For example, you require a cool room. But you know that the southern region has been experiencing load shedding. Yeah, Zambia also has not been spared, and so another country have a similar challenge. And you find that it becomes very difficult for you to maintain your temperatures within the lab. I think, Zach, you saw that at one of the facilities, that it becomes very difficult to maintain the temperatures and be able to run your GeneXpert. And you find that that increases your turnaround time. I think these are the major challenges that I could highlight for now. There are many others. All right. So as a country, I think we will adopt this provided step-by-step process of national planning, budgeting, regulatory requirements. We will try and expedite some of the processes. I think we've started doing some of this to just help us. But also in terms of health product procurement and supply chain, we're glad to say that we have at least the in-house availability of a supplier who is registered. But I think the key thing to implementation science and implementation research is number 4, policy and guideline. I think that if we don't take an active step now to update our guidelines and national algorithms, it will take us 17 years plus to get this going. So I think that we want to get this done by 2026 so that then we have dissemination and we prepare the ground to just ensure that implementation is smooth and uptake is improved. Monitoring and evaluation is key, and I'll highlight this as one of the bottlenecks that we anticipate to see in the program, but we'll adopt this process. Great. So where are we? Basically, we thought as a program, we will deploy this in a phased approach, basically, and we will make sure that we deploy over 51 platforms in parallel, and we have a unique way we want to do it. One of them is that we will target the rural decentralized sites. I think you could see that we have the, you know, the urban towns, but we want to target 47 decentralized sites in the rural provinces. And these have unique challenges in terms of what we see in terms of access, in terms of what challenges they might experience. But we also want to have some sites that are basically too low throughput with good supply of electricity. And this will help us to think about the next step when we want to scale up. But we also want to add another high throughput facility with also electric. That is basically, again, located in the central or the provincial town. And again, this will help us with scale up as well. We hope to start by June 2026 through to December 2026. Basically, what we notice is that our selection is really mainly guided by geographical gaps that we've seen. That's why we want to go to the Lulo. And the infrastructure, the things I've talked about in terms of just having a lab to ensure that we are able to run this. In terms of regulatory requirements, like everywhere, it's a tedious process. So basically, we are glad to state that at least we have reached the process of basically application and submission for validation. And this has been because of prior research that has been done in our country setting. And I think this has helped to speed up this process with ZAMRA. But that's the whole process that we have. And basically, because of the previous research that has been done, we anticipate that the timeline would decline from 24 months to less than 9 months. Okay. In terms of the health product procurement supply chain, what we notice is that the planning is ongoing, and we've started with the high volume sites as we've communicated. Focusing on quantification is done for 2026 to 2028, but we do have a mid-year review, and that gives us an opportunity to integrate the NPOC. But in terms of order placement timelines, it takes about a month, and shipping and delivery, it takes about 3 to 6 months. I was chatting with Judy, my colleague, to say that's a small gadget. Therefore, it would take us less time. You can just put it on a plane, okay, even if it's large quantities. But I think that's being optimistic. In terms of budgeting, we hope for co-funding, and this is being reviewed as we received more instructions on how we should progress from GF. I must mention that we also have a local supplier in terms of who is licensed and available in country, and that would be very helpful. But the next steps would be to then adopt the algorithms and facilitate integration into the national stock management and stock management tools. We also have to integrate and distribute the cycles and warehouse management systems, just the current flow system. Okay. Sorry. In terms of policy and guidelines for implementation and training, some of the things that the program would like to ride on basically is to update our TB national guidelines, national consolidated TB guidelines by 2026. And I think this helps with uptake of any commodity or any innovation that's coming on board. And I think the program has put processes in place to ensure that by 2026 we have these guidelines and they are disseminated to the. In line with the process of a new molecule innovation, especially with diagnostics, validation in country will have to be done, but also presentation of this particular information to the technical working group in the TB and lab also have to be done. But also we're glad to mention that this process of internal validation has partly been done because of the research that was done in the country on the same platform. Also, policy circulars are being drafted and will be shared using implementation platforms, using platforms that we have currently, the ECHO and the TB Situation Room, that would serve for this dissemination of the circular. We also have processes and plans to introduce NPOs as his and twos, as well as IEC materials, and also to start demand creation. I think that would be very key for us to increase the uptake. It's very difficult to move people, especially when they're used to some like microscopy and you're bringing a new tool. So there is a need for demand creation in the communities and in the facilities, as well as to conduct many trainings, both regional and facility level. Monitoring and evaluation framework will adopt most of the indicators. I think that they fall in line with what the program envisions, just basically to look at the reach of how many people are we testing, who is being tested, what's the outcome. And I think this will help us to see some of the implementation outcomes, such as reach, effectiveness, as well as adoption. But also what we want to see is that we want to have integration of the routine monitoring system aligned with the TB platforms, such as the DISA, the BiPower 2 that we have as a dashboard, and then the GHIS 2. We also want to integrate the NPOCs, like I've said, the indicators, and we want to monitor these through a weekly situation dashboard that we run as a program. It will be good, and we plan that we will conduct monthly reviews and quarterly supervision visits just to improve and sustain the use as well as fidelity to some of the tools that we develop. Also, we plan that more probably for the first year, we have a standing agenda item on the TWG for TB and lab, just to track where we are with the implementation of the NPOC. Support and needs, we have adopted the need for the technical assistant, but also budgeting will be something that we will require. And we envision that data capturing might be some of the challenges that we will get, especially if we are to get the data from the equipment into our reporting tools like DISA, as well as generation of screening algorithms. In terms of budgeting, I think this is still an ongoing process, but we will cost based on what we've been guided for 50,000 indicative volumes. Enablers and bottlenecks. I must gladly say that we have a lot of support from the leadership and governments as regards the TB program, and we still want to ride on that even as we bring in the NPOC's implementation. We also want to strengthen and update our guidelines, so this becomes an enabler, as well as we have a process already in line with ZAMRA, or Zambia Medical Regulatory Authority, and this process is ongoing and has reached an advanced stage, like I've said there earlier. In terms of availability of resource, we have a local agent that's already available. I think Judy has done a great work of mapping out all the facilities that would require this process. Also, we do have technical capacity to roll out and implement. In line with this, recently the government adopted what's called a minimum package, which basically ensures TB services are provided, and this has recently been disseminated. And one of the key messages has been to diagnose TB using molecular testing. So I think that becomes an enabler as we implement. What we see as bottlenecks, probably commitments to getting the cartridges by 2026, budget constraints, short shelf life. I think most of the other colleagues commented about this. Training of frontline workers, but we also envision reporting from the machine to get the data. Thank you.
Thank you very much. Now, are there any questions for the Zambian team? Oh, question over here.
Thank you. Question to Zambian team, because they are my friends and we have a lot of similarities. So yes, you talked about testing in parallel. I didn't get that right. But you also mentioned a lot of KPIs here. which I imagine some of them will be about accuracy, safety, and so on. Is there any KPI you will see which will scare you from expanding?
Thank you so much for your question. So when I talked about the way we would do it, basically we want to run a lot of the activities simultaneously. Pick the sites, train, start collecting data. We want to start integrating as much as possible from the start. And that's what I meant by parallel running. In terms of the KPIs that would scare you, maybe I can ask Judy what she thinks. For now, I'm blind to see which KPI would scare me, but maybe my colleague can see.
There really isn't any KPI that would scare us to expand, but what we are just looking at is where we have, like for the Gene Expert cartridges, they're already committed for the whole 2026. So meaning that if we introduce this new platform, we might risk expiring. And we are also introducing the TrueNut at the same time. So that's what is scaring us. Thank you.
Great. Got some more questions here.
Thank you very much, Team Zambia. I was just wondering when you said scared of expiration of those platforms, is that why the projection for 2026 is just 51 facilities and 51 docs? Because when I look at that, each of the facilities then cannot test more than 10 people per day. So could that be the reason why you are not going beyond that projection of 51?
So the projection for 51 is what we received from Global Fund. What we had planned as a country was 100. But when we got that notification, we had to revise to downsize what I know.
And I think just to sort of say, there's kind of from the Global Fund perspective, there is the allocation that we can use with our access fund. But as we get feedback from all the countries here and negotiate with the supplier, we hope there may be an opportunity to offer you more tests. So I think that is why also in the template, there is the sort of the opportunity for say how you're going to use what is allocated. But if you were able to get more tests, how many more tests would you get? We cannot guarantee, but I think we want to, as much as possible, see if we can match the ambition within the program. And then just to sort of clarify, when we're talking about tests, how many licensed machines and platform you receive, it's an indicative bundle. As we get clarity on the final negotiations with the manufacturers, the locations of the site, the country-specific aspects, the exact bundle may change, but all we want you to know is that we will provide what we think is the right combo of licensed machines and mini docs for that site to achieve the test that it is aiming for. So and while we're doing Global Fund clarifications, I know there's one more questions within and was brought up as a sort of key point within this early adopter package. We are aware of both the time pressure that we are pushing, all of us in this room are pushing for. So an initial package is factoring in air freight for both the platforms and the tests. So this may not be needed in the longer term, but as we are trying to achieve a lot in a short period of time, we are factoring in the air freight costs. One more question here at the front. And then Jean, I see you online, so I'll come to you after.
Thanks, Zambia. And Zambia mentioned that they plan actually to have, in fact, they mentioned policy and guidelines to them as an enabler area. So and Dalia mentioned they plan to have an expedited process. I don't know how because sometimes that can quite be a bottleneck. So how are they planning to make sure that the policy and guidelines are expedited for this?
So for the way, first of all, the registration of the product and the platforms. We did inquire from our regulatory authority, and they did tell us that since it has the ERD already, then it won't require the 24 months. It's easy. Then secondly, there is a new policy that because of this cut in funding, where we are now implementing what we are calling the minimum package of care. And the main or the objective of that is that we implement or any diagnostics, quality diagnostics, but at a cheaper cost. So this is the guideline or the policy that we want to ride on to say, okay, this is cheaper than what we are currently using, and this is how much we are going to save. So that one is going to actually work to our advantage as a program.
Thank you. Jean?
Yes, thank you. Thank you very much, Zambia. I have a question about, maybe it's for everybody as well. It's about budgeting. We all know that when it comes to budgeting the lab, I think because we have many NTP managers in the room, when really it comes to budgeting lab components, the cost is high. As a result, the cost is cut, and lab is, let's say, compromised. So for Zambia, I saw you have just one line about the budgeting. Do you have a planning in the budgeting tool you will use to make sure that the plan you have, the 5-year plan, can be followed for your scale up? Maybe your response can help others as well, because this is, I think, a bottleneck we are having in the region, the planning and the budgeting tool, which can really give us a good indicator. For me, we still have a long way to go to make sure that the budget is not cut for the lab. So if maybe Zambia can elaborate a bit, can be good. Thanks.
I will try and answer part of the question. So in terms of the budgeting, first of all, we just showed one line because this is work in progress. When we got the notification, it meant that we needed to start reworking certain things. So that is why we just said, okay, because budgeting takes some time. So we didn't want to rush the process. So we just showed what we were allocated, but the budgeting, the actual one will be done. Then what we use mainly for the for commodities, laboratory commodities, we do use the forecasting and quantification tools that we use for the commodities. Then we get to do that. And we have done that for TB, where we know how much we want for each of the years up to 2029. So what we are planning to do is that we are going to now just, from what we have done so far, get the allocation for the NPOC, and then it will automatically do the calculations for us to know how much is actually required for each of the years. That's part of the what I can explain. Thanks.
Thank you. Any other questions? Can we have a round of applause for the Zambia team, please? Great. So I will now like to invite our colleagues from Peru to present. For those of you, I think they will be presenting in Spanish. So for those of you online, make sure you're on the translated channel. And those of you in the room, the headsets are on the table. And someone will help me with what the English channel. Channel 1 is moving it to English. So 2 for French and 3 for Spanish. So thank you.
Good afternoon. I thank you for the invitation that Global Fund gave us to participate. We came being 3 people Fateko, I'm a Fateko from Institute of Health, and the Sotatake from the Ministry of Health. Before everything, I would like to express the greetings from the Institute of Tuberculosis in Peru. Now talking about where we are located in South America, and we are bordering with Brazil. We have this tuberculosis density. We have 34 million of inhabitants in the whole country. The density, we have 25 inhabitants per square kilometers in 25 regions. Lima is the capital city of the country. Next. As a national program, we have done analysis of geolocalization to know the situation of TB in the country, having in mind of how the accessibility it is in our country, health facilities distribution, where our big cities are. Next. That is the product of that analysis in what we have done. We have focused on tuberculosis in districts. And also we focused on the places of higher risks because of the inequalities increase. Now talking about the overview, we have 33,049 cases notified in 2024, but we estimate 59 cases of tuberculosis. From those, 200 as resistant of to rifampicin. We have a few cases of TB because of the definition. In 2024, we have 10 cases. The organization of diagnostic network in Peru, that National Institute of Tuberculosis in 2021, we have local laboratories and we have microscopes, and we have implemented in 33 centers using molecular tests. In national laboratories, we have 29 at national level, and all the laboratories use sample molecular. They do molecular tests. Now, in some laboratories, they do denotype, and we also have a reference national laboratory that has the test available for diagnosis of TB resistance and also quality control. As I said, with regard to expansion of molecular diagnosis, in 2023, we had 14 laboratories with the Gen Expert, with all the laboratories which are equipped with the budget of a global fund. In 2024, that is, we could introduce 10 laboratories with Gene Expert equipment, which do DST. In 2025, this year, all the laboratories of the region do that DST test according to the global fund. We have the budget for the equipment. With the public funds, we could buy the inputs. Now here in 2025, we have 24 equipments of a Gene Expert at national level. and the 33 equipments TrueNat, which are being implemented in the first level of care and in the regions in green. This allowed us to increase the coverage of diagnostic using molecular testing in Peru, but we have 1%. And 2024, we closed with 44%, 45%. And then here, this year, we are approaching 50%. As you can see, that the numbers which are absolute as expert molecular test, they have increased in 17,000 in 2025. As we have planned for the introduction of NPOC, I was saying that we did a partial analysis that allowed us to identify that we have regions that are the capital city where they can do molecular tests, but in interior, in rural area, there's less accessibility for the population. Now, a few people could benefit from that test. Now, here we have in Amazonia or Peru, that is to say, in the forest region. Now we have indigenous communities there as Loreto, Amazonas, on the Cayade, Madre de Dios, San Martin, where even if you can see that they are together in the big cities or the capital cities, but the region, in the region, the access is limited. For Via Fluvial, you can see that in that area, the level of access. In these places, we have identified for us to implement that methodology, identified 20 health facilities in the first scenario, 4 health centers for the scenario 2, and 3 health facilities for the scenario 3. And we have 32,000 tests for the whole year. That will replace what we have done in the health centers, but also we use this methodology to do that. Now, we need to have, we have still a challenge in terms of transport of the samples so that we can identify the resistance rate. We have used this criteria focusing on incidence rate of tuberculosis and low accessibility because of the distance of the health centers, and also a connection using water and air means, and also this that is also there are some population which is not benefiting from the test using molecular test. The country, among the requirements for importation, we have 2 scenarios. The first scenario is the donation through Global Fund, where working with the Ministry of Health through public funds. In that case, in the first phase, we had the scenario of donation through Global Fund, which is through the main beneficiaries. Now, that is what we did at administrative level, and also the regulator center has facilities so that the product can be received. Now, Now, the stock is in the Ministry of Health. Now, our institution is in charge of distribution with regard to sustainability of actions that we have initiated with the Global Fund. There is the level of procurement. There was evaluation of the interventions. Now, we are working with the Ministry of Health, which is the center of procurement of products. The ministry is responsible of sanitary registration, which is very indispensable in our country. As a supply chain in our country, we, as a national program in coordination with the National Institute of Health, we do estimations of needs, and we determined the number of biomedical equipment and the number of tests that will be used in this year, and another additional resources. The main beneficiary is responsible, is the Ministry of Health, who does the request. And he did also all the processes necessary. The distribution is done by the Ministry of Health, not the ministry from the distribution of inputs to the distribution and destination level. For the implementation of the test, we have to modify our regulatory documents, given that what we have was approved last year, and it has a framework, regulatory framework of a national laboratory, so that it can elaborate the procedures of laboratories for laboratory resistance test within the policy of the National Institute of Health. All the tests that can be used in the country need a technological evaluation. In that case, we are accelerating or putting in place a margin of time so that we can do that evaluation, technological evaluation, which is a requirement, which is the responsibility of the Institute of Health. Now, there's a pre-installation assessment as well that we are considering in 15 days, doing it in a mixed way, virtually or physically, to identify if the health centers have conditions for the equipment for test. We also have technology transfer that is very important. That means that the staff of the National Institute of Health has to distribute it to each establishment. We have 24 posts who have to do capacity building on the methodology. And finally, there's monitoring and supervision, which is continuous. And after that process, we did an evaluation with which we estimated the last year the programmation of inputs that have been budgeted for to be bought by through the public funds. Now we started that in 2020. We will start in 2026. Sorry, let's say in the second term of 2026. We need to have covered the first term of 2027. We will have a challenge in the second term, because we do programming the year before. So we think we will have finished that evaluation. I don't know if it will be necessary to do that, because we will have finished, and maybe we'll have used the public funds. For monitoring and evaluation of the implementation, we have a nominal system that not only register TB cases, but also in everybody who has gone through screening. Now, that is interconnected with the Institute of Health with regard to diagnosis test. With that information, which is nominal, we have to give information so that we can do monitoring and also to be able to accelerate analysis and of the indicators which are aligned with the indicators of WHO. And what enablers that we have for implementation, we have political support, and also we have identified the establishments in which there is a BK and have the necessary resources. Now, that is where that methodology will be carried out. And talking about the bottlenecks that we identified, to date, we don't have any representative in the country of that new methodology. Now, for us, if it will be ideal to benefit from technical support and also equipment so that our team can be trained. With regard to other tests, we need a representative in the country, and also we need to make sure that a methodology can have a representative in the country. That is mainly what we have found as bottlenecks, and also the regulation of the test. We saw that in 3 months, but considering that it takes a lot of time and the health centers are not very near. In our case, we consider that we have to have the duration of 18 months at least. That is all from Peru. Thank you very much.
Thank you very much. So are there any questions for the Peruvian team? And you can ask your questions in English and they will translate it. So we're not expecting Spanish. Okay, we have a question.
Thank you for that presentation. I'm just wondering on one of your last points when you say 18 months of data are needed. So are you saying that needs to be done first before you can roll out in the remote areas? I think you had a sentence that said 18 months of evaluation data or something to that effect is needed since the instruments will be placed in remote areas that are hard to access.
No, me referí.
I was talking with the 18 months. I was talking about the expiry date of the kits of doing the test, the expiry date of the testing kits.
John, is that a new hand? Have you got a question for the Peru team?
Sé que tiene una pregunta, John, virtualmente.
Yes.
Que
Are
sí.
you talking in Spanish? Are you talking in Spanish so I could not
No, será
understand Spanish?
entonces, como estaba hablando en español, no puedo como
Sorry.
entender. Entonces, bueno,
Okay.
no puedo como entender en español. Entonces,
Thank you.
puede hacer la pregunta en inglés y luego a tener en español.
Okay, thank you very much. I have a quick question about the implementation training. There is a slide, and thank you very much for Peru. There is a slide where a colleague from Peru showed us technology assessment plus pre-installation assessment plus technology transfer before or monitoring the impact. He mentioned 25 days, 15 days, and 3 months. Isn't it too ambitious? That's the question. Thank you.
Esta pregunta
That question, my colleague will answer it. He comes from the Institute of Health. It's about the process of evaluation, technological evaluation. My colleague maybe can answer that question.
Bueno, sí,
To evaluate, to do technological evaluation, we involve the place where there is that facility. Now, we have done implementation with technology. Truna, we are 18 persons in the laboratory. Then in total, we follow the protocol, and then in a specific moment, we go to different places to work with the companies, but we also do massive training. That training is for the whole staff who are involved, so that we can generate that training. What we have done is we did something for 1 week, and that we went to different sites with regard to implementation. Now, we did it through Tronat. So first of all, we started with the technology transfer. We did the situational analysis virtually, first of all, on the capacity of the staff in the laboratory. And after that, we did implementation in laboratory. And after that, because technology is something which is automated, in which there is a staff at the national level involved in the molecular test, we didn't take a lot of time because maybe 1 day, 2 days, but that structurally, that is our program, because we could generate the capacity building, implementation, and monitoring. We are doing that nowadays in that process of verification with regard to on-site work.
Thank you. We've got one more question and then another question over on the other side of the room. Who's having? And we have a microphone over here. Thanks.
Gracias. Voy a intentar en español.
I will speak in Spanish. I will ask in Spanish. Thank you very much for the presentation. A question on the data system. As she did, the new data in very remote places, are they connected to the system that you have, which capture all the information electronically or not? Or how are you going to capture the results of the test and all that? Is that connected to your system? With regard to national program, all the health centers are registered on a nominal system now. Now, that can be transferred to different zones. Now, if we had thought on laboratory aspect, because if it is an issue in which we can include necessary equipment so that we can do that, we can take data on the test that we do. Now, we use laptops and other equipments and given the conjecture of our country and a lot of risks, now we need computing equipment to resolve or to address that issue now. But everything is registered in a nominal register that we have on tuberculosis. I don't know if there's no problem with the laboratory registers, but we need to equip the laboratories with such an equipment.
Great, thank you very much. Any other questions? Otherwise, please round of applause for the Peruvian team. Now, I'm going to be very cheeky and push our coffee break just a little bit further. And we may slightly go over this evening, but I think these conversations and these questions are really helpful. So before coffee break, I would like to invite the Benin team to come and present their plans. Excellent. And please introduce your team as well. Thank you.
Hello. Good morning, everyone. I speak French. I present my communication in French. Okay. Alors, merci.
So thank you. So the team of Benin is composed of me, Sebenaro, who is in charge of the coordination of the NPNT, and it is managed by the Professor Bisua, who is in charge of the PNT as well. And we have Mr. Osua, who is representing the ministry, especially the National Laboratory. Thank you. So the implementation plan. So Benin is a beautiful country in West Africa, which has about 13 million inhabitants. Benin is not the capital city of Nigeria. It's just Benin is a country which is just next to Nigeria. So I'm just some clarification that I would like to say. The capital, economic capital of Benin is Cotonou, and according to the World Health Organization, we should have about 7,000 cases of tuberculosis this year. So we have about 2003 number of health facilities, which are public, private, and others. In 2004, you can notice that in 2024, we had 4,067 number of all forms of cases, and we had also 3,987 number of incident cases of tuberculosis. The seroprevalence of the cases is about 12%, which means that we have about 12% of TB and HIV. So the number of drug-resistant TB cases, we had 40 cases in 2024. It's not a lot. So, which is something that is really very unique in Benin. With the number of cases that we have had, we have about 91% of treatment success rate. You're going to notice that we have a 91% of success rate in terms of treatment susceptible to TB. And we have some of whom that are TB resistant. In terms of the general country information, here we're going to see the current World Health Organization recommended coverage for the year 2022. You can notice that for all cases that were tested, we have 65% who have been diagnosed thanks to the technology Gen X. and 66 for 2023, 66 for 2024. But in 2025, we were able to get to 71% of cases that have been diagnosed by GeneSma. Countrywide overview alignment with the National Strategic Plan. We're going to look at the number of incident cases. In 2024, we expected 4,169. We had 3,987, which represents a gap of about 182 in terms of the strategic plan. In 2025, we expect 4,227, and 2026, we expect 4,285 cases. So what's the current status of the diagnostic infrastructure? We have in Benin, we have about 99 laboratories. We have 99 laboratories which are all over the national territory, and we have 94 number of screening and treatment centers. We also have 34 number of sites performing Gen Expert first line, and we also have one reference laboratory which of course done the Gen Expert MTB RIF and MTB RIF Ultra, culture, density, and genomic sequencing. So, what are the major challenges related to tuberculosis diagnosis? First of all, we expect to cover at least 2/3 of all laboratories with molecular testing to ensure first-line coverage. By using GenExpert. And then we would also like to ensure continuous operation of molecular testing equipment, and also ensure continuous availability of TB screening supplies, especially the cartridges and sputums. So the introduction and the planning of NPOCs is going to be like it had been proposed. We're going to have country planning and budgeting. We are going to have regulatory and import requirements. We also are going to have management, product procurement and supply management. Also policies and guidelines on implementation and trainings. Then we are going to have monitoring, evaluation, and learning. In terms of national planning or early access rollout strategy, the preferred rollout scenario was that because we do not have a lot of sites, we generalized the technology to the togetherness of all the laboratories to about 99 sites, especially from March 1st to 30 August 2026. And so that the first phase, half of the laboratories can be approximately 50 laboratories can be equipped, and the second phase, the rest of the laboratories can also be equipped, so to attain the 99. So what are the regulatory and import requirements in Benin? You have to do national registration, so that you have to get to the regulatory exemptions. So to do that, you have to have advanced import authorization to release authorization. So you're going to have an invoice, a delivery note, or a bill of landing, or airway bill. After that part, we have a tax waiver or exemption, or custom clearance, custom declaration. We're going to have interchange for import by land, and certificate of analysis for each lot if required, delivery at the port or entry. So we estimated at about 2 months all these requirements to be able to have the technologies at the site level. In terms of management of purchasing, we have purchasing planning, quantification of purchases for the year 2026. We would like that the commands in 2026 be under the order of the Global Fund financing, and the procurement is going to follow the current system. up to on-site distribution. Of course, there is already a good system that is already existent at the country level to ensure efficient distribution of product. And when you talk about command, the orders of 2027-28, we would like really to do them with the national budget. So when it comes to policies and guidelines on the implementation and the training, at the end of these workshop, and of course, if the technology is accepted and if you have it, we are going to have, of course, training feedback or from all the actors, especially the lab technicians. We're going to develop an algorithm and we are going to produce a circular note to implement very fast. So it's going to be very short to allow us to go very fast. In terms of monitoring, it's expected to put in place a routine monitoring system to integrate point of care diagnosis indicators into the national, subnational dashboards. When I talk of the dashboard, the national dashboards, I'm talking about the intermediary level and the peripheral level. It can be regional or district if you want. Then we can go into the conduct monthly data reviews and quarterly supervisory visits to assess performance and of course maybe to do a course correction. And then finally, we can use feedback between screening sites in Benin, the laboratories, and of course, programs that are here, programs of fighting against tuberculosis to improve the data quality and case management. In terms of indicators, we have 5. So that we can be brief and intelligent, we kept 5. The number of people diagnosed near the point of care for tuberculosis, number of positive results after NPOC diagnosis, number of positive cases who initiated treatment, number of tuberculosis cases with non-HIV status, number of positive tests near the point of care, the NPOCs, with a drug susceptibility test. So these indicators were kept because we already have a system that is in place that can allow for the sharing of this kind of data. So in terms of support, we need if it's possible to do an updating of the NTP guide, because it was elaborated in 2022 and there is a whole procedure that is in place to update it, so that we say that's why we should have an update of the NTP. So we say if it's really complicated, we can move on into another circular. So we can also do a recruitment of a technical assistant to support the coordination team. And of course, we need to have capacity building for laboratory technicians. We can also have preventive and curative maintenance of the equipment, and we need to have regular implementation of supervision or quality assurance. So we also put in place a budget, and this budget is just for the implementation. It is really not taking into account the cost of the equipment and other things. So this discussion is going to be done with the Global Fund. What we have is an estimation of the about $94,000 for the implementation phase. So when we talk about the enablers and the obstacles, so let's talk first of all of the enablers. In terms of coordination, we have a leadership and commitment that's going to facilitate the implementation of these technologies. There's also the support from partners, for example, the World Health Organization, the Global Fund, and the unions that are going to accompany us in the implementation of this technology. We also have an enabler, which is the availability of a supranational laboratory, which is an important tool to allow us to go very fast. It's very important because the laboratory allows us to manage the network in an efficient manner of the laboratory of the country. In terms of the bottlenecks, especially with the mechanisms of the implementing of activities by the Global Fund. Today we have many stakeholders and it's a bit complicated. We have a lot of back and forth, which makes that it can be an obstacle really. And then after there's the mobilization of actors at the operational level with unfulfilled promises in terms of the configuration of the element that makes that the actors are about demobilized. We hope that we are going to get rid of these obstacles in a way that is efficient. To conclude, I'm not sure if I should present this really, but we also preview, we put in place, or we foresaw, as you can see, we have a number of batches. We have 65 for batch 2 and 34 for batch 3 that are equipped with Gen Expert, and the 65 for the other sites which don't have the Gen Expert. We have to know that at the laboratory level, we really don't have an electricity problem. That's why we opted for the first machine. Thank you very much.
And thank you. So please, if there are any questions for the Benin team. Yes, we have a hand straight up, or reflections from their own team.
Yeah, it's not a question, just to clarify one point. Our goal at the moment is not to reach the GNS website, is to push the machine, is to put the machine on the other sites, not the GNS website. And then when this microscopy sites, we will replace microscopy by the new technology. And if it is positive, that's what we are doing at the moment. If there is a TB patient, then the sample is sent to the GNS website. Just a clarification I would like to make. Thank you.
Okay. Question here.
Merci beaucoup, le Benoît. Je n'ai pas compris le...
Thank you very much, Benin. I did not understand the position of the 94 laboratories.
We have 99 laboratories in the country. Among these laboratories, we have 34 with GeneXpert already. The new technology will be placed in those who are not GeneXpert sites, which means 65. So that's why I clarified the point that it will not be in 99, it will be in 65. So all the laboratories, they are doing microscopy for follow-up. But so far, we have for diagnosis microscopy in 65 laboratories. And then when the technology will come, the technology will replace microscopy for diagnosis in these 65 laboratories. When the test is positive, then the sample is sent to GeneXpert site for rifampicin resistance. That's the situation. Thank you.
Merci. Great. Any questions? Oh, we've got lots. One over there.
Thank you very much, and very well elaborated presentation. I notice you say Benin is SRL, but then you say the SRL is an enabling factor for Benin to absorb plus life. But I also noticed that you needed a certificate of analysis in order to approve the new test. My question is, I thought Benin was overseeing about over 23 countries. Do you really believe that all those countries needed to repeat an analysis for them to adopt this technique? and what would be your role to accelerate this uptake? Thank you.
The analysis we are talking about, it is a regular from the national regulatories. Before you accept a new test or a new reagent or a new drugs in the country, you have to get this analysis. It's not that we will use the test to do verification method or something like that. It's some regulatory issues at the Ministry of Health. The need from the supplier that it is endorsed by the WHO, and then so they give the certificate. It's not something we will do in our lab, but still, as a supranational reference lab, we will get the equipment next week, so that we will practice the equipment, because we will be in a position to help the other countries. If we are not able, if we don't use the equipment ourselves, it will be harder to help the other. And this is a critical point I want to mention here. Here, it looks like TB is a matter of English speaking and high burden. Yes, it's to look like that. But don't forget that there are so many countries, though they have small amount of countries, but still some have a huge amount. There are many. If you put them together, they can go beyond this high burden country. But we need this country, because we need this country. That's why, as they are using my voice to tell the partners, Global Fund, that yes, I hope that this is the next step.
Yes.
And then definitely we will have the step for these countries. These countries, more than the high burden, the NTPR and the National Reference Lab and the National TB Laboratory Network are weak. There will be more supranational reference lab, this country, for support. If not, you will have the recommendation, the guideline, but you will not have implementations. So I will encourage you to go to the next step. Thank you.
Thank you. Yes, and I think absolutely this is phase one of what we see as a very accelerated program across 2026 and into GC8, where there's a new opportunity, a new funding request for countries to really scale up. And I think the call to all the current countries in the room is that your expertise, your experience, your pathways, your workarounds, your sort of early adopter approach, we want to give you the platform to share with your colleagues in the region who are not able to be part of this early adopter. But I think your experiences and your context will be really pivotal to Dr. Bisu's point that we want to make sure that very quickly in GC8 or 2027, that your experiences are joined by many others. So yes, thank you. Any other questions? Great. Well, I think you have more than earned your T-bait, but before we go for tea, I'd like to have a round of applause for all the 4 countries who presented after lunch. Yet again, I'm going to cut 10 minutes off your break, and we may have to run over, but so if we can have 20 minutes, so come back at 4:20. We have 2 more countries. We are saving the best till last, so not putting any pressure on Uganda and Cameroon. And then we will open up just for reflections on the day from the teams and the countries, the opportunity to ask any questions, and our technical partners may feed in to some of what they've heard today. So please go refuel. We've got a bit more to go, and we'll see you back here at 3:20. Et merci beaucoup. And gracias.
Especially, so I think it is very important if this tool, given its cost, it's likely to penetrate private sector, which brings opportunities and challenges, which we must. Actually, as we say, these early implementers, in Uganda, I already had phone calls. The private sector is not going to wait for us. They want to purchase. They want to purchase this equipment, and we must be prepared to really control the quality, connect to them, and it's actually could be a good opportunity. Of course, funding is being talked about, the high maintenance cost for the equipment we have, and I think also problems with placement. You can't tell how many times I've pleaded with the SafeFeed, and I'm not embarrassed, with SafeFeed, with the mobile, with the BD Max, BD, to place equipment. And usually those conversations are not very easy, very, very difficult. But maybe this one, maybe it might be easy. And maybe even placement may not be a big issue, given the cost. So that could really solve the issue of equipment. And even equipment maintenance, maybe instead of crying, I would buy another equipment as the other one is being maintained. Those type of things might make life very well. This waste disposal, I know there are sometimes hidden things before we know. The other time we thought a cartridge was easy to dispose, not until we had things to do with cyanide and other things. But I hope, hopefully there will not be hidden things here, but we are prepared. Specimen collection challenges, I think those will remain, but these are key issues here. Okay, I think the rest is very similar. In terms of developing plans, therefore national planning will follow. And as I have been advised by my technical working group and procurement and supply management, they don't see any much difference between this and any other tool they are going to bring in terms of regulations, and it is going to be really not a complicated thing. And I think people have already gone through that. In-country milestones for introduction and planning, as I have told you, Uganda, like I think many countries, we are going through familiar steps. Usually when there is a new test, we form an implementation team, and Uganda has already formed a TB Diagnostic Network Technical Working Committee. And so the presentation here, the committee has gone through it, and they are waiting, when I go back, what you tell me, they are waiting to hear, and they modify what they are going to do. So they will think about guidelines, training, demand generation, integration in sample referral network. And you know the sample referral network, we are going to leverage it on too much. They bring the sample, but they can take back the batteries, which are charged in case there is no charging at the site, and maybe other commodities as we do. And there is always a sample referral network to coordinate this. So they will facilitate absorption. Proficiency panel testing, by the time I come here, I think the lab is nearly finishing a PT for Plus Life, which is a good thing. And then, so that will be very nice. And the private sector engagement, this is going to be heavy PPP, and the technical working committee knows that very well, that this time we can't ignore a private sector. So we are going to develop linkages, particularly the sample referral system was not capturing very much the private sector. We had our sample referral in government. This time we must go there. And quality control, we are not minding very much about private sector. This time we have to go there in the private sector and equipment maintenance. And the other thing here is connectivity. I think we had an integrated connectivity system, the lab expert, which was bringing in results for HIV, TB, X-rays. And as I speak, I think they have really made a success inroads in connecting this tool to an app which captures data which could be transmitted. And this is going to be key. We need to find the data, particularly in the private sector, to really link it up and make sure those samples are transferred for rifampicin resistance. that's going to be a huge thing. Okay. Okay, I think I have talked about this slide already. The systems for NPOC linking to National Diagnostic Information System, which we are very familiar here, DHIS2, others. So this, I think, is not going to be a difficult thing. Definitely, we are going to track KPIs and see how things work. Usually, sometimes, many times, things work very well on paper, but we'll really make sure that we see how it works. Okay, I'm about to end. I know people are tired. So this is the early access deployment. I think Uganda, the technical working committee is really very ambitious. You know, one of things, TB people are very cautious, and they want to take things slowly, like the organism itself. So this is what they think. They want 2,000 tools for bundle one. Bundle one, whether you have two mini docks and the thermal, the light set equipment. So that's what the bundle one, and then they want 200 for bundle two. These are more advanced facilities which have electricity. They may not need batteries here. So these are the number of machines they are really thinking about. So the KPIs, many of them have been mentioned, and they are looking forward to a monitoring approach. Particularly, their worry is to capture that data, and they have a routine monitoring systems aligned with existing TB data. And the lab expert and the DHIS2 is going to be very key. And as I've told you, they have already prepared that. Integrate indicators into national and subnational dashboards, conduct monthly data reviews and quarterly supervision. I know there is a separate discussion which Uganda will do along this line. So I will not do that. Do we need any support? Yes. I think it is really very important if we get a consultant to help us develop and initiate this implementation plan, because sometimes it is very important to put people in the room and make sure them get organized. So I think we will need some support in that direction. Budgeting. I think the budgeting, this is the budget my technical working committee has put for me in terms of stakeholders meetings, trainings. And I think these trainings, they are really worried about both public and private. This time, we have to reach out to the private sector and even their consultation and even their support supervision, and as well as demand creation. And they really think also it will take time to integrate this into the lab expert and establish a quality assurance scheme, but also enhance a specimen referral system, particularly reaching out the private sector. When we implement this, we expect, because that is the plan, we expect to find more missing cases. We expect to find more drug resistance cases. By implication, the National TB Reference Laboratory will get more work, if you really think through that. So you might begin to think about more supplies there, more capacity there. Otherwise, it will get overwhelmed. So I think that is also estimated there. So the enablers, I think already the committed leadership is already there. The technical working committee is there. We have a very well-structured network, the hub and spoke model for transport system. We have a very well-established testing capacity and the readiness to really to do that, and a stronger supply chain mechanism. So I think this will make it very easy. And I think I must tell you, we have one of the enabler people are really frustrated with the microscope. So I think if there is something which comes really to replace it, especially if it's linked to some connectivity solution, would be a good idea. So bottleneck, of course, budget, of course, short shelf life, people have already talked about that. hopefully it will give us time to distribute it. I know this, you are trying to ask me the question of SRL. Don't ask. You already answered it. Thank you very much. Yes.
Thank you very much. Do we have any questions for Uganda? Right, excellent. We'll go Lucy, back to the room, then yourself and.
Thank you so much, Prof. And really exciting to hear that SRL Uganda is already working on EQA panels. So 2 questions for you. What proportion of your TB cases are diagnosed through the private sector? And secondly, I didn't quite get how you selected the facilities for NPOC implementation. Are you thinking of doing any network optimization to select those? If you could just say how you selected those. Over.
Okay, so I think the first question is asking, well, maybe what proportion of our TB is diagnosed by private sector? Yeah, it's approximately 20% from the records. But however, I think there is some black box. If you asked me how many private labs you have in the country, if I'm to be sincere, the correct answer is not easy. Some are there today, tomorrow they are not there, things like that. And the people agree with me. And then our ability to correct data from there is also a problem. So I think this is what we need to improve as we do have a technique which goes, and I think people are agreeing with it. Yeah. The other question was, how did we select this? I think I think I gave you a good preamble that we do have about 2,050 microscopy centers, and only 400 have gene experts. So I think the dream was just replace that thing. If this thing works, what are you waiting? I think I've answered that question. Yes.
I think question here.
Okay, thank you, Professor, for your nice presentation. My question is regarding the monitoring and evaluation related. As we see from all presenters and you as well, we have one indicator which says number of positive NPOC results with DST result. So how can you track easily this indicator to avoid the duplication of reports at gene expert site and NPOC?
Okay, those are very important questions. I think for now we don't intend to have any POC at gene expert side. That's what. Yeah. But however, I'm not. That's why I think we really need to invest in data, and the dream is really digitalization, and that's why I have already told you that already the IT people in Uganda are working with the developers into an app which is already existing actually, which they can work into for wherever that an NPOC is located, because it doesn't have very strong connectivity like Gene Expert or whatever, but there is some connectivity, and that we need to capitalize on that. Otherwise, in this area, I don't see any other way around. Yes.
Thank you.
Mohammed, Shaila, and John. So.
Thanks, Professor, and thanks to yourself and the first colleagues from BENAB. You've really supported countries in these in the different phases of molecular scale up and all that. my question regards, I see you are ahead of the curve, thinking about maintenance, and probably for you also, Grania. He's talking about depending on what price the platform gets to land on, thinking of, are we going to do maintenance? Are we going to use and discard? So is that going to be part of your, as you roll out in Uganda, see what makes sense where?
Sure, I think you have answered the question. Sometimes when before when I had to bring a person to go into fix margin expert, and then I have to wait for them on the airport and drive them and give them a hotel and then drive them some 600 kilometers. That's already more than the cost of a minute. So I think we have to rethink. Maybe if it requires maintenance, we could have some extra as we collect these ones maybe into one place, and then we have to have a more cost-effective way of maintenance. But this seems to reduce our headache, that maybe having multiple, like that's why you see bundle one has two. Maybe we could increase those ones so that it reduces the stress and the disruption of service, interruption of services, if this can be affordable. So we can rearrange the maintenance compared to before. Yes.
Yes, I'll quickly add on that. I mean, so I think the current estimated cost of a mini doc platform is $150. We are not planning for a service and maintenance type approach. It is going to be much more of a warranty approach, so that if the machine breaks down in the warranty period, it will be replaced. So yes, that is the thinking.
We are thinking alike, huh? Okay.
So I think we have.
Well, thank you very much, Professor. It's a very good overview of how you plan to do this introduction and wider ecosystem of TB diagnosis in Uganda. My question is focused on the challenges that you have raised, and these are the two things. One is the short shelf life, and what are you thinking in terms of how to manage that with the first shipments that will come to the country? And then the second one is on the budget. And here I would like to emphasize something that with this sort of accelerated early access to this product, there is a need to think a little bit in the not the business as usual sort of mindset. And budgets in a normal sort of circumstance where we have a longer implementation timeline, we could do multiple trainings, we could do the list of activities that was mentioned on the presentation. But thinking out loud with you, do you think there is a way where you could sort of have a relook at some of these activities and sort of prioritize and think about what would be the critical or most essential activities that you need to actually do for the first introduction to happen? And I'm mentioning this because, to be very fair, we are coming to a point where there is a constraint on the grants, and already we are budgeting something for the product cost, but then the other costs we will have to also prioritize and be very prudent in terms of what we select, the type of activities, the number of trainings, et cetera, et cetera. So I just wanted to sort of think out loud with you about these two challenges, because I'm sure that they also cut across in the other countries. Thank you. The shelf life.
Okay. Yeah, I think that's a very important question, and I think people mentioned before, we don't have that shelf life, because if the shelf life is 13 months, which is a year, which that's where we started with the cartridge. But I think I guess in this room we really have to be very careful on what we are bringing in. And we have already started as a technical working committee. We can actually regulate the government arm on how we bring in this equipment. How are we going to regulate the private? That is a question we are going to ask. Are we going to tell them wait until when we do the government arm and then you come in, or we are going to let them go as they so wish? Because I think we may have no option but to speed up things. Otherwise, we will get ourselves into trouble. So I think you are saying because yes, how are you going to accelerate things? That's why the technical working committee in my country is really moving very fast, so that once this is out, particularly that the private sector arm, we need to be prepared, because they can easily buy very many equipment. This is pocket change for them. But I think that is the discussion we really need to have. By the time I leave here, I think we really need to dig deep into it. That's why I was saying I wasn't hearing my colleagues going in that direction so much. But it is something we really need to think through. So in terms of first steps, I think, as I've told you, is really to bring all the stakeholders in the room, both the government, private sector, the implementing partners. Once we, and that has always been a winning strategy. And then together with what is possible, what's not possible, then we can go ahead. And as I've told you, I think if you had marked my word, as soon as I land back in the country, they are waiting for me to tell, and then they will make those decisions. Thank you. I don't know whether I have answered your question. Very difficult question, though. Thank you.
So thank you, Professor, for your elaborated presentation. So I have one quick question, actually, to get the sense of your country's laboratory numbers. So you have mentioned that you have 2,000 plus microscopy center as well as 400 gene expert sites. So my question is, are these 400 gene expert sites are overlapped with this microscopy center, or these are totally separate centers?
Okay, they do overlap. But do you have a follow-up question? They do overlap. Okay, it's not like 2,050 plus 4. They do overlap. So because you are taking me into another area. Because you see, we still believe that even if you have a gene expert, you still have to do microscopy for follow-up, which I've not understood its value. I know when you are looking at, but which I have not understood its value contribution, especially if you have a sensitive molecular diagnostic test at the beginning. But let me leave it at that.
Thank you. I see Jean's hand's gone down, so can we please give a round of applause for Dr. Moses? Great. I would now like to welcome our final country for today, the team from Cameroon. If they would like to come up and present your plans, that would be, and if you're presenting in French, others may need to re-plug in their headphones. Merci beaucoup.
Okay. Good afternoon, everyone. I'm going to present on behalf of Team Cameroon. My presentation will be in French. I don't want to leave our borders from Benin alone. So, yes. The team of Cameroon is made of, I will call on the coordinator of the TB program, Dr. Noah Apunoni. We also have one of our TB reference lab, Dr. Ateba Ghislaine from Hospital Jameau, and Dr. Melissa Sander from the TB regional lab in Bamenda. Okay, myself, I'm Elizabeth Pedro Mufula. I'm from the Ministry of Public Health. So, donc, le
Cameroon is a country that is located in Central Africa, like we can see in the map as shown. We are neighbors of Chad to the north, to our north. We also have the Central African Republic to the east. And to the west, we share the border with Nigeria, and to the south, we share our border with Equatorial Guinea, Gabon, and Congo. The country has an area of about 475,442 kilometers squared and a population of about 30 million inhabitants. We're in a country that is divided into regions. We have 10 regions in total, but we have 12 epidemiological regions. The official languages, we have French and English. We have 205 health districts, and we have 982 health areas. People living with the tuberculosis, we have 27,153. That's data from 2024. And in terms of centers for diagnostics and treatment, we have 380 centers in that nature. So the current status of diagnostics normally is done in 304 health facilities with 994 satellite trainings. We have 12 field coordinators, and we have mentored 254 people. In terms of sites of diagnostics and treatment coverage, we have one of that kind center for 77,495 inhabitants. We have 356 sites of microscopies, and in terms of TB lab, we have 56 of them. In terms of GeneXpect, we have 85, and TrueNut, we have 25 of them. We have 2 reference laboratories that do cultures over tuberculosis and resistance, and the reference laboratory of references for TB. The World Health Organization estimate for 2024 for tuberculosis cases was at about 43,000 cases, and resistant tuberculosis was about was at 650 cases. In terms of these data of 2024, we have an underreporting of TB cases with a gap of 37%, and for the resistant TB, we noted a gap of 71%. For that comes from GC7, which has about 205 health districts. In terms of diagnostics and treatment centers, we have 387, which are covered by those that I've just stated. We have 137 health districts that have a high TB burden. Among the 308 centers for diagnostics and treatment. So we have the necessity to prioritize the budget allocation in terms of the review of some partners. So current challenges that we have sample transport, especially meeting this installation of an integrated transport network in the country. We also have the maintenance of the diagnostic fleet. Many of us have already talked about it in terms of GenExpert. We have a lot of difficulties in terms of maintenance. We have the supply of inputs for the last mile trainings. In terms of the national supply that wants that all inputs go through the regional funds, and they don't have the ability to go until the last mile. So another challenge is the reduction in external financing. In terms of introduction of the implementation of the NOPCs in terms of planning and budgeting, we plan or we foresee to conduct a budget analysis incorporating all the relevant case costs to accelerate product introduction and adoption of these new diagnostic platform. We should equally develop introduction plans, including phased rollout to microscopy and which means centers of diagnostics and treatment of care centers of primary health. In terms of regulatory and the import requirements, it's important to work in authorization by national regulatory to talk about the introductory of this product in the market with the support of the local suppliers in terms of supporting importing, not only in terms of the equipment, but all the tools that go with that equipment, and also to work together in terms of custom clearance requirement on this new diagnostics platform. In terms of management of purchasing and supply of health products, it would be important to go through quantify the needs for tests and fulfill the orders, which means align supply and demand and track the order from the order point until the delivery. Another important thing is that we should equally include products in supply chain systems of the country. In terms of policies and guidelines, we would like to update the guidelines and national tuberculosis diagnostic algorithm to include tests close to the place of care, which are elaborate in at the level of the treatment centers, and to also integrate into the sample transport and drug susceptibility test transfer systems. In terms of monitoring, evaluation, and learning, we are going to link near point of care diagnostic data to national diagnostic information systems, especially the LIS, the SIGL, or the real-time dashboards. And it's also important to train health workers in procedures and data entry to promote adoption and use. It's also important to have the monitoring of key performance indicators. In terms of planning, the strategy that we have, currently we have noted a need of the molecular tool. We need 100 and we have 198 centers for diagnostics and treatment which do not have the molecular tool. So we want as a first phase to have 100 equipments of diagnosis for the sites that do not have, which are a bit behind and that do not have the molecular tool. And as the second tool, we're going to have 50 sites, as you can see. In terms of regulations, it's very clear that we are not been able to give deadlines because the registration of products normally goes first of all through an authorization of going before it gets into the market, and there is a national commission that sits every 3 months. So in terms of depending on when you put your demand, if you put it when the committee had just sat, that's very nice. But if you put it after, depending on when you put in your dossier, the authority takes a while to do the clearance. And in terms of the equipment that are qualified prior, we have this advantage where they don't have to go through a number of verifications at the national level. So we use the documentation that has been provided by the World Health Organization in terms of qualifying these products. In terms of regulatory exemptions, we have special import exception, which is given. We can give a deadline of about a month so that we have a regulatory exception. And we also have a customs exemption for certain number of products. And for this kind of exemption, we cannot really give a deadline because it depends really on the Ministry of Finance. Allow me to say that it does not depend on the Ministry of Health. And then after that, we have custom clearance, delivery at port, and entry or on site. In terms of health product procurement and supply management, as we said, we go through the quantification and forecasting, and we have the planning and the implementation of these purchases and the procurement and planning implementation, and then there is the entry of the grants in terms of the co-payment, which is taken into consideration as well. In terms of the policies and guidelines, it means that we need to update, we need to have an update of the national screening guidelines and of the tuberculosis, and to include a policy circular which can be circulated by the Ministry of Health. We can design tools of information for education and communication, and we should go into active case finding and community participation. We also have in plan training of trainers. Could it be at the national level, regional level, or at the district level? And we have the coordination of activities at the regional level and at the national level. In terms of monitoring and evaluation, we focus to have a routine monitoring system which is aligned with the existing data platforms on tuberculosis, especially the DHIS2, and equally integrate into the national and subnational dashboards, the NPOCs. We should also conduct monthly reviews and quarterly supervisory visits to assess performance and correct errors. We should also make use of the feedback given between screening sites and laboratories and tuberculosis to improve data quality and case management. In terms of indicators, I'm really not going to read line by line because we have really had the same indicators by other countries. So just like the others, we really need the support or the accompanying, especially in terms of the strengthening of the integrated sample transport system. We're at a pilot phase of an implementation of an integrated transport system of samples, be it samples of HIV or TB or other biological samples. So the system is something that is being implemented. It's not yet 100% operational. So it was going to be important to strengthen those systems. Equally, it's important to strengthen the coordination of activities, be it at the national or at the regional level. We have also foreseen an integration of indicators into the DHIS2 and training of the stakeholders at all levels, and the development of SOPs and communication tools, mapping of sites and optimization of diagnostic networks and equipment maintenance, and improving active case finding. So we have a budgeting. We have a budgeting of at a certain level of a number of activities that you have proposed. For the first time, for example, for the revision of guidelines and diagnostic algorithm, an estimation of about $50,000. For the strengthening of the integrated transport system, based on what is really going on currently, we already have we based ourselves on the transport system that exists to get at a cost of 382,000 for 690 sites, and also the strengthening of the coordination of activities at the national level and at the regional level. And we also have the training of the stakeholders, since we already have that difference in between the actors. And we're also going to have the training of the service providers on the sites and development of communication tools and the improvement or active research of cases. In terms of enablers, we have the committed leadership for the Ministry of Health to facilitate the introduction of deployment of the NPOCs in the CDTs. You also have, if you're here, is because there is the engagement of the government to facilitate that tool. The transport system, our transport system that is robust, is equally important for the best implementation of this project. Equally, the technical capacity development and preparation of the centers for diagnostics and treatment. And in terms of obstacles, we can note that we have cumbersome administrative procedures. We have in terms of approval or custom clearances, in terms of financing as well, to support these initiatives. And we also have running out of stocks and the short shelf life, as we have already talked about. Most of the participants have already talked about it. So I thank you. Thank you very much.
Keep to Cameroon. You have the benefit of all the questions coming.
Thank you.
Great, thank you. A round of applause for the Cameroon team. Okay, so now I think we're just going to have a bit of time for any general questions that have come out from the day, any reflections, and also an opportunity for some of our technical partners to add into conversations or their reflections on what they've heard today and how that marries with some of the experience that they have had with the tools. So it is now open floor time. So please, there is, and I see there's a post-it note on the board. So while you're thinking of your question, I'm going to run over and see what that question is. And then I will come back and we will see if there's any other questions. And I know it's getting near the end of the day, but we'll see if we can get anything more. So I'm off to get the post-it note while you think of your questions. So, whoops, I've tangled myself up entirely. So any questions? Otherwise, I will go to the post-it note. Great. Okay, so this is a general question of what is the role of diagnostic network optimization in selecting sites for the near point of care implementation? And I wonder maybe if this is either our technical partners, our SNRLs, or any diagnostic partners have any thoughts on this question? Okay, maybe we are getting very much to the end of the day. So we'll maybe let that question rest overnight. We will have the opportunity to do more Q&A tomorrow. I'm going to put one of my colleagues on the spot, but I think sort of thinking about the conversations today, there was, and I think I'm very pleased to see a lot of sort of thinking about community engagement, stakeholder engagement, demand generation work. And I think this is something that we too at Global Fund are very also think is very important, not just for this early adopter, but very much as we're seeing this as phase one of a much longer term process. So we have been also giving some thought to that. So I will put my colleague Melanie Katongo on the spot to just give a brief summary of some of the work that we've been thinking with our CRG colleagues on this. Yeah, and we've got a question while Melanie's off to find a microphone. So
shall we take the question first, or?
It's a quick one.
Yeah.
So and probably to partners and people who've implemented, I see many of the countries, they are going towards putting the equipment off grid, even 150 kilometers off grid. What are the capabilities of the batteries? How off grid can you get?
great question. Implementing partners, and I may TB Reach is the immediate colleagues that I'm thinking of. Have you got any reflections on that, Stephen?
Oh, thank you, Masini, for the question. We, in our own setting, that is our own team, we got these batteries that were supposed to be supporting the mean X-ray, the portable digital X-ray, to power the Plus Life equipment. So with 2 batteries, we last the whole day, you know, so it doesn't die out. But I can't tell you the capacity of those batteries. I have to check because we got them from the NTP. So maybe when the NTP person comes, I'm going to ask about the capacity of the batteries. But with 2 batteries, you're comfortable to go the whole day. But of course, you know, each test is like a round of 35 minutes, you know, plus the other, you know, it's written 30 minutes in the document, but it takes you 35 minutes. And you go very far, you cut out the time already. So you can see how many cycles of tests you can have in a day. So that is why we go with the big one that has 8 docks. The big Plus Life equipment with the 8 docks. So that is the one we use for the community. Yeah.
Great.
Follow-on question. How long does it take to charge those batteries? So how much time does it take to recharge those batteries?
Just a few hours, 2 to 3 hours, and that is done when you're back, you know. You don't have light in the remote area. So 2 to 3 hours, you have a fully charged batteries. With 2 batteries, it can power 3 set of docks like that. 1 battery can connect it to all of them, and then you can spend the whole day working. It doesn't draw down a lot of energy, actually. It's a thermolyzer because of the vibration, you know, that it does. Yeah.
Great. Your time will come, Melanie. Yep.
Yeah, thank you. Just still on the battery issue, I want us to be sure the battery provided for Jana, it's from the depth or from the PDX. However, if Plus Life is in the room or we get this information, what is the capacity of the battery they are providing alongside the instrument? Just like we have batteries provided for TB Lab, provided for TrueNat, we don't have to start sourcing for batteries separately. So what's the capacity of the battery they are providing for this instrument, and how long will that last? Thank you.
So I think Melanie, that is one of the questions we did ask them. So Melanie's going to read the answer because I don't know it off heart.
Yeah, and we shared the responses that we got from the manufacturer as well. So I'll just read it word for word. So Plus Life said our mini dock workflow is not battery operated. It works on an external DC power. For outage prone or off-grid sites, we offer 2 portable UPS options that keep the mini dock and thermolyze running at 576. Well, there's technical terms in there, but it provides about approximately 20 hours of operation, which is around 40 testing runs under the standard MTB workflow. And then they have one which provides up to 40 hours of work, which is approximately 70 to 80 rounds. Both recharge from mains or solar, and the actual runtime will depend on the workload and the local conditions. But I think we shared these questions as well with you all as part of the package, so you can go back and look at the technical wording in it.
And I think that's also in the demand template, which goes into much more detail than the sort of general overviews that we've been presenting today. Some of the questions around the placement of the machine, where the facility is, and the throughput is to help us ensure that if you are requesting an off-grid option, that we provide the right size of battery for the proposed workload of that site. So, and also the right number of mini docks for that site as well. So that is why there is the tab on the demand template around where the site is and the expected annual throughput, so that we can ensure that you get the right size battery and the right number of platforms and lattice machines for your need. Okay. Mo, do you want to build on that?
Yeah, just building on this, since we were talking about the package, that was the info package that was sent before the meeting. The demand template is a key document. I think we received it now from Indonesia, Benin, and Uganda, right? So I know that some of you are still working on it. Some of you might need a bit more time. Ideally, if you could send it before noon, tomorrow noon, so that we can use it in the discussion in the afternoon in the in the breakout groups. Obviously, one thing I have to emphasize here, that this is an estimate. This is not a firmed up demand for now. And we are asking you for the full unconstrained demand for 2026 for the Plus Life product. So don't constrain yourself with the indicative volume that we have shared with you, because this is what we think now that we can for sure, based on the budget that we have and based on the price that we have made our calculation against, that we can support you with. But some countries might want less, some countries can get more, and we can get a better price maybe in the coming few weeks where we are negotiating with the suppliers still. So send your full demand for 2026 and try to be as close as possible to what you think your implementation timelines are aligned with that demand. For 2027 and 2028, these can wait. Or if you have them but you're not sure, this is just an estimate so that you can add them. There's no firming of demand at this stage. I just wanted to flag this because this is a really key document and very important for us at this design phase of the initiative. Thank you.
Thank you. Melanie, now you have the microphone if you want to just give a...
Yeah, just to highlight a little bit about the community engagement piece. I think as part of the Next Gen Market Shaping SI, we have been conducting regional engagements. We had one in Abidjan last week for the Africa region, and I see a lot of familiar faces. We've been collaborating closely with ASLM, who's also helping host this meeting. We're inviting CSOs, TB programs, lab directors to these conversations, so we're all in the same room speaking the same language. We had a similar discussion in Vietnam in April of this year for the Asia region, and we plan to continue doing that for the next 2 years, just to make sure that all the work that we're doing, we're not leaving communities behind in all of this planning. In addition, at the Global Fund, we have the Community Rights and Gender Department that we're working very closely with. They interact closely with the TB regional hubs and learning networks. And so a lot of this information is being disseminated to the communities. I also want to give a special thanks to Professor Disu, who's really championing community engagement in the West and Central Africa region. We've had a number of webinars dedicated to this region to just make sure that we're all speaking the same language and understanding the impact that this tool can have. So if you have any additional suggestions, ideas, we're really welcome to that. But I think we see community engagement as a really key piece to moving this work forward, and are committed to continue doing that for the next 2 years. Thank you.
Great. Yep. 2 questions over there.
Sorry, back to the batteries.
Yep,
So
back to the batteries. We can go back to the batteries.
I just confirmed that it's a 500-watt battery, and then if it's completely discharged, then you have to charge it for up to 4 hours. But if not, 3 hours, 2 to 3 hours will do. So that is the battery that we're using right now. It's 500 watts.
Okay.
And just to confirm that, yes, that Plus Life shared the two options are 576 watts and 1,152 watts. So those are the two options they have available.
A few questions and perhaps comments from me. The first one is around local distributors. I think consistently each of the countries was indicating that they either have the local distributors in place or they're working towards it. And I'm just curious what informed this approach of having the local distributors, especially when you think of the long-term sustainability. What we have seen sometimes with some of the health products, when you have a local distributor, they kind of control the market, and there is also a markup for that local distributor. So maybe there is good reasons for having that approach, but just to understand why we are opting to go in that direction. Two is around the co-pay amount. I think the presentations that were shared during the webinar indicated that there will be a co-pay amount of $2, which includes in-country distribution. So just to clarify, how far is this in-country distribution going? Is it from port to central warehouse, or are we saying from port all the way to the site, which I think is not the case, but good to clarify that. Then around the shelf life, we have shelf life of 13 months, but I think even as we sit down to crunch the numbers of the quantities that are needed, what can be taken up, we need to be very clear around what will be the shelf life upon arrival at the countries and then upon arrival at the sites, because we have several processes that are running. It's collected from the manufacturer, it is shipped, it is cleared, it is taken to the central warehouse, then finally taken to the site. And all this takes time. So we need to really have a good idea around the shelf life upon arrival. Then in terms of the bundles, again, a practical point when it comes to really crunching the numbers is we have the smallest bundle being 1,000 tests. Again, what does this mean for low volume sites? A few of the countries have indicated that they will be trying to target the lower volume sites, middle volume sites, but can they really uptake this 1,000 tests? Is there room to come up with a bundle that is smaller for those low volume sites? I think that will be our quickest win in addressing things around risk of expiry. You don't want to push out 1,000 tests to a low volume site, they can't consume it, then we are dealing with the expiry. Then around the budgets, I saw budgets for sample transportation. Uganda, you have huge numbers, my neighboring country. And for me, a new product or a new equipment that we're trying to introduce, the idea is really trying to push for riding on the existing system. Again, looking at the near point of care, when you introduce it in the system, I thought it would be reducing your need to transport samples because you have brought the testing closer to the populations that need it. So just to challenge the countries as we, again, refine our numbers is the budgets. Can we look at riding on existing systems as much as possible? We are in a situation where funds have reduced, and in terms of prudence, that would really be the direction to go. Thank you.
Thank you. And there's a great comments. I'll just quickly answer the Global Fund specific questions, and then I'll give an opportunity for colleagues in the room to reflect on your local distributor question if they want to feedback on why they're thinking about that, as well as the being pragmatic and looking at what already exists rather than necessarily having to create new. My question, so With regards to shelf life upon arrival, and I think this is why the demand estimation is so important, of being very clear of when the in-country regulatory processes, import processes, what the exact, like, when will you be ready for first product and test to arrive in country. We may also be looking at, although we are talking about bundles, that isn't necessarily how it will arrive to you in program. So we may have all the machines and lysis platforms arriving ahead of the test to allow those to get to sites to be embedded, and then planning very closely with the Global Fund team and your in-country, and maybe Mo's better at answering this than me, of the in-country supply chain, so that you don't necessarily get all your 1,000 tests on day one, and then your countdown is, your shelf life is counting down from then. But how can we manage with you, the Global Fund team, and the manufacturer on maximizing that short shelf life we have, and having clarity on all your various in-country processes that we can then match up with the before it gets into country. And the question around in-country distribution, I think that is also very important that we get from you of where are you planning to put these sites, and then we can try and push as best we can the manufacturer to see what level of in-country distribution, but knowing how remote or concentration in this year one will help us in that negotiation period. So that again is why it's in the demand estimation. I see Mo wants to add in, and I'll just say, with regards, and again, it's back to the demand estimation, we are aware, and I'm very interested to see the level of ambition here today for scaling out to those low volume sites. So again, that's why it's in the demand estimation of the sites that you're planning. We've asked you what their annual testing is likely to be, so that if there does need to be a different bundle for less than 500, we can sort that out for you. These bundles are indicative, they are not fixed. We will make them, we want to work with you and the supplier to give you the right bundle for the site that you prove that you would like that those first tests to be in. So that is why it's really very key in this demand estimation that you identify and let us know where those sites are, so we can get the best package. Mo, over to you to fill in my gaps.
Thanks, Grania, and I think you have covered pretty much most of the answer. Janet, thanks, very thoughtful questions and comments. I think colleagues here counted five questions within that question, so I'll do my best. Remaining shelf life, that's how we are calculating it. So it would be 13 months at the time of release from the manufacturer. You have to count in the time for shipping document sharing, giving green light, and then shipping to country. It will be an air shipment for the first shipment. So we're counting for this about 60 days. That's a very conservative estimate. It's likely going to be 4 weeks or so, but we are counting more than this. So you can count that you'll have it at the port of entry, or at least at the central warehouse, and I'm going to come to the point in country distribution, at 11 months. Okay, so 11 months in country, and then you start counting your implementation timelines from there, going to the site, and then from there, you have to do your thinking about how much time you have left, how much remaining shelf life, so that you could use it within your introduction plan. So that's one. I think the second thing on the in-country distribution, so the package that is being introduced, we kind of think it's a really holistic, all-inclusive package for good reasons. The reasons are, we don't want to overburden the grant at this time with other costs. And with that, not only distribution to the site, but actually installation and training is included in that price. So it's actually distribution to the site plus installation and training. So that's part of the package, and this has been confirmed by our direct sourcing colleagues. I think what was the, Amina, you were taking the question, sorry. The bundling. Yeah, so as Grania mentioned, this bundling is just, I mean, we thought 1,000 would be the minimum, but obviously we thought that there will be sites which will do, I don't know, 500 or less a year. So the bundling is just to help the countries to think about the levels they want to place the platforms and how many of those platforms at what levels. And obviously this is linked to the number of tests. But as Grania mentioned, it's not going to be shipped in bundles to the countries. This is just a way to think about it and also to help us in our calculation, right? So there's obviously the way that you could think in the country that I will need, okay, 200 of my sites will be in bundle one, which is the lowest number of tests, which is 1,000 tests. But actually maybe from the 200, I would have 20 or 30, which will do less. So I think in the total number of tests that you will start with, you just think about, okay, maybe I will reduce a bit on this bundle one or increase a bit so that I can adjust it. Eventually, you will get the tests at the central level, and they will be distributed according to your distribution list, to the site distribution list that you will give to the local agent of Plus Life in the country, right? So you'd say, okay, these are 200 sites. I'm going to put, 60 tests here, 100 tests here, 1,000 tests there, depending. Okay, so there's no constriction or there's no sort of limitation in the sense of how you would distribute, how much you could distribute to the site. There's no limitation on this. So I hope that's clear. You had, the point on the local agent or? Okay, I'll leave that to you, but on the local agent, I think the countries will answer. I think I do tend to agree with you that it comes with a lot of markups that are unnecessary. In many situations, it's related to the local regulations, but in other situations, particularly for diagnostics, it's really about the service and maintenance, or being able to find someone in the country who could provide direct support and troubleshooting to the site level at a short period of time. So that's sort of the kind of what you pay for that markup. That's the service that you get for paying for that markup. So I hope that answers some of your question, but Amina.
I just remember there was one other one that I think we skipped out, which was on the copay. You had asked what the copay was, and the copay we are currently working with is $2 per test from the countryside, and then the Access Fund would pay the difference. And tomorrow I will give a presentation first thing in the morning that will explain to you what this entire package is, what is the bundle, or the full package of one test, what it comes with, and all the things that Mo has spoken to, that Grania has spoken to, all the different services that will come along with your one test to make it easier for implementation. The last question I think that we hadn't answered, that Janet asked, was around sample transportation. And I think Obert might be better to answer that question than me, but I will start. And if Obert decides to take over, then that's fine. But I think what you had asked was, with this new test, do we still need to do sample transportation? I think the idea is that yes, because we need to understand if there is if it needs to have a reflex test for DRTB, but at the same time, we know that there will be a much reduced number of tests that are actually being sent through the sample transportation, because you're only sending the positives. And so that way there is the cost even of the reflex testing is reduced as well, because you're not doing all the tests that you need to do, only for the positives that would need to then be sent. But Obert, do you want to add anything?
I can add and say, well, we hope that the cost will go down. But I think the point was that if you are going to put them at microscopy sites, we were already referring. So I suppose it's just strengthening what you have. But if you decentralize further to the primary healthcare centers, hopefully there was some way they were moving specimens to a microscopy site. So you try to leverage that. But of course, we know that there's already been weaknesses with sample referral system in many countries. So that's something that still needs to be sorted out. Thanks.
So sample referral does not just move samples up, but also moves things down. Particularly, I think you have had that battery challenge. Unless we think we are going to have solar power, solar panels, but moving those batteries back and forth is going to be an innovation to keep those batteries going. It's one of the options, and I think it might prove very important. Of course, on the private sector, it's possible that a positive patient will say, okay, here there is no treatment, you go to a government facilities. But there are some private sector which treat, which are also treatment centers. In other words, if those increase, we'll see again an expansion of sample referral system. I need at least to cater for this. Even moving PT, proficiency panels, they move in the opposite direction. And you bank on it to do many things. So yes, with even the instruments, if you are going, she says, take back this one which is not functioning, bring a new one. That system, and remember it is integrated. It's not only TB, the other diseases are using it. So if it is there, we better strengthen it, and it does all this. Thank you.
We've got a question here.
I have one question. We know that the NPOC the approach for decentralized the TB test in not only for microscopy center, we might go down low level in the primary healthcare center. But my wondering that it is okay to perform the near point of care test in the primary healthcare center without the biosafety. During with the testing procedure, we can see that with the near point of care, still some kind of step to swap the sputum about 10 times for 15 seconds and then wiping inside the wall of the container. So I think it still have risks of infectious, the adult generation. So I'm quite concerning about that one when think about when we can the near point of care can be placed in the primary healthcare center without the biosafety cabinet or not.
Okay, I wonder, I'm going to maybe put some of my lab colleagues on the spot for that one, either Robert or Patricia.
Wayne is the one who worked on the biosafety manual.
You know you've asked a good question when they all fight over the microphone.
Sure. So we're pointing at each other over here, but I think everyone, any of us could have answered. So for us, when we did the class determination and we look at the procedure and we see the risk of managing the sputum sample with the swab inside of the sample, it doesn't look like it's greater than sputum management and initial processing than would be done at a smear microscopy level. And oftentimes smear microscopy sample processing is done outside of a BSC in a well-ventilated space. So I do think that ventilation will still be important. An appropriate swabbing technique will be important, but we don't expect it to be an elevated risk. And this is similar to what we've heard from some of the evidence generators as well.
Okay. And then I'll
Shahid.
Do you want to follow up on that and then we'll come to you?
Yes, so I would like to follow up with the Patricia comment. So yes, so I know that to minimize the adult generation, we need kind of proper the handling, right? And but you know that with the primary healthcare center, the staff have kind of not the minimal the skill. So we might not require so much for them to have a proper handling to be able to minimize the adult generation. So that's I'm still concerned about that the risk is still there, not zero. Yeah. So I'm actually from my point of view, I'm not feel comfortable or confident to ask the staff in the primary healthcare center to perform near point of care without the biosafety. Yeah.
Thank you. So I have a follow-on question. Today was my first time I actually had a hands feel of the equipment and the process and everything else, right? So we got the biosafety risk in terms of aerosolization with the swab, right? So there's potential there, but limited. It all depends on the viscosity and everything else that surrounds it. And generally in our environment, we get really what you call it, less viscous samples. So they're not really mucopurulent. It's more like a solution type. So the risk still remains, right? That's the first component. The second component is really the dropper issue. Because if you were to drop the extracted material in that space, your risk of contaminated DNA in that area is really high. And I mean, there has to be a lot of, what you call it, there has to be a lot of training around that space, because when you move in the dropper, tilting it upside down, there's a risk of a drop spilling in your environment. So I'm really worried about that system. And then after that, you're just going to get positives, right? I know, you have to wash your walls in a lab with bleach when you have a DNA contamination. So I'm not sure what's going to happen in a facility. The second issue is, has there been any evidence? I know Safi did it in the early days to actually show the log reduction in bacillary viability with the buffer solution. What is the evidence that's been generated for the plus life in terms of its solution and log reduction or totally inactivating the material that's in the dropper? Thank you.
Okay, I have four things here. And I may not be able to fully answer, but we can get back to you on some of these. Because I don't want to speak before I've looked at the materials. First, for both of you, I completely agree. I mean, we are diagnostic and lab people. There's never zero risk associated with what we're doing with infectious diseases. So I very much take the point, and I do think that appropriate training, having PPE that does not come with the kits on hand, and having appropriate cleaning solutions is going to be incredibly important. We've also seen from point of care and near point of care testing in other diseases that having very clear, easy to read, appropriate language job aids around these critical steps and treating them as critical steps during training can be incredibly helpful. So for bloodborne pathogens, for example, there are often these job aids around how to appropriately collect and manage the specimen to reduce risk. And so I think this is something that maybe hasn't been as emphasized in smear microscopy laboratories and gene expert sites because they're laboratory settings, and these are laboratory technicians that have gotten a technician certificate in many settings to be able to manage these samples. That brings me to tester certification programs. If you have tester certification programs for point of care tests where these people are trained in sample management and infectious disease handling, it can be really useful. In some cases, these have been set up for HIV tests, and particularly at peripheral. So those that have been doing HIV testing peripherally may have these types of approaches, and they can be really useful also for biosafety training and for doing competency assessment for refreshers. So those are some of the reasons to consider when you're implementing this new type of strategy at a new level of the health system. Then when it comes to inactivation of material, the manufacturer, my understanding is that they have done inactivation verification and stability studies. I do not have that data set with me, but my understanding is that it has been done. And certainly claim of inactivation is something that we'll follow up with our pre-qualification colleagues on as part of the pre-qualification process. For risk of contamination, again, having appropriate cleaning practices is going to be incredibly important in general. I will say that the risk might be slightly lower than with, for example, the MalBio TrueNat. So many of the countries here today presented on the use of MalBio and the TrueNat systems that you currently have, where you have a pipetting step of the pure DNA. That is an extraction step where you have a lot of DNA in a small bit of volume. In this sample, we're talking about a lysate. So there is DNA there, but there's also a lot of other stuff, right? It hasn't been purified. It hasn't been concentrated in any way. But again, appropriate handling of the sample and appropriate cleaning of the area routinely before testing, after testing, in the middle of a day, spill management where there is drops. These should all be part of the procedure that will be, again, critical steps. So it's a simple procedure, but like any procedure, it will have to have these components built into the SOP.
So I think one of the points that came through from everyone was the issue of training. And I know that with the package, there is some training component. But maybe the question is, how comprehensive is that training component? Thinking about the biosafety issues that are being mentioned here. We used to think microscopy was simple, but we ended up doing 5 days training just for microscopy with lab staff. So maybe something to think about. And maybe as we start, how do we advise countries who are in this early adopter phase about their training? Should they start with what the vendor will provide and then follow up that later with a more comprehensive training? Or do we start with just a more comprehensive training just to allay a lot of the fears, especially for biosafety? Thanks.
And I think maybe this is an opportunity for some of our implementing partners from Nigeria or Cameroon to share your experiences of what training approaches and timelines have you had, and have you incorporated some of these biosafety concerns into that? Sorry to put you on the spot. Can we have a microphone over here? There's Melissa, or Stephen?
Yes.
Okay, sorry, Melissa, I didn't know.
Yeah. I think for us, we saw the importance of training firsthand. I mean, proper training, because when we started with the laboratory tests for presumptives of all ages, we got a result that got our heads, spinning. What we saw was screening 1,000, close to 1,500 sputum sample. That's a sputum swab. We got like 125, 127 positive on plus life. The same samples taken to expert came back with 92 positive, but all the samples that expert came out positive were positive on plus life, which means we had like 30-something samples that were positive on plus life, but negative on expert. Then the team from Stop TB Partnership came, and then we started looking at all the processes, how the tests were run. And then they discovered that, there are some instructions. You hold the tube, you turn it around for 10 seconds, you do it 10 times. So some team members were doing 20 times instead of 10. Some were repeating some of the procedures on ending cycles. So probably this was the reason why we got some additional positives. Then they now shared those videos for trainings again. Then we went through the whole training process again. And from the time we went for the repeat training up till now that they're in the field, every single plus life is coming out to be positive. Also, if it's positive on plus life, it's coming out to be positive on expert. So we stopped seeing those kind of weird results. So, and I was discussing again with Dr. Emperor from the NTP, and clearly he was hammering on the issue of training. And this is one area also that we're looking at the involvement of the reference laboratory, not just quality assurance, but also coming down to the implementers and then conducting supervision on the job training and also making sure that they repeat the formal trainings where possible. So training is extremely important, and we saw the value of that.
Melissa, do you want to add? And then I'll come to yourself. And John, I do see your hand up, so I'll come to you.
Yeah, thank you. In Cameroon, it was, we did a online training with Plus Life that took about 2 hours for our personnel in the reference lab. And after that, they were able to do the test. Those are people that are normally doing expert testing and microscopy. So they're aware of molecular testing. And then they trained additional people at the 5 labs where we did the Plus Life for the study that we did. And we didn't have any issues, but we were working with people who are already working in the TB lab. So I think for us, the online
a 2-hour online training from the company was sufficient for the people that we trained who were people working in the TB lab already.
Yeah, so the questions I asked are not to in any way destabilize anything, but for us as a country to understand the processes. So in the case where your staff were retrained, these staff that were retrained, were they constant? Were they the same people that are running the study, or is it not changing? So that's my question, because in our environment, we have a lot of rotation of staff, a lot of changing spaces. So we just want to understand that if it was constant and you retrain them, of course, you'd get corrective action. But if you have a constantly changing environment, you're definitely going to see ups and downs in that space. Thanks.
Yes, the staff were the same team, the same people. Now, a big difference between our own staff and Melissa's staff is that her own staff were laboratorians. They're already doing TB work. But in our own case, we only have 1 laboratorians and then program guys. So these are the guys that are running the test till date. So you can see the difference in the type of staff that we have.
Jean, and then I'll come to Patricia, because you've had your hand up a long time online.
Yes, I would like to give thank you so much indeed. I would like to give a point of view on the training. I think there are 2 kinds of trainings. There is a training which is provided by the manufacturer, which is basically technical and for technical troubleshooting, etc. So from our experience and from diagnostic technologies and also so far, what we learned was that in addition to that training from the manufacturer, it's always great to have a training package to address programmatic issues sites will be experiencing. I think in the rooms, I have colleagues who have been working together, like Wayne Van Gomert. I think even other colleagues, we've been really working on the training package to adapt GeneXpert, for instance. That's a good one of the examples. And also to address components which were not addressed by the manufacturing companies, like biosafety, like the turnover of staff you might have at sites who are using the same technology for different diseases. So definitely having a training to address programmatic issues is needed. And I think the GLI, Global Laboratory Initiative Secretariat, has been producing many training packages that really were very helpful in speeding up the process of the uptake and the rollout. So I think we should have a working group within the Stop TB partnership and within WHO GLI Secretariat to work on training package and come out with let's say a component that can be complementary towards the manufacturing facilities are providing. That's what I think about the quality of the
Do you still have, yeah, if we can have a microphone over here.
Thank you very much. Thanks, Jean, for that important point around the availability of a training package, and certainly the experience from Stop TB and the importance of the inputs from the Global Laboratory Initiative as well. So a first point, just to follow up on some of the training. So the development of training materials, including job aids for sites, is underway. Through adaptation of some of the existing materials, including reference to the Stop TB partnership documents. And we look forward to partnering with the Global Laboratory Initiative Core Group to get external reviews of that package. And so when I mentioned earlier this implementation guide that we're planning to package and to produce and develop, it will not be perfectly informed by all the real world settings and some of the primary healthcare use cases, because that hasn't happened yet in order for us to have that information. But again, we have worked with all of the evidence generators, including Melissa's group and some of the Stop TB Partnership and colleagues and others, to be able to feed back some of the users who have really used it, some of their inputs on what we call break the test. So what happened where it was confusing or it didn't give you the result that you expected? What do you wish you had more information on? We've done a survey across those groups, and we are building out some of the key considerations for the class and for the Plus Life technology into this user manual that will cover all of the 10 areas of implementation of a new diagnostic test that are included in our operational handbook. And it will come with these practical tools. So training slides, job aids are included. There's a capacity calculator. There's also a Q&A indicator list. And so I think, we're happy to share more around that as it gets developed. The other thing I would say is it was nice to see in many of the presentations a mix of training formats when we talk about training and what we mean with training between on-site, TOT, virtual, and then within site, I think is something that will need to be considered, particularly given the frequent staff attrition, staff movement that happens particularly at peripheral levels. So what kind of creativity and models can the programs consider around ensuring redundancy at sites beyond the one individual that may be trained in the procedure or two individuals? How is redundancy and how are refresher trainings done within a site for these types of procedures that may need to be considered so that if someone leaves, that site is not all of a sudden down? The other thing that I think will be important around the indicators, so we saw the list of indicators here, which is very nice, shared between countries, which are largely performance indicators. But the quality indicators will also be incredibly important to monitor, particularly for sites that haven't done these types of tests before, for those considering decentralized or peripheral placement. Things like failure rate, because many of you will not be using these instruments in a way in which they're providing an error code necessarily. Sites won't know what's happened when the test fails. They'll know if they're invalid maybe, but they won't know otherwise the reason for that. They'll need to capture that. They will also need to understand positivity rate. For those of you who have implemented and went through the early days of lateral flow LAM implementation, when early LF LAM decentralized sites started getting positive results one after the other, it really worried the testing sites. And then they immediately, many of them across various countries, started trying to use water as a negative control or coming up with controls in the absence of QC in order to determine whether or not the results were accurate and those could be used for patient care. So there are two factors here. One is to please consider the inclusion of quality indicators that you already use with your program that you would have for other tests. And the second is how you're going to get that information back to the program from decentralized or peripheral sites. And the last one is to link those things and consider how in the troubleshooting section of your trainings that happen for any test, what happens when these quality indicators or quality challenges arise, and how would they communicate them back so that the sites aren't left without a clear path for action?
Great, thank you. And we will have a session tomorrow morning on some of the M&E, so we can potentially go into more depth. Now, I'm going to pause the questions because I think it's been a very long day. But I want to give Dr. Jean Iragena from the WHO Afro Technical Officer. You've heard his voice a lot over the screen, but he's going to help with just give some quick reflections from today, from what he's heard, and then I'll sum up and close the day after that. So, Dr. Jean.
Thank you very much. Do you hear me?
Yes.
Excellent. Thank you very much for organizing this very important meeting. And from the reflection of today, what I would like to retain is that even the title itself of the meeting is really exciting. It's catalyzing the access. I think this is a good title. catalyzing the access means that we need to accelerate the uptake, rollouts, and make sure that we can have the impact on case findings to fill in the gap between diagnosis and treatment. I think this is really great. And from the meeting, what I really retain is that there's a potential near point of care for TB diagnostics will really make a difference in the way TB is diagnosed. And the partners like a Global Fund, WHO, ACLM, Scientific Partnership, and the others are very much enthusiastic to support the early adopters. And I think this is really great. However, there are some key insights and spotlights that have been mentioned by the countries we need to take into account. Even if everyone is very enthusiastic and ready to implement, we have also a way to go through different phases of preparedness, technology transfer, and also monitoring and evaluating the impact of the technology. I think this is very important to work on. And common priorities have been identified across all the countries that really presented. And also common challenges have been highlighted. What it is really good also is to, when you have a common priorities, common challenges, you can also have common solutions. I think this is an advantage of being together, highlighting all those priorities and challenges to make sure that all together we can work and accelerate the uptake and rollout. Of course, it has been mentioned by many countries, the integration of this NPOC into the existing TB algorithm, which is not an easier thing to do because we know that many countries also are challenged by the diagnostic algorithm. Some of them are still using microscopy, experts, TrueNut, and some others are using a mixed model, but we have always the challenges around this. Training capacity, I think this has been highlighted as a priority for many countries, and also the data integration into the routine health and lab information systems. All those together required a higher level commitment at the Ministry of Health to make sure that every component is well addressed. There were emerging themes such as the need for clear operational guidance and technical assistance. And I think even tomorrow you will continue to work on that. And this has been highlighted by many countries, meaning that it's needed. The sustainability in terms of financing has been also highlighted by many countries as it looks like the long-term funding strategy need to be also in place before countries can start to implement. Monitoring and evaluation, a consensus on defining essential indicators for near point of care has been highlighted, and I think this is a really great component that need to be discussed. As my colleague Patricia highlighted, also we have indicators for quality. We have other indicators also for monitoring and evaluation of the impact of the technology. And also on the top of that, we have indicators countries are reporting. Because if you, as you know, the world knows how the burden of a disease is when someone reads the global TB reports. So the indicators you are reporting through the global TB reports need also to be well defined because we need to see the impact of this near point of care diagnostics on patient care at the end. The last not the least was the next steps that have been discussed, such as the country implementation plans. also the timeline and the roles of partners. And I think these need to be worked out much more for everyone to know what the role will be in terms of the implementation. And also the identification of the enabling factors to accelerate the introduction. This has been also highlighted as one of the steps that need to be worked out much more. And also the integration of these M&E and the plans to make sure that the impact of the technology is well highlighted. So overall, the reflection of this day one from what I really succeed to capture is that this day one demonstrated a strong alignment among stakeholders and the countries for the urgency and opportunities the NPOC TB diagnostic can offer. And I think this is a key reflection. And the collaborative spirit and also the commitment which has been shared during this first day of the meeting shows that there is a solid foundation for operationalizing the planning and the scale up of this technology. So I do believe that all those countries really together, in addition to the partners, are strong enough to implement. What it is, I think, more important is to use this catalytic philosophy and the model, not to duplicate the efforts or to fragment the efforts, but to leverage on the successes. The SRL network, the Supranational Reference Lab network, has been really going through a decade, especially in Africa. And I think Professor Joloba and Disu can share what they succeed to do supporting countries in addition to the South African SRL. And I think altogether, there is a way to catalyze the scale up and rollout of those new technology and speed up the process in a way the impact can be measured as soon as possible. Let me submit my reflection of the first day to you. Thank you.
Thank you very much, Dr. Jean. I will be very brief because I think you have captured a lot of what I was going to say. I mean, I think, first of all, the level of preparatory work and detail and reflections in all the country presentations today was incredible. And I really want to thank everyone because it's a busy time of year for all the work that you've put in. And I think it's really helped set the scene today about how this new tool can really be implemented in many different ways. There is not a one-size-fits-all approach. You've all reflected on your challenges, and the sort of implementation ideas that have come out from that are unique to your context. And that's great. I think that's what we wanted, to get a chance for us all here today to really see how others are thinking about the problems and learn and see if there's anything that maybe we haven't reflected on as much or that we can learn. And I think Professor Joloba's comment on kind of the engagement of the private sector, then there was a lot sort of how this is going to be worked in some of the key and vulnerable groups, in IDPs, refugees, prisoners. So I think sort of it's been really enlightening today to hear all of your thinking and all the opportunities and potential that this new point of care test could have, and the sort of approaches that you are looking at of workarounds for this early phase while you are doing some of the longer processes that could enable you to move from a phase one approach into embedding it into your programs, looking at how it's incorporated in the GC8 funding request. But I think we've heard even from Indonesia today of how, and sort of other countries, of how it can also be incorporated into future domestic resources. So I think this vision is great. So for tomorrow, There's an opportunity, sort of really, we're just going to spend the morning, if it is worth it, we're starting a little bit earlier at 8:30, where Amina will go through in more detail, as she was saying, about this $2 copay, what you get for it, how you can access it, some of the terms that will be important for you to be aware of. We'll have a brief overview on some of the TA and how the models, what we're thinking, and timelines for that. And then a session, and I think it's been brought up many times, on kind of thinking about M&E processes and how to kind of think about that, both for the early adopter phase and then more embedding it into your program. And then the rest of the day will really be an opportunity for you to sit down again with your compatriots and have access to all the knowledge in the room, and further refine and develop your implementation plan, get some clarity on the timelines, the numbers, and so that we from Global Fund can really, and with partners, really kind of help you be successful in 2026. So I feel that I have talked for long enough and you have listened to me for long enough. I also, as other people have been listening, I'd like to thank our translators, because it's been a long day for them as well. And to our IT staff who've been working hard to make sure that you can all hear me. And then the final round of applause is for yourself. So well done, everybody. And I look forward to seeing you tomorrow at 8:30. Thank you very much. Well, I hope you all have a lovely evening, and we will see you bright and early at 8:30 tomorrow. Thank you.